on ethical, safe and legally secure patient care. We once again welcome you all to this Augustus occasion. Thank you.
Chapter 024 and also served as the Secretary of the
Concerned, I thank organizers for organizing. Unfortunately, law, there is a dictum in the law which is called ignorance is not an excuse. That means if you are driving, red signal means stop, green signal means go. But when we break the rules, we cannot tell that I didn't know this to the police. Same thing once we start practice, law presumes that we know all the rules governing our medical practice. We cannot tell I didn't know all these things because that won't stand in court. So one of the most important aspects is the consent, where the doctors are repeatedly doing mistakes because they don't know how to take consent, what all to write in consent. And remember, consent is the one which is going to protect the doctors, because if you do a procedure with consent, something goes wrong also, it won't be held as negligence. So in this class we are going to learn few basic concepts of consent, and I am going to show you the model consent forms also, so that you can improvise on your practice. So the concept of informed consent arises from the fundamental and ethical principle of autonomy and right of self-determination. That means if you touch someone who is on the road or who is sitting, it becomes a molestation without a permission. The same thing applies. If you do a procedure or touch a patient without the consent, it becomes damaging to the right of the autonomy of the patient. Okay. So core idea of autonomy is one's actions and decisions are their own. The concept of autonomy suggests that the competent adult has every right to choose the mode of treatment and reject it, even though it is medically wrong. Okay. Medically wrong, if the treatment option selected by the patient may be medically wrong, still the patient has right to choose it. For example, patient is on ventilator and patient attendant wants to take the child to temple and come back. We cannot withhold the patient, because even if it is medically wrong, the patient has every right to select what happens to with his body. So every patient, even if it appears in the wrong eyes of the physician, as a rule, medical treatment, even if it is a minor, should not proceed unless the doctor has obtained the patient consent. Except in emergency, law is very clear that the consent has to be informed one. So only in case of emergency, the law will give an exception that you have not taken consent, provided that you have proved in your notes that it was an emergency situation. For example, obstetric care, it was obstructed labor, patient was a semi-conscious patient, and in your semi-conscious stage, you don't have time to take consent. Here, offense, physical interference without consent in absence of legal authority constitute offense, and the laws of consent are not fully developed, like how you have law, family laws, contract laws, or land laws, or banking laws. There is no separate book called law of consent. All these consent were evolved from the law of contract and the Supreme Court judgments. So there is no separate book to read about the law of consent. Okay. So what are the types of consent? Is implied consent. Implied consent is patient comes to our OPD to get examined. Okay. So if a patient comes to OPD, I auscultate. I am not going to take consent whether to auscultate or not. That is called as implied consent. That means why the patient has come to our OPD, paid the bill, that itself tells that he was willing to get examined. Next is the express or verbal consent. Okay, if you are doing a intimate examination, we are going to ask the patient, can I do a PV examination? That becomes verbal consent. Next is the express written consent, which we are going to take when you do a major procedure such as anesthesia or surgical procedure. Law doesn't clearly determine which type of consent to be taken in which situation, but most of the time it is advised whenever you are doing a intervention or surgical procedure, written consent is mandatory, because it cannot be, the patient cannot refute it later. Okay. So types of consent are implied, expressed, or written consent. Okay. If you are doing a procedure, please take written consent. Rest all implied or verbal consent is enough. Implied consent also court accepts it. Patient cannot go and say later that I didn't give consent for examination. Then the judge will ask, then why did you go to the doctor from the beginning? Because you went to the doctor to get examined only. So don't think you have to take consent for everything. That is also not correct. So implied consent is very well holds good. For example, vaccination. Patient comes to our clinic for vaccination and pays fees for the vaccination. Then patient cannot tell later that I didn't give consent for vaccination because he came for vaccination only. So for all routine types of treatment, implied consent is enough. For detailed types of treatment, ideally oral consent may be enough, and for complex type of treatment, you need to take the express consent. Okay. So this law of consent has evolved from the law of contract. You might have undergone various type of contract when you buy a property or when you lease out a rent agreement or something like that. When you when they draft a contract, three things are very important. One is the person should be above 18 years because law presumes less than 18 years doesn't have enough intellectual capability to undergo a contract. So the mandatory thing is person should be less than above 18 years. Next is he should be of sound mind because any contract made with a person who is of unsound mind will not be held valid. And there should be common understanding between the person, two people who are undergoing contract. If we are renting out a property, it will be clearly written that there is a common understanding between the person who is renting out and person who is taking the rent. So there should be common understanding, and there should be two individuals because you cannot have unilateral contract. Contract itself is two individuals. Now let us understand how these things applies to the medical field. Okay. So I'll give an example. Age of 18 years. How it applies to medical field is any contract made with a child of less than 18 years will stand null and void. Okay, for example, I am a pediatrician, a 17-year-old patient comes to my clinic who is staying in hostel. I examine and do surgery or give any treatment without informing the parents or without informing the local guardian. Something goes wrong, if the parents file a case, 100% we will be held negligent. It is not parents, at least we should have someone who is a local guardian. Many people think like 16 to 18 years can give assent. There is something concept of assent where some people presume that 16 to 18 years people have enough intellectual capability to understand things, what will happen to them. But when it goes to court, especially when the patient suffers or gets injured, the patient parents will not leave the doctor there. They will always make sure that they will argue that they should have been informed because adolescent, what happens, they don't inform anything happening to them to the parents. And something goes wrong and patient ends up having shock or expiring, 100% doctor will be held negligent. So what I advise, less than 18 years, one day less than 18 years, patient comes to you alone, unless it is emergency, don't treat, send them, ask them to come back with any person who is above 18 years. If they don't want to inform parents, that is okay. Let them come back with a friend who is above 18 years, or let them come back with a local guardian who is above 18 years, teacher or hostel warden, and anyone is okay. Okay. Never treat less than 18 years without a local guardian. Sound mind. Okay. Now a patient who is having intellectual disability or something like that, there whatever may be their age, their consent won't be held valid. So you should always take consent from the guardian. Okay. So this is what happened in Samira Kohli versus Prabha Manchandana case. I will explain this case in future later. She was 44-year-old female where the consent was given by her mother. This consent was not held valid. So above 18 years, only that person only can give consent. No other party, even the parents also cannot give consent if the patient is above 18 years. Below 18 years, cannot give consent, only the local guardian has to give consent. The proxy consent will not be held valid if the patient is above 18 years. One case where appendicectomy operation was done for a 21-year-old person, consent given by the father friend was not held valid. Okay. The proxy consent is only valid for minors. So and also for unconscious patients. Okay. So in some situation, beside patient consent, it is desirable to take additional consent of the spouse. Example, government law recommends for IVF and surrogacy, you need consent of both. Those are all exceptions, you need to follow those guidelines. Sterilization procedure according to Family of Health and Government of India guidelines, consent of spouse is not required. Although if the female undergoes sterilization without the consent of the husband, that is a criteria to get a divorce, but that is not under our purview. You can, sterilization as such doesn't require consent of the spouse. Medical Council of India, cases and operation carries risk of sterility, consent of both husband and wife is needed. Whenever there is a conflict of two laws, any one law followed is enough. You don't have to worry. Okay. Then it is advisable to take consent of spouse when the treatment of procedure may be adversely affect the sexual function or result of an unborn child. Special guidelines given by the Government of India and IVF and surrogacy. All those things, only those guidelines has to be followed. Okay. So we have finished 18 years and sound mind. So implication is above 18 year, take consent from the patient. Below 18 year, take consent from the guardian. Special guidelines given by Government like IVF and surrogacy. Follow the guidelines given by the Government of India. So next thing is what you understand by common understanding. Common understanding is where you are going to explain the procedure to the patient and the patient has to understand. So you, doctor and the patient should have a common understanding, then only the consent becomes valid. So what are the common understanding means? What are three things the doctor has to explain is what is the procedure, what are the complications and what are the alternatives available. That's it. Okay. You don't have to explain 1 in 1000 complication, which is very rare. Many cases where malignant hyperthermia, all those things, or anaphylaxis have happened. The court have a doctor not negligent because these are very rare complications, need not to be explained. And alternative forms of available. This is very important where doctors are lacking. What happens is, I have a nurse, for example, someone has a nursing home where the only treatment of surgery is available for a particular oncological condition and treatment of radiotherapy is not available. Doctor tend to not to tell the option of radiotherapy because the patient may go to some other hospital where radiotherapy is available. For example, you have a option only for open hysterectomy. You don't have a facilities for laparoscopic hysterectomy. You tend not to tell them about laparoscopic hysterectomy. So that is called as negligence. The patient has to know what are the alternative forms of available because the patient will select what is best for them. So if you don't tell what are the alternative forms of available or what are the best treatment available, even if your hospital don't have it, you will be held as negligent. So three things you need to remember: what is the procedure the patient is undergoing, what are the complications can occur, and what are the alternative forms of available. What we are missing is we are not telling alternative forms, that we have to learn. So what is the nature of information to be provided is exact nature of the disease or ailment, need of treatment, nature of procedure, expectation of likely chances of success. This can be told in terms of percentage. For example, if a patient is undergoing hysterectomy, what are the percentage chance of a particular complication? It can be told as 1%, 2%. Okay. Then alternative forms of available, sufficient time must be given for the patient to understand. This is very important. What is happening is recently patients are also becoming very litigant. Many cases are filed where the consent was taken on the OT table. This happens with many patients. Patient will be shifted to OT and before giving anesthesia, surgeon or anesthetist remembers that nothing was taken, and on the OT table they take signature of the patient on the consent form. This is completely not valid because law recommends us to give a sufficient time for the patient to contemplate the disease or alternatives available. If you take consent when the patient is about to shift to trolley, this won't be held valid. This has happened in recent few judgments. This was not there before. Now patient advocates are picking up this point, the time of taking consent. If the time of taking consent was 10 o'clock and you operate at 10:15, of course they will argue that patient was under sedation or patient was not having enough time to contemplate. So what I tell is, for elective procedures, patient will be coming for PNSTC checkup. So at that time only you should take consent, so that no one can argue that enough time was not given to the patient. All elective procedures, hysterectomy, this hernia, where patient comes for PAC for 1 day, 2 days before, but you can take consent 2-3 days before also, when the patient comes for investigations or something like that, because patient will be coming for OT 1 day before. So there is no hard and fast rule that you have to take consent on day of surgery. Okay, so you can take consent when the patient comes to you 2-3 days before only, so that the validity of your consent will be more. Then it adds to the validity. They cannot go on arguing that enough time was not given. Okay, so sufficient time must be given. For relatively minor examination of therapeutic procedure, oral consent is employed, and nature and extent of information should be the extent which is expected as a normal, proper by a body of medical men skilled and experienced in that particular field. That means, if the patient goes to the court and tells that these complications were not explained to me, judge is not going to decide with his wisdom. What he will do? he will ask for an expert opinion from the same branch. For example, patient has undergone a surgery of appendectomy, some complications occur, and patient, for example, malignant hyperthermia. Okay, patient has anesthetist has induced and patient has developed malignant hyperthermia and died. Then patient will complain that this specific complication of malignant hyperthermia was not explained to me. The judge is not going to decide the doctor is negligent. He is going to call for an expert anesthetist team, and they will tell whether this need to be explained or not. Then they will come out with a recommendation telling
Now I request Dr. Soumya S. ma'am to kindly
Dr. Lata MG ma'am, we welcome you to the dais ma'am. Medical Director Shri Sanjeevani Hospital Hiriyu and Shri Sharada Nursing Home Basaveshwara.
Good morning everyone. It's my great pleasure to introduce our next speaker, Advocate Gopinath N. Shenoy. Advocate Gopinath N. Shenoy is a medical legal consultant in Supreme Court, High Court, Civil Consumer, have greatly influenced legal practice in India. Let's welcome Advocate Gopinath N. Shenoy, sir.
I feel that I should always address you all. Is there are certain judgments that have really brought about a drastic change in the way we practice today. Once upon a time, we used to, I have decided is, I will start from the roots. From the roots I will take it up, so that you will know exactly what's happening. So that is what I intend to do today. But I don't know how much time I am going to be giving. The moment you want me to stop, you just have to tell me when to stop, but give me a notice about 10 minutes in advance and I will stop. But this topic is very interesting. Okay? Now, right from the basics. Now, there can be only two kinds of laws. Only two kinds of laws. The first is something known as the civil law, and the second is something known as the criminal law. What is the basic difference between civil law and criminal law? In civil law, the end result is payment of compensation. That is, the person who has done something wrong pays money to the person who is aggrieved. That is civil law. But in criminal law, what is the major difference between? In criminal law, the wrongdoer is imprisoned. You go behind bars. So among the two, civil law and criminal law, what is the law that we people are more worried about? People always feel that it is the criminal law that we people are more worried about. And the reason that they give is that nobody wants to go behind bars. Well, that is one of the reasons. But as far as criminal law or criminal implication is concerned, there is something which is very important, which most of you all must not be knowing, and this is, if at all you are imprisoned by the criminal courts even for 1 day, remember, indicted by the criminal court even for 1 day, imprisoned. Say till the rising of the court, you are imprisoned in the court. That kind of order can be passed. If at all that happens, the medical council can all by itself deregister you. Remember, if at all you are implicated by a civil court, it really doesn't matter. But when it comes to criminal indictment, then the medical council can automatically deregister you to your name from the council. That is what we people are worried about as far as criminal law is concerned. That is one way of doing it. There is another way in which you can classify law. Another way. This is just the introduction, because otherwise you will not know what I am talking. The second way of classifying law is law can be said to be something known as a statutory law, and as against the statutory law, there is something known as a judge-made law. What do you mean by statutory law? Statutory law is a law that is enacted either by the parliament in the center or by the state assemblies. Example, see, law is best explained by an example. PCPNDT Act is a statutory law. Medical Termination of Pregnancy Act is a statutory law. Organ transplant HOTA is a statutory law. Remember, so most of the statutory laws, that is the laws that are made by the parliament or the assembly, end with the word act, ACT at the end. Like Medical Termination of Pregnancy Act, PCPNDT Act, that's what I told you. As against this, you have another kind of a law, which is known as the judgment law, These judge-made laws are the laws that the judges of the superior courts make, and these judge-made laws are also known as precedents, they are also known as authorities, and they are also known as case laws. Why is it called the case law? It is called the case law because this particular law is based on a certain case. That is why it is known as the case laws. But by and large, superior courts means the Supreme Court and the High Court. These are the courts that make the law. They are courts of records. And as far as the consumer courts are concerned, the state commission laws are also precedents. The national commission laws are also precedents. But laws made by the district court, decisions made by the district courts are not precedents. So it is High Court and above, state commission or above. Why am I saying this? I am saying this because today I am supposed to speak about medical negligence. Remember, the topic given to me is, all of us here, is medical negligence. Now, medical negligence is what kind of a law is the first basic question that I put across. As far as the first classification is concerned, medical negligence can be both a civil law as well as a criminal law. Remember, medical negligence can be taken to a consumer court, which is a civil authority, and you can go to the police station and initiate the criminal authority. As far as the second part is concerned, medical negligence, is it a statutory law or is it a judge-made law? And the answer is, it is not a statutory law. There is no such thing as the Law of Medical Negligence Act or the Medical Negligence Act. There is no such thing as the Medical Negligence Act, remember. So medical negligence is a pure judge-made law. By that I mean, what is medical negligence and what is not medical negligence is something which the judges tell you. So, in order to understand what is medical negligence and what is not medical negligence, what must you read? Judgments, correct? So, it is the judgments that decide what is medical negligence or what is not medical negligence. Are you understanding what I am saying so far? Okay. Now, I will explain another basic thing. See, we talk about medical law, correct? Now, what is medical law, I tell you? Medical law is a genus. It's a genus, big thing. And in this genus, there are two species. Remember, we all are medicos over here. So you understand what is the meaning of the word genus and what is the meaning of the word species. Now, medical law is a genus. And in this genus, within this genus, there are two species. The first species is statutory medical law, and the second part is the law of medical negligence. So, law of medical negligence is a part of medical law, and the other part of medical law is statutory medical law. Now, when I say medical negligence is a judge-made law, on what does medical negligence go? By what? And the answer to this question is, medical negligence is in law known as, it falls under the law of torts, T-O-R-T-S. Law of tort means there is no statute, the judgments are the ones that decide what the law is, and the end result is payment of compensation. Are you understanding this? Now, small part, then we will go to the topic. See, if you read the Constitution of India, in the Constitution of India there are articles, there are no sections. Constitution goes by articles. There is one article by the number 144. Article 144 of the Constitution of India. What does that say? Article 144 of the Constitution says, the rulings of the Supreme Court, have the force of law. That means if at all the Supreme Court decides a particular proposition in a particular way, that particular ruling has the force of law, and all judicial authorities which are inferior in hierarchy to the Supreme Court are duty bound to follow it. So coming back to the topic today, topic that I am supposed to speak on. I am supposed to speak on certain judgments, certain laws that have changed drastically how we practice today. See, mind you, I'll just give you a little bit of information. I started practice, I was an obstetrician and gynecologist. I started OBGYN practice in the year 1975. I think a lot of you all must not have been born at that time, 75. And I gave up my medical practice. I returned to my medical registration in the year 2016 after 41 years. I was a professor of obstetrics and gynaecology, and I delivered the child I delivered. That stage we reached. The other side of me is, I also am a law graduate. I finished my LLB, my LLM, and my PhD in law. And I started the practice of law from 1991. So practically 35 years I am practicing law. For a large period, I was doing both medicine as well as law. You can do it in the consumer court. You don't need a sanat. But in the year 2016, I gave up my medical practice because it was becoming difficult to manage both sides. Instead of lining up in the courts unnecessarily, I said I've got to give up one. And I gave up medical practice. At that time when I gave up medical practice, I didn't sleep for 10 days. But today, I think I was a fool not to give it up earlier. You know why? My anti-hypertensives have gone down 50%. My anti-diabetics have gone down 50%. I sleep very well and there is absolutely no problems. Trust me, medical practice has become a pain in the neck today. But well, you people cannot do anything else. Correct? You people are not like me. So you people cannot do anything else. So let's accept it and go ahead. So coming to the topic. Judgments that have changed the way we practice. Now, I'll give you a situation. You are a family physician, a family doctor. You look after the entire family. Now I'm coming to the topic after the introduction. I'm coming to the topic. You are a family physician. You look after the entire family. The husband, the main breadwinner, is not keeping well. So I get the husband investigated. And in the investigations, I find out that the husband is HIV positive. The moment I get the report that the husband is HIV positive, I counsel him. I tell him, see, you have got to be very careful. There are lots of problems. Husband is very intelligent. So what he does, now when he has sex with his wife, he suddenly starts using condoms. A person who never touched condoms. Remember, nobody likes to use condoms. But then this particular husband is responsible. Counsel. So now he starts using condoms. The wife is very intelligent. We always think wives are more obstinate. No, it's not so. They are more intelligent than what you are. Wife is very intelligent. She starts thinking, my husband never used condoms, but now he started using condoms. What is the problem? Husband is not speaking about anything. So the wife comes and sits in front of the family physician, the GP, and asks the GP, what is wrong with my husband? Tell me. Now, there are three options available to the GP, correct? Huh? First thing is, he says, you bring your husband, both of you come together. If your husband gives consent, I will tell you everything. First option. Second option is, he tells directly the wife what the problem is. So there are only two. And the third option is, he keeps quiet. Correct? Among the three options, which option is correct is the question. And I'm sure all of us believe that a personal confidential information that belongs to the husband cannot be given to anybody, including his wife, without the consent of the husband. That is what all of us believe in. That is the fact that was there all this time. But today, that belief is not correct. Why? Why? Once again, medical law means it is a case law. There was a case based on this, on which the entire thing came up. I'll tell you what that case was. It's a very famous case which goes by the name of Dr. Yeptomi versus the Apollo Hospital, Madras. Many times it is said that Dr. X versus Hospital Y. A lot of ways in which it is put. I tell you what happened in this case. This happened in Nagaland. These are all true facts. Once again, a Supreme Court judgment. This happened in Nagaland. There was a person by the name of Dr. Yeptomi, and he had a very close friend who had aneurysm of the aorta. So this aneurysm needed to be operated. So what they did, they packed up and they came to Apollo Hospital, Madras, and got himself operated. Blood was required, and Dr. Yeptomi said, for my friend, I'll give blood. And Dr. Yeptomi donated. They identified that Dr. Yeptomi was HIV positive. His blood was discarded. The surgery went off very well, and the patient became fine, and they came back home. And once they landed home, everything was fine. And one fine day, Dr. Yeptomi got engaged to a very beautiful girl by the name of Miss Akari. The name is there in the judgment, Miss Akari. And a small town, doctor is the Dula Raja, so Dhumna, the whole town was invited and everybody had just, first class. Then what happened? After the engagement, the would-be in-laws started hearing something. And that hearing was, their would-be son-in-law is HIV positive. They started hearing it. So what they did, the husband-wife, the would-be father-in-law, mother-in-law, took the first available flight, came to Apollo Hospital, Madras, and sat in front of the hospital administrator and asked a very simple question. See, my daughter is going to be married to this person, and we will be given to understand that you people have identified him to be HIV positive. Please help us. And the hospital administrator was very large-hearted. He called for the papers. And he opened the papers in front of the in-laws and said, yes, Dr. Yeptomi is HIV positive. His blood was discarded. The moment the in-laws heard about this, they took the next flight back home to Nagaland, and the first thing that they did was they broke the engagement. Correct? No, they rightly did it. They broke the engagement. And when the engagement was broken, the whole of the town came to know about it. Small towns, the word spreads like fire. Everybody came to know that Dr. Yeptomi was HIV positive. He couldn't walk on the streets because everybody started pointing fingers. See, he is HIV positive. Sarvaguna Sampanna, HIV positive. The moment his living became difficult, what Dr. Yeptomi did was, he packed up Bolia, Bister, everything, and he shifted from Nagaland and came to Madras. And from there, he filed a complaint in the National Commission. His contention was, National Commission is the consumer body in Delhi. His contention was very simple. This is confidential personal information. This information should never have been parted away to anybody without my consent. And what have these people done, Apollo Hospital people have done? They have given away my personal confidential information without my consent. As a result of which today I cannot get married to another girl. As a result of which today I just can't live. I had to leave Nagaland, I had to move out. So I want to pay paid compensation. What the National Commission said? National Commission said that it is too complicated a matter to be decided. As a result of which you go to the civil courts where evidence can be adduced in a proper manner. Well, Dr. Yeptomi was not satisfied with this particular judgment. Dr. Yeptomi started filing appeal in the Supreme Court. From National Commission, you go to the Supreme Court. And that is how Supreme Court decided this issue. The issue is, can such kind of a confidential information be parted away without the consent of the person concerned? Is that right? GP parting away with the information of the head of the family to the wife. Now, the Supreme Court said, Apollo Hospital Madras has done nothing wrong. Perfect. What it has done, parting away over the information, was the correct thing to do. Now remember, whenever a judgment is given, the judgment always has something known as reasoning to it. A judgment without proper reasoning is not worth the paper it is written on. So what is the reasoning given by the Supreme Court is something to be understood over here. The Supreme Court said, in this particular case, if the marriage had taken place and if the marriage had consummated, what would have happened? Miss Akali, one fine morning, would be HIV positive. It goes without saying, correct? And her lifespan automatically would have come down. She would have had a premature death, correct? That is what the Supreme Court said. And the Supreme Court then went to say that in this case, there are two rights involved. On one side is the right of Miss Akali to live a life to the fullest. And on the other side, there is Dr. Yeptomi's right of confidentiality. So, when there is a conflict between right to life and right to confidentiality, when these two rights clash, which is the right that is going to override which right? The right to life. You are exactly right. See how beautiful the judgment is. You know, the reasoning is something that should be understood. If you understand the reasoning, it becomes so interesting. These talks become so interesting. So the Supreme Court said, no.
Enriching session, sir, with a lot of insight to it. Thank you so much. Now I request Dr. Rashmi to open appreciation. Now I would request the speaker of the section, Dr. Vivek Dorai sir, come on stage.
Good morning everyone. It's my proud privilege to introduce Dr. Vivek Dorai sir. Sir is orthopedician by himself. Sir is now working as Deputy Director Medical Acts and Health and Government of Karnataka. Sir has digitalized KPME portal in 2020 to simplify Maharashtra and Andhra Pradesh. Sir has successfully conducted 9 decoy operations under the PCP and DK Act, and Sir has conducted many workshops on 916 to 947, and we welcome you, sir.
ಅವ್ರು ಹೇಳಿದ್ದೇನೂ ಇಲ್ಲ. ಎಷ್ಟು ಜನ ಇಲ್ಲಿ ರೇಡಿಯಾಲಜಿಸ್ಟ್ ಇದೆ? 1, 2, 3, 4, 5. ಗೈನಕಾಲಜಿಸ್ಟ್ ಎಷ್ಟು ಜನ ಗೈನಕಾಲಜಿ ಸ್ಕ್ಯಾನಿಂಗ್ ಮಾಡ್ತಾರೆ? 1, 2, 3, 4, 5. ಕೊಟ್ಟಿರೋದು 40 ನಿಮಿಷ. 2 ಟಾಪಿಕ್ ಇದೆ, ಪೋಕ್ಸೋ ಆ್ಯಂಡ್ ಡಿಸಿಪ್ಲಿನರಿ. ಸೊ ನಿಮಗೆ ಎಲ್ರಿಗೂ ಬೇಕಾಗಿರೋದು ಪೋಕ್ಸೋ ಫಸ್ಟ್ ಮಾಡೋಣ. ಯಾಕೆಂದರೆ ಎಲ್ಲರೂ 2 ದಿನ ಮಾಡೋಂಥದ್ದು ನನಗೆ 20 ನಿಮಿಷ ಕೊಟ್ಟಿದ್ದೀನಿ. ಸೊ ಎಲ್ರಿಗೂ ಯೂಸ್ ಆಗೋದು ಫಸ್ಟ್ ಪೋಕ್ಸೋ ಮಾಡೋಣ. ದೆನ್ ಇದು ಡಿಸಿಪ್ಲಿನರಿ. ನೆಕ್ಸ್ಟ್ ಒನ್ protection of children against sexual offences. ಇದು ನಮಗೆ ಒಂಥರ ಕಬ್ಬಿನ ಕಡೆ, ಯಾರಿಗೂ ಬೇಕಾಗಿಲ್ಲ. ಐದರ್ ಪ್ರೈವೇಟ್ ಆರ್ ಗೌರ್ಮೆಂಟ್. PHC ಬಂದರೆ CHC ಕಳಿಸ್ತೀವಿ, CHC ಬಂದರೆ ತಾಲೂಕು ಹಾಸ್ಪಿಟಲ್ ಕಳಿಸ್ತೀವಿ, ತಾಲೂಕು ಹಾಸ್ಪಿಟಲ್ ಬಂದರೆ ಡಿಸ್ಟ್ರಿಕ್ಟ್ ಹಾಸ್ಪಿಟಲ್ ಕಳಿಸ್ಕೊಡ್ತೀವಿ, ಡಿಸ್ಟ್ರಿಕ್ಟ್ ಹಾಸ್ಪಿಟಲ್ ಅವರು ಮೆಡಿಕಲ್ ಕಾಲೇಜ್ ಕಳಿಸ್ತೀವಿ. ಮೆಡಿಕಲ್ ಕಾಲೇಜವರು ನಾವು ನೋಡೋದಿಲ್ಲ, ನಿಮ್ಮ PHC ಎಲ್ಲ ಇದೆ ಹೋಗಿ ಅಂತ ಅವ್ರು ಕಳಿಸ್ತಾರೆ. ದಯವಿಟ್ಟು ಪ್ರೈವೇಟ್ನವರು ಇಲ್ಲೇ ಇದು ಗೌರ್ಮೆಂಟ್ ಕೇಸು, ನಾವು ಅಲ್ಲಿಗೆ ಕಳಿಸ್ಬಿಡಿ, ಫಸ್ಟ್ ಅಲ್ಲಿಗೆ ಕಳಿಸ್ಬಿಡಿ ಅಂತೀವಿ. ಹೌದಾ? ದಿಸ್ ಇಸ್ ದ ಸರ್ಕಲ್. ಮೋಸ್ಟ್ ಆಫ್ ದ ಅಫೆಕ್ಟೆಡ್ಸ್ ಯಾರು? ಏನೂ ಗೊತ್ತಿದ್ರೆ ಅಮಾಯಕರು. ಅವರಿಗೆ ಅಫೆನ್ಸ್ ಅಂದ್ರೆ ಏನು ಗೊತ್ತಿಲ್ಲ, ಸೆಕ್ಷುವಲ್ ಅಫೆನ್ಸ್ ಗೊತ್ತಿಲ್ಲ. ಚಿಕ್ಕ ಮಕ್ಕಳು ಅಟ್ಲೀಸ್ಟ್ ಒಂದು 16 to 18 ಅಂದ್ರೆ ಅವ್ರಿಗೆ ಒಂದು ಸ್ವಲ್ಪ ನಾಲೆಡ್ಜ್ ಇರುತ್ತೆ. ಐ ಹ್ಯಾವ್ ಸೀನ್ 4 years. ಆ ಮಗು ಏನು ಗೊತ್ತಿರುತ್ತೆ? ದಟ್ ಟು ಮೇಲ್ ಬೇಬಿ ಅಸಾಲ್ಟೆಡ್ ಬೈ ಸೋದರ ಮಾವ. ಅಲ್ಲೇ ಸಾಯಿಸಿದ್ದಾನೆ. ಐ ವಾಸ್ ಎ ಮೆಡಿಕಲ್ ಆಫೀಸರ್. ಅವರನ್ನ ನಾವು ಓಡಾಡಿಸ್ತಾನೆ ಇರ್ತೀವಿ. ಸೊ ಕಾಲ್ಡ್ ದ ಕ್ರೀಮ್ ಆಫ್ ದ ಕ್ರೀಮ್ ಲೇಯರ್ಸ್, ದ ಮೋಸ್ಟ್ ಇಂಟೆಲಿಜೆನ್ಸ್ ಆನ್ ದಿಸ್ ವರ್ಲ್ಡ್. ನಮಗೆ ನಾವು ಅದೇ ಅನ್ಕೊಳ್ಳೋದಲ್ಲ, ಎಲ್ಲರೂ ನಾವು ಅನ್ಕೊಳ್ಳೋದಂಗೆ, ನಾವು ಗ್ರೇಸ್ ಓದಿದ್ದೀವಿ, ಹ್ಯಾರಿಸನ್ ಓದಿದ್ದೀವಿ, ಡೇವಿಡ್ಸನ್ ಓದಿದ್ದೀವಿ, ವಿ ನೋ ಎವ್ರಿಥಿಂಗ್, ಗಿವ್ ಮಿ ಸಮ್ ಟೈಮ್, ಐ ವಿಲ್ ಡೂ ಎವ್ರಿಥಿಂಗ್ ಅಂತೀವಿ. ಮಾಡ್ತಾ ಇರೋದೇನು? ಇದನ್ನೇ ಮಾಡ್ತಾ ಇರೋದು. ಆ್ಯಂಡ್ ವಾಟ್ ದಿಸ್ ಆ್ಯಕ್ಟ್ ಸೇಸ್, ಲೀಗಲ್ ಆಗಿ ನಾವು ಏನು ಮಾಡಬೇಕು ಅನ್ನೋದಕ್ಕೆ ಅನ್ನೋದನ್ನು ಸ್ವಲ್ಪ ಜಾಸ್ತಿ ಹೇಳ್ತೀನಿ. ವಾಟ್ ಈಸ್ ಆ್ಯಕ್ಟ್ ಏನಿದೆ ಅಂತ ಹೇಳ್ಬಿಟ್ಟು ಅದನ್ನು ಸ್ವಲ್ಪ ಕಡಿಮೆ ಕಂಡೆನ್ಸ್ ಮಾಡೋಣ. ಇದಕ್ಕೆ ಒಂದಿನ ಮಾಡೋದು, ಒಂದು 20 ನಿಮಿಷದಲ್ಲಿ ಆದಷ್ಟು ಐ ಟ್ರೈ ಟು. ಇದು ನೆಕ್ಸ್ಟ್ ನಾಳೆ ಇದೆಯಾ? ನನ್ನದು ಸ್ಟಾರ್ಟ್ ವರ್ಕಿಂಗ್. The Act to protect the children from offences of sexual assault, sexual harassment and pornography. And what is that sexual assault and harassment and pornography? ನಮ್ಮಲ್ಲಿ ಎಷ್ಟು ಆಗ್ತಾ ಇದೆ ಅನ್ನೋದು, ಬಿಲೋ 6 years, 6 to 12 years, 12 to 16 years ಅಲ್ಲಿ in total, and 16 to 18 years total ಆಗಿ 2097 in 1 year ಆಗಿದೆ. ಇಟ್ಸ್ ಇನ್ ಮೇಲ್, ಏನಿಲ್ಲ, ಇಟ್ಸ್ ಎ ನ್ಯೂಟ್ರಲ್ ಆ್ಯಕ್ಟ್. ನಾವು ಅನ್ಕೊಂಡಿರ್ತೀವಿ ಇಟ್ಸ್ ಓನ್ಲಿ ಫಾರ್ ದ ಫೀಮೇಲ್ಸ್, ಇಟ್ಸ್ ಎನ್ ಎ ಜೆಂಡರ್ ನ್ಯೂಟ್ರಲ್ ಆ್ಯಕ್ಟ್. ಒಂದು 4-5 ಕ್ಯಾಟಗರಿ ಇದೆ ಇದರಲ್ಲಿ ಶಿಕ್ಷೆ ವಿಧಿಸಬೇಕಾದ್ರೆ. ಪೆನಿಟ್ರೇಟಿವ್ ಸೆಕ್ಸುವಲ್ ಅಸಾಲ್ಟ್, aggravated penetrative sexual assault, sexual assault, aggravated sexual assault, sexual harassment of the child, use of child for pornographic issues. ಏನು ಪೆನೆಟ್ರೇಟಿವ್? ಇಲ್ಲಿ penetration is happened either by penis, heart, finger, heart, tongue, ಈ ಥರ ಒಂದು ಪೆನೆಟ್ರೇಷನ್ ಅನ್ನೋದು ಹ್ಯಾಪನ್ ಆಗಿರುತ್ತೆ. ಎನಿ ಆಬ್ಜೆಕ್ಟ್, ಹಾರ್ ಬೈ ಮೌತ್, ಹಾರ್ ಬೈ ಇದು ಏನೋ ಒಂದು ಇದರಲ್ಲಿ ಆಗಿರುತ್ತೆ. ಬಟ್ ಇಸ್ ಅಗ್ರಿವೇಟೆಡ್ ಅಂದರೆ ದಟ್ ಈಸ್ ಬೈ ಅಫೆನ್ಸ್ ಬೈ ಸಮ್ ಜನರಲ್ ಮ್ಯಾನ್, ಜನರಲ್ ಪರ್ಸನ್, ಜನರಲ್ ಫೀಮೇಲ್, ಆ ಮೇಲ್ ಆರ್ ಫೀಮೇಲ್. ಅಗ್ರಿವೇಟೆಡ್ ಅಂದರೆ it is we do, the responsible persons, the police officers, wardens, doctors, teachers, army officers, ಇದನ್ನು ಅಗ್ರಿವೇಟೆಡ್ ಅಂತೀವಿ. ಯಾಕಂದ್ರೆ ವಿ ಆರ್ ರೆಸ್ಪಾನ್ಸಿಬಲ್ ಫಾರ್ ದಿಸ್. ಏನು ಕೊಠಡಿಗಳು ನಿಮಗೆ ಶೇರ್ ಕೊಟ್ಟಿರ್ತೀನಿ, ಟಿಕೆಟ್ ಇದು ನನಗೇನಲ್ಲ, ಇದೆಲ್ಲ ನಿಮಗೆ ತಂದಿರೋದು. ಯಾರು ಬೇಕಾದ್ರೆ ಅವ್ರ ಹತ್ರ ತಗೊಳ್ಳಿ ಅಥವಾ ನಿಮ್ಮ ಆರ್ಗನೈಸರ್ಸ್ ತಗೊಳ್ಳಿ. ದಿಸ್ ಮ್ಯಾನೇಜ್ಮೆಂಟ್ ಅಲ್ಲಿ ಯಾರು ಇರ್ತಾರೋ, ಜೈಲಲ್ಲಿ, ರಿಮಾಂಡ್ ರೂಮ್ ನಲ್ಲಿ, ಹಾಸ್ಟೆಲ್ ನಲ್ಲಿ ಇದು ಮಾಡೋದಂತ ಅಗ್ರಿವೇಟೆಡ್. Sexual assault, there is no penetration, but there is a touch of her or his private parts of the child. The vagina, penis, anus, breast of the child. ಇದು ಯಾವ್ದಾದ್ರು ಒಂದಿದ್ದಾರೆ, that is called sexual assault. Aggravated ಅಂದ್ರೆ same, again, the persons who is responsible, who is doing the sexual assault. Harassment, ನಮಗೆಲ್ಲರಿಗೂ ಅಭ್ಯಾಸ ಆಗ್ಬಿಟ್ಟಿರುತ್ತೆ. ವಾಟ್ ಇಸ್ ಹರಾಸ್ಮೆಂಟ್ ಅಂತ? uttering a word, making sound, gestures, exhibiting objects, making a child exhibit his part. ಇದೆಲ್ಲ, this is harassment. Use of child for the pornographic purposes. ಅದನ್ನು ಇಟ್ಕೊಂಡು ಸಹ ತಪ್ಪು. Not only the showing to the child, you keep the child pornographies in your mobile, in your laptop, in your any electronic gadget. This is an offense. What is the punishment? ಎಲ್ಲದಕ್ಕೂ ಅಗ್ರಿವೇಟೆಡ್ ಇದ್ದಾಗ ಆಲ್ಮೋಸ್ಟ್ ಡಬಲ್ ಇದೆ, ಸೆಕೆಂಡ್ ಟೈಮ್ ಇದ್ದಾಗ ಡಬಲ್ ಇದೆ, 5 years and 10 years ಈ ಥರ ಇದೆ. ದ ಫ್ರೆಂಡ್ಲಿ ಕ್ಲಿನಿಕ್ಸ್ ಅಲ್ಲೆಲ್ಲವೂ ಮಗುನ ಎಲ್ಲೂ ನಾವು ಕೋಟಿಗೆ ಕರ್ಕೊಬರಲ್ಲ. ಮಗು ಎಲ್ಲೂ ಇರುತ್ತೆ, ಅಲ್ಲೊಂದು ಅಟ್ಮಾಸ್ಫಿಯರ್, ಮಗುಗೆ ಆಟ ಆಡೋಕ್ಕೆ ಒಂದು ಅಟ್ಮಾಸ್ಫಿಯರ್ ಕ್ರಿಯೇಟ್ ಮಾಡಿರ್ತಾರೆ. ಅಲ್ಲಿಂದ ಒಂದೇ ಕೇಳೋದು, ಇವನೇ ಮಾಡಿದ್ದ ಅಂತ ಕೇಳ್ತಾರೆ. ಎಸ್ ಅಂದ್ರೆ ಮುಗೀತು, ಮತ್ತೇನು ಅವ್ರ ಹತ್ರ ಕೇಳೋದಿಲ್ಲ. ಎಸ್ ದಿಸ್ ಪರ್ಸನ್ ಎಸ್ ಡಿಡ್ ಇಟ್ ಅಂದ್ರೆ ಎಸ್ ಅಂತ ಮಗು ಹೇಳಿದ್ರೆ ದೆನ್ ಮಗು ಇಲ್ಲಿಂದ ಸ್ಕ್ರೀನ್ ಅಲ್ಲಿ ಹೊರಗಿರುತ್ತೆ, ಎಲ್ಲ ಇದರಲ್ಲಿ VC ಅಲ್ಲಿ ಇರ್ತದೆ, ವರ್ಚುವಲ್ ಇದರಲ್ಲಿ ಅಲ್ಲಿ ಮಗು ಆಟ ಆಡ್ತಾ ಇರುತ್ತೆ. ಇಲ್ಲಿ ದಟ್ ವಾಯ್ಸ್ ಸ್ಟಾರ್ಟ್ ಆಗುತ್ತೆ. ಈ ರೀತಿ ಒಂದು ಫ್ರೆಂಡ್ಲಿ ಅಟ್ಮಾಸ್ಫಿಯರ್ ಅನ್ನು ಕ್ರಿಯೇಟ್ ಮಾಡಿರ್ತಾರೆ ಅವರಿಗೆ. ಇದು ಮಗು ಇರುವಂತ ಜಾಗ. ಅವಾಗ ನಮಗೆ ಇದು ಬೇಕಾಗಿರುತ್ತೆ. ಇಷ್ಟು ಅದೊಂದು ಆಕ್ಟಿಂಗ್ ಬಗ್ಗೆ. ವಾಟ್ ವಿ ಶುಡ್ ಡೂ ಇನ್ ಅ ಮೆಡಿಕಲ್ ಎಕ್ಸಾಮಿನೇಷನ್, ಇಟ್ಸ್ ಲೈಕ್ ಎನಿ ಅದರ್ MLC ಎಕ್ಸಾಮಿನೇಷನ್, ನಥಿಂಗ್ ಎಲ್ಸ್. ಪೋಕ್ಸೋದಲ್ಲಿ ಮೆಡಿಕಲ್ ಎಕ್ಸಾಮಿನೇಷನ್ ಮಾಡಬೇಕಾದ್ರೆ ಮ್ಯಾಂಡೇಟರಿ ದೇರ್ ಶುಡ್ ಬಿ ಲೇಡಿ ಮೆಡಿಕಲ್ ಆಫೀಸರ್ ಅಂತಾನೆ ಇದೆ. JJ ಆಕ್ಟ್ ನಲ್ಲಿ ಇಲ್ಲ. ಪೋಕ್ಸೋ ಮಾಡಬೇಕಾದ್ರೆ ಯು ಶುಡ್ ನೋ ದಟ್ ಅಡ್ಮಿನಿಸ್ಟ್ರೇಟರ್ಸ್, ಹಾಸ್ಪಿಟಲ್ ಅಡ್ಮಿನಿಸ್ಟ್ರೇಟರ್, ವೆದರ್ ಇಟ್ಸ್ ಎ ಪ್ರೈವೇಟ್ ಆರ್ ಗವರ್ನಮೆಂಟ್, ಫಿಮೇಲ್ ಮೆಡಿಕಲ್ ರಿಜಿಸ್ಟರ್ಡ್ ಮೆಡಿಕಲ್ ಪ್ರಾಕ್ಟಿಷನರ್ ಆಫ್ ಫಿಮೇಲ್, ಅದು ಗೌರ್ಮೆಂಟಿಗೆ ಹೋಗ್ಬೇಕು ಅನ್ನೋ ಅವಶ್ಯಕತೆಗಳು ಇಲ್ಲ. ಬಟ್ ವಿ ಆರ್ ಡೂಯಿಂಗ್ ಇಟ್, ಗೌರ್ಮೆಂಟಿಗೆ ಹಾಕ್ಬಿಡ್ತಾ ಇದ್ದೀವಿ. ಬಟ್ ಎಲ್ಲವನ್ನೂ ನೋಡಿದ್ರೆ ಯಾರೋ ರೆಸ್ಪಾನ್ಸಿಬಿಲಿಟಿ ತಗೋಬೇಕಾಗುತ್ತೆ. ಆ ಮಗು ನಮ್ಮದೇ ಅಂತ ಅನ್ಕೊಂಡಿದ್ರೆ ವಿ ವಿಲ್ ಟೇಕ್ ಎ ರೆಸ್ಪಾನ್ಸಿಬಿಲಿಟಿ. ಆ ರೆಸ್ಪಾನ್ಸಿಬಿಲಿಟಿ ತಗೊಂಡಾಗ ಏನು ಮಾಡಬೇಕು? ನಮಗಿರೋವಂಥದ್ದು ಏನಂದ್ರೆ ಇಲ್ಲಿ ಒಪಿನಿಯನ್ ಏನು ಬರೆಯೋದು ಅನ್ನೋದೇ ದೊಡ್ಡ ಸಮಸ್ಯೆ ಆಗಿರುತ್ತೆ. ವೆನ್ ವಿ ಸೆಂಡ್ ಇಟ್ ರಿಪೋರ್ಟ್ ಟು ದ ಪೊಲೀಸ್, ನಮಗೆ ಏನು ಕ್ವಶನ್ ಕೇಳ್ಬಿಡ್ತಾನೆ ಜಡ್ಜು, ವೈ ವಿ ಶುಡ್ ಅನ್ನೆಸರಿ ಇನ್ವಾಲ್ವ್ ಅನ್ನೋದೇ ನಮಗಿರುವಂಥ ವೆರಿ ಬಿಗ್ ಪ್ರಾಬ್ಲಮ್. ನಮಗೆ ಗ್ರೇಸ್ ಅನ್ನೋ ಅರ್ಥ ಆಗುತ್ತೆ, ಯಾರಿಸೇನು ಅರ್ಥ ಆಗುತ್ತೆ? 30 ಪೇಜ್ 20 ಪೇಜ್ ಇರುವಂಥ ಫೋಕ್ಸೋ ಯಾಕೆ ಅರ್ಥ ಆಗಲ್ಲ? ಆ್ಯಕ್ಟ್ ಅನ್ನೋದೇ ನಮ್ಮ ಡಾಕ್ಟರ್ಗಳಿಗೆ ಕಬ್ಬಿಣದ ಕಡಲೆ, ಅದೇನಕ್ಕೆ ಬೇಕು ಅನ್ನೋದು ತುಂಬ ಜನರ ಹತ್ರ ಇರುವಂತಹ. ಫಸ್ಟ್ ಪ್ರಿಯಾರಿಟಿ ಇಸ್ ಆಸ್ ಯೂಶುವಲ್ ನಾಟ್ ಎ ಟ್ರೀಟ್ಮೆಂಟ್ ಇಸ್ ಫಸ್ಟ್ ಪ್ರಿಯಾರಿಟಿ. ಫಸ್ಟ್ ಅದನ್ನು ನೋಡಿ, ಮಗುನ ಬದುಕಿಸಿ, ಫಸ್ಟ್ ಏಡ್ ಮಾಡಿ, ಬ್ಲೀಡಿಂಗ್ ಏನಾದ್ರು ಆಗ್ತಿದ್ರೆ ಬ್ಲೀಡಿಂಗ್ ನಿಲ್ಲಿಸಿ, ಇದನ್ನ ಫಸ್ಟ್ ಇದು ಮಾಡಿ. ದೆನ್ ಒನ್ಸ್ ದ ಚೈಲ್ಡ್ ಇಸ್ ವೆರಿ ಸ್ಟೇಬಲ್, ದೆನ್ ವಿ ಡೂ ದ ಮೆಡಿಕಲ್ ಎಕ್ಸಾಮಿನೇಷನ್. ಎಲ್ಲರೂ ಹೇಳುವಂಥದ್ದು, ಇಲ್ಲಿ ಮಾಡೋಂಥದ್ದು ನಾವು ಆಬ್ಸ್ಟೆಟ್ರಿಷಿಯನ್, ಮೋಸ್ಟ್ ಆಫ್ ದ ಕೋರ್ಸ್ ಮಾಡೋದೇನು ಆಬ್ಸ್ಟೆಟ್ರಿಷಿಯನ್ನೇ ಮಾಡ್ತಾರೆ. ಅವರಿಗೊಂದು ಇದಿರುತ್ತೆ, ಟಿ ವಿ ಮಾಡಿಬಿಡ್ಬೇಕು, 2 ಫಿಂಗರ್ ಟೆಸ್ಟ್ ಮಾಡಿಬಿಡ್ಬೇಕು. ಅದು ಮಾಡಿದ್ರೆ ನಾವು ವಿ ಆರ್ ಕಾಲ್ಡ್ ಆಬ್ಸ್ಟೆಟ್ರಿಷಿಯನ್. ಇಲ್ಲಿ ಇಟ್ ಈಸ್ ನಾಟ್ ಟಿ ವಿ ಮಾಡಂಗಿಲ್ಲ. ಕಾಮನ್ಲಿ ರೆಫರ್ಡ್ ಬೈ ದ 2 ಫಿಂಗರ್ ಟೆಸ್ಟ್ ಮಸ್ಟ್ ನಾಟ್ ಬಿ ಕಂಡಕ್ಟೆಡ್. ಇದನ್ನೆಲ್ಲರೂ ತಿಳ್ಕೊಳ್ಳಿ. ಇಟ್ ಈಸ್ ಓನ್ಲಿ ಫಾರ್ ದ ಟ್ರೀಟ್ಮೆಂಟ್ ಪರ್ಪಸ್. We are going to do the TV, not for the purpose of POCSO case. ನಾವೇನೋ ಬರೆಯಲಿಕ್ಕೆ ಅಂತ ಮಾಡೋದಿಲ್ಲ. ಓನ್ಲಿ ಫಾರ್ ಏನೋ ಬ್ಲೀಡಿಂಗ್ ಆಗ್ತದೆ, we are not able to approach, then you do your Bible, that is your TV. And ನಮಗೆಲ್ರಿಗೂ ಒಂದು ಇದು ಅಭ್ಯಾಸ ಇದೆ, ಸೈಜಲ್ಲಿ ವಿಜಯನ ಬರೆಯೋದು, ಐಮನ್ ಇದೆಯಲ್ಲ ಬರೆಯೋದು, ಐಮನ್ ಇಂಟ್ಯಾಕ್ಟ್ ನಾಟ್ ಇಂಟ್ಯಾಕ್ಟ್, ಐಮನ್ ಇಸ್ ಟೋರ್ ಟೇರ್ ಅದು ಎಲ್ಲ ಬರೆಯೋದು. ಇದು ಯಾವುದು ಬರೀಬಾರ್ದು. ಆ್ಯಂಡ್ ಎಬಿಚುವಲ್ ಸೆಕ್ಸುವಲ್ ಇಂಟರ್ಕೋರ್ಸ್ ಇವತ್ತು ಲ್ಯಾಕ್ಸಿಟಿ ಆಗಿದೆ, ಇಲ್ಲ ನಮಗೆ ಇದು ಅನಿಸುತ್ತೆ habitually sexual intercourse. It is none of your business to write anything on that POCSO case. You should write ಆ ಸೆಕ್ಷುವಲ್ ಆ್ಯಕ್ಟ್ ಅವತ್ತಿನ ದಿನ ಆಗಿದೆಯಾ ಇಲ್ವಾ, ವೆದರ್ ಇಟ್ ಇಸ್ ಪ್ರೀವಿಯಸ್ ಇರೋದನ್ನ ಬರೀಬಾರ್ದು. ಇಂಜುರಿ ಡಾಕ್ಯುಮೆಂಟೇಶನ್ ಶುಡ್ ಬಿ ದೇರ್. ಇದು ಲೈಕ್ ಎನಿ ಅದರ್ MLC ಕೇಸ್. ಅದು ಸೈಜ್ ಬರೀತೀವಿ, ಶೇಪ್ ಬರೀತೀವಿ, ವೇ ಬರೀತೀವಿ, ಎಷ್ಟು ಬರೀತೀವಿ, ನಂಬರ್ಸ್ ಬರೀತೀವಿ, ಎವ್ರಿಥಿಂಗ್ ವಿಲ್ ಬಿ writing. The examination of the body part of sexual violence related to findings such as injuries, bleeding, swelling, tenderness, discharge, ಇದೆಲ್ಲವನ್ನು ಬರಬೇಕು. Details of size, shape and color, relevant findings. So, a sexual offense is reported against not only females, males and transgender, intersex, ಯಾರಾದರೂ ಇರ್ಬೋದು. ಫಸ್ಟ್ ಹೇಳಿದ್ರೆ ಇದು ನ್ಯೂಟ್ರಲ್ ಲಾ. The nature of forensic evidence collected will be determined by 3 main factors: nature of sexual violence, time lapse between the incidents, and the examination whether surveillance was or not. ಇದು ಮೂರನ್ನು ನಾವಲ್ಲಿ ರೆಕಾರ್ಡ್ ಮಾಡ್ತೀವಿ. ಅದು ಮಾಡ್ತೀವಿ, ಹೆದರಿಕೆ ಅಷ್ಟೇ, ಎಲ್ಲರೂ ಮಾಡಿರ್ತೀವಿ. ಯಾರು ಜಾಸ್ತಿ ಹೆದರ್ತಾರೋ ಅವ್ರು 5-6 ಜನ ಕನ್ಸಲ್ಟ್ ಮಾಡಿರ್ತಾರೆ. ಆಗೇನಕ್ಕ ಇಷ್ಟು, ಆಗೇನಕ್ಕ ಇಷ್ಟು, ಆಗೇನಕ್ಕ ಇಷ್ಟು, ಮೇಡಮ್ ಹಿಂಗೆ ಮಾಡ್ಲಾ ಅಂತ ಮತ್ತೆ ತಪ್ಪು ಬರ್ದಿರ್ತಾರೆ. ನಿಮಗೆ ಗೊತ್ತಿರುತ್ತೆ, ನಾ ಅಷ್ಟು ಚೆನ್ನಾಗಿ ಹೇಳ್ಕೊಟ್ಟಿದ್ದೆ ಮತ್ತೆ ಹಿಂಗೆ ಬರ್ದಿದ್ಯಾ ಅಂತ ಮತ್ತೆ ನೀವೇ ಕೇಳ್ತೀರ. The issue of whether the incident of rape, sexual assault occurred in a legal issue, not a medical diagnosis. We are not going to write any medical diagnosis. Rape ಆಗಿಲ್ಲ, sexual assault ಆಗಿದೆ, sexual assault ಆಗಿಲ್ಲ ಅನ್ನೋದನ್ನು ಮೆಡಿಕಲ್ ಟರ್ಮಿನಾಲಜಿ. ಇಟ್ಸ್ ಎ ಲೀಗಲ್ ಇಶ್ಯೂ. ಅವ್ರು ಬಂದಿರೋದು ನಿಮ್ಮ ಹತ್ರ ಲೀಗಲ್ ಆಗಿ, ಇಟ್ ಈಸ್ ಈ ಥರ ನನಗೆ ಅಸಾಲ್ಟ್ ಆಗಿದೆ, ಅದಕ್ಕೆ ನೀವು ಕೊಡಿ. ಬಟ್ ಅದನ್ನು ಬಿಟ್ಬಿಟ್ಟು ನಾವು ರೇಪ್ ಆಗಿದೆಯಾ ಇಲ್ವಾ ಅನ್ನೋದನ್ನ ನೋಡ್ತಾ ಇರ್ತೀವಿ. ಅಸಾಲ್ಟ್ ಆಗಿದೆಯಾ ಅಥವಾ ಇಲ್ಲ ಅನ್ನೋದು, ಯಾಕೆ ನಾವು ನಮ್ಮ ತಲೆಯಲ್ಲಿ ನಾವು ಡಾಕ್ಟರ್ ಅಷ್ಟೇ ಆಗಿರ್ತೀವಿ. ಅಲ್ಲಿಂದ ಹೊರಗೆ ಬಂದು ಅವ್ರ ಇಶ್ಯೂನ ಅಡ್ರೆಸ್ ಮಾಡ್ಕೊಂಡು ಹೋಗೋಣ. Consequently, doctor should not, on the basis of medical examination, conclude whether rape or sexual assault had occurred, or not only the findings in the relation to the medical findings should be recorded. ಏನು ಬರೀಬೇಕು ಅನ್ನೋದು ಕ್ಲಿಯರ್ ಆಗಿದೆ. ಪ್ರೊವಿಷನಲ್ ಒಪಿನಿಯನ್ ಏನು ಅಂತ ನಿಮಗೆ ಇದೊಂದು ಚಾರ್ಟ್ ಒಂದು ಸಿಕ್ಬಿಟ್ರೆ ಇಲ್ಲಿರೋ ಅಷ್ಟು ಜನ POCSO ಕೇಸ್ ನಾಳೆ ಅಂತ ನೋಡ್ತೀರಾ. ವಾಟ್ ವಿ ಶುಡ್ ರೈಟ್ ಇನ್ ಎ ಪ್ರೊಫೆಷನಲ್ ಒಪಿನಿಯನ್. ಏನು ಎರಡು ಇರ್ತದೆ ಈ ಸೆಕ್ಷುವಲ್ ಅಸಾಲ್ಟ್ ಅಲ್ಲಿ, ಯಾವುದೇ ಸೆಕ್ಷುವಲ್ ಅಸಾಲ್ಟ್ ಅಲ್ಲಿ ಓನ್ಲಿ 2 ಇಂಜರೀಸ್. ಒನ್ ಇಸ್ ಫಿಸಿಕಲ್ ಇಂಜರಿ, ಒನ್ ಇಸ್ ಜೆನಿಟಲ್ ಇಂಜರೀಸ್. ಎರಡೂ ಇದ್ರೆ ತಲೆನೋವು ಇರಲ್ಲ. ಎರಡೂ ಕಡೆ ಇದೆ ಅಂದ್ರೆ ತಲೆನೋವು ಇರಲ್ಲ, ನಾವು ಬರೆದು ಬಿಡ್ತೀವಿ. ಏನ್ ಬರಿಬೇಕು ಅಂತ ಗೌರ್ಮೆಂಟ್ ಆಫ್ ಇಂಡಿಯಾನೇ ಕೊಟ್ಬಿಟ್ಟಿದೆ ಚಾರ್ಟ್. ಗೌರ್ಮೆಂಟ್ ಆಫ್ ಇಂಡಿಯಾ ಹೆಲ್ತ್ ಡಿಪಾರ್ಟ್ಮೆಂಟ್ ಹ್ಯಾಸ್ ಇಶ್ಯೂಡ್ ಎ ಚಾರ್ಟ್ ವಾಟ್ ವಿ ಶುಡ್ ರೈಟ್. ಇಷ್ಟನ್ನೇ ಬರ್ಕೊಡಿ. ಗೌರ್ಮೆಂಟ್ ಯಾವ ಸುಪ್ರೀಂ ಕೋರ್ಟ್ಗೆ ಹೋದ್ರು ಅವ್ರು ಕೇಳೋದು ಇದೇ ಒಂದು ಪದಗಳನ್ನು. If the both injuries are there are signs suggestive of recent use of force, forceful penetration of vagina or anus, a sexual violence cannot be ruled out. ಈ ವರ್ಡಿಂಗ್ ಅಲ್ಲಿ ಏನಾದ್ರು ಇದೆಯಾ? ಇಷ್ಟು ಬರ್ದು ಕೊಟ್ಬಿಟ್ರೆ the both injuries are there, even provisional certificate. Provisional ಅಲ್ಲಿ ಇದು ಕೊಡ್ತೀವಿ. ಜೆನಿಟಲ್ ಇಂಜರೀಸ್ ಪ್ರೆಸೆಂಟ್ ಅಂಡ್ ಫಿಸಿಕಲ್ ಇಂಜರೀಸ್ ಅಬ್ಸೆಂಟ್. ಅಲ್ಲೂ ನಮ್ಗೆ ಏನೂ ತೊಂದರೆ ಇರಲ್ಲ, ಆದ್ರೂ ನಮ್ಗೆ ಡೌಟ್ ಬಂದ್ಬಿಡುತ್ತೆ, ಫಿಸಿಕಲ್ ಇಂಜರಿ ಇಲ್ವಲ್ಲ. ನಮ್ಮಲ್ಲಿ ಅಲ್ಲಿರುವಂತ ಅಡ್ವೊಕೇಟು ನಮ್ಮನ್ನ ಇನ್ನು ಇದೇ ಇದ್ರಲ್ಲಿ ಹೇಳ್ಬೇಕು, ನಮ್ಮನ್ನ ರೇಪ್ ಮಾಡ್ಬಿಟ್ರೆ ಅಂತ ಅನ್ಕೋಬಿಡ್ತೀವಿ ಅಲ್ವಾ. ನಾವು ಅದನ್ನ ಸೇವ್ ಮಾಡಕ್ ಹೋಗಿ ಈ ಮೇಕ್ ಇಟ್ ಅಸಾಲ್ಟೆಡ್ ಆರ್ ವಿ ಮೇಕ್ ಇಟ್ ರೇಪ್ ಅದನ್ನು ಹೇಳ್ತಾರೆ ಏನ್ ಬರೀಬೇಕು ಅಂತ. ದೇರ್ ಆರ್ ಸೈನ್ಸ್ ಸಜೆಸ್ಟಿವ್ ಆಫ್ ರೀಸೆಂಟ್ ಫೋರ್ಸ್ಫುಲ್ ಪೆನೆಟ್ರೇಷನ್ ಆಫ್ vagina and anus, whatever ನಾವು ಏನು ಫಿಸಿಕಲ್ ಆಗಿ ಏನು ಸಿಗುತ್ತೋ ವಜನೋ ಏನಸೋ ಮೌತ್ ಏನೋ ಅಂತ ಬರಬೇಕು. ಜೆನಿಟಲ್ ಇಂಜರೀಸ್ ಆರ್ ದೇರ್, ಫಿಸಿಕಲ್ ಇಂಜರೀಸ್ ಪ್ರೆಸೆಂಟ್. There are signs of use of force, however vaginal or anal or oral penetration cannot be ruled out. ಅಲ್ಲಿ ಇಂಜರಿ ಇಲ್ಲ, ಬಟ್ cannot be ruled out. This is what we should write. ಆವಾಗ ನಮಗೆ ಅವ್ರ ಕ್ವಶನ್ ಕೇಳುವಂತ ಇದರಲ್ಲಿ ನಾವೆಲ್ಲದಕ್ಕೂ ಆನ್ಸರ್ ಕೊಡೋದಕ್ಕೆ ಇಲ್ಲೇ ಇರ್ಬೇಕು. ಬೋತ್ ಆರ್ ಅಬ್ಸೆಂಟ್, ಇದೇ ದೊಡ್ಡ ಪ್ರಾಬ್ಲಮ್ ಇರೋದು, ಬೋತ್ ಆರ್ ಅಬ್ಸೆಂಟ್. ನಾವೇನ್ ಬರೆಯೋದು ಅದು ಕ್ಲೀನ್ ಆಗಿ ಕೊಡ್ತಾನೆ. ದೇರ್ ಆರ್ ನೋ ಸೈನ್ಸ್ ಆಫ್ ಯೂಸ್ ಆಫ್ ಫೋರ್ಸ್. ನಾವು ಕ್ಲಿಯರ್ ಆಗಿ ಮೆನ್ಷನ್ ಮಾಡಿದೀವಿ ನಮ್ಮ ಪ್ರೊವಿಷನಲ್ ಇದರಲ್ಲಿ. ದೇರ್ ಆರ್ ನೋ ಸೈನ್ಸ್ ಆಫ್ ಯೂಸ್ ಆಫ್ ಫೋರ್ಸ್, however final opinion is reserved pending availability of FSL reports. Sexual violence cannot be ruled out because there is a complaint. ಏನು ಇಲ್ಲ, but cannot be ruled out, waiting for FSL report. Correct? Any doubts here? ಈಗ ಫೈನಲ್ ಒಪಿನಿಯನ್ ವಿತ್ FSL report ಬರೀತೀವಿ. FSL report ಬರೀತೀವಿ. ಏನ್ ಬಂದ್ರೆ ಪ್ರೆಸೆಂಟ್ ಬಂದ್ಬಿಡ್ತು, ಯಾವುದು FSL ರಿಪೋರ್ಟ್ ಪಾಸಿಟಿವ್ ಪರ್ಸನ್. ನೋ ಇಶ್ಯೂಸ್. ಈಗ ನಾವು ಏನ್ ಬಂದಿದ್ವಿ ಎಲ್ಲ ಸರಿ ಆಯ್ತು. ದೇರ್ ಆರ್ ಸೈನ್ಸ್ ಸಜೆಸ್ಟಿವ್ ಆಫ್ ಫೋರ್ಸ್ಫುಲ್ ವಜೈನಲ್ ಏನಲ್ ಇಂಟರ್ಕೋರ್ಸ್. ಎಲ್ಲಿ ನಾವು ಬರ್ದಿರ್ತೀವೋ ಅದು ಬರ್ಬೋದು. ಡೌಟ್ಸ್ ಮುಗಿತಾ? ಈಗ ಫಸ್ಟ್ ಏನು ಬಂದಿದೆ ಅದೇ ಇದ್ರಲ್ಲಿ ಬರ್ತದೆ ಪಾಸಿಟಿವ್ ಫಾರ್ ಅಗೇನ್ ಜೆನೆಟಿಕ್ ಫಿಸಿಕಲ್ ಇಂಜರಿ ಆಬ್ಸೆಂಟ್ ಇದೆ, ಪಾಸಿಟಿವ್ ಫಾರ್ ಪ್ರೆಸೆನ್ಸ್ ಆಫ್ ಸೆಮೆನ್ ಇದೆ. ಸೊ ಅಲ್ಲೂ ಡೌಟ್ ಇಲ್ಲ ನಮಗೆ, ಸೆಮೆನ್ ಸಿಕ್ಕಿದೆ ಅಂದ್ಮೇಲೆ. ದೇರ್ ಆರ್ ಸೈನ್ಸ್ ಆಫ್ ಸಜೆಸ್ಟಿವ್ ಆಫ್ ಫೋರ್ಸ್ಫುಲ್ ವಜೈನಲ್ ಏನಲ್ intercourse. Genital injuries absent, physical injuries present, positive for semen. Allu namage problem, there is no, there is a science suggestion of forceful vaginal anal intercourse anta birth kalsthi. This is the final opinion. Illi mugitu namge. Both are absent, positive for presence of semen. Allu namage ಆಧಾರ ಸಿಕ್ತು. So we are going to write there are signs suggestive of vaginal anal intercourse. And ಇದೆರಡು ಆಬ್ಸೆಂಟ್ ಆಗಿ ಪಾಸಿಟಿವ್ ಫಾರ್ ಡ್ರಗ್ಸ್ ಅಂಡ್ ಆಲ್ಕೋಹಾಲ್ ಅಂಡ್ ಸೆಮೆನ್. ಎರಡು ಆಬ್ಸೆಂಟ್ ಇದ್ದಾಗ ನಮಗೆ ಪ್ರಾಬ್ಲಮ್ ಬರೋದು. ಪಾಸಿಟಿವ್ ಫಾರ್ ಡ್ರಗ್ಸ್, ಆಲ್ಕೋಹಾಲ್ ಅಂಡ್ ಸೆಮೆನ್ ಮೂರು ಇರುತ್ತೆ. There are signs suggestive of vaginal anal intercourse under the influence of drugs and alcohol ಅಂತ ಬರುತ್ತೆ. ಏನ್ ಡ್ರಗ್ಸ್ ಕೊಟ್ಟಿರ್ತಾನೋ ಆ ಡ್ರಗ್ಸ್ ಅನ್ನು ಹಾಕ್ಬಿಟ್ಟು ಬರೀತೀವಿ ಅಷ್ಟೇ. ಗಾಂಜಾನೋ ಇನ್ನೊಂದು ಮ್ಯಾರೇಜ್ ಏನೋ ನಮ್ಗೆ ಏನು ಗೊತ್ತಿರುತ್ತಲ್ಲ, ಈಗ FSL ರಿಪೋರ್ಟ್ ಕೊಟ್ಟಿರ್ತಾನೆ ಅದರ ಪ್ರಕಾರ ಬರೀತೀವಿ. ಇದರಲ್ಲಿ ಏನಾದ್ರು ಡೌಟ್ ಇದೆಯಾ? ಈ ಎರಡು ಚಾರ್ಟ್ ಇದ್ರೆ ನೀವು ಎಲ್ಲರೂ ಬರೀತೀವಲ್ಲ. ವಿ ವಿಲ್ ಗಿವ್ ಜಸ್ಟಿಸ್ ದ ಕ್ರೀಮ್ ಆಫ್ ದ ಲೇಯರ್ಸ್. ಗರ್ಲ್ಸು ಏನೋ ಇರೋ ಈ ಗೋಬಿಜಿ ಬುಕ್ಕಲ್ಲಿ ಯಾವ್ದಾದ್ರು ಇದೋ ಗೊತ್ತಿಲ್ಲ, ನಾವಿದ್ದಾಗ ದತ್ತ ಇತ್ತು ಇದಿತ್ತು, ಮೊಹಮ್ಮದ್ ಲೇಯರ್ ಅಂತಿತ್ತು. ಈಗ ದೇರ್ ಆರ್ ಸೋ ಮೆನಿ ಬುಕ್ಸ್, ಅದು ಇದೇ ಇರುತ್ತೆ. ಮತ್ತೆ ಎಲ್ಲ ನಾವು ಸ್ಟ್ರೈಕ್ ಮಾಡಿದಾಗ ಇನ್ನೊಂದು ಮಾಡಿದಾಗ ನಾವು ಹೇಳೋದು ನಾವು ಸರ್ವಿಸ್ ಮಾಡೋಕ್ಕಾಗಿ ಬಂದಿರೋರು, ನಾವು ಸರ್ವಿಸ್ ಮಾಡ್ತಾ ಇರ್ತೀವಿ, ನಮ್ಮನ್ನೆಲ್ಲದಕ್ಕೂ ಬಿಟ್ಬಿಡಿ ಅಂತ. ಸರ್ವಿಸ್ ಕೊಡ್ತಾ ಇದೀವಿ ಅಂತ ಕೇಳೋದು ಮಾತ್ರ ಅದಿರಲ್ಲ. ಇದು ಬಂದಾಗ ನಮಗೆ ಸರ್ವಿಸ್ ಅಲ್ಲ, ನಾವು ಡಾಕ್ಟರ್ ಆಗ್ಬಿಟ್ಟಿರ್ತೀವಿ, ಸರ್ವಿಸ್ ಅಲ್ಲ ನಾವು. Genital injury is present, physical injury is present. Final opinion for bite marks present in Balitri. There are signs suggestive of evidence of bite marks on that site ಅಂತ ಬರ್ಬಿಟ್ಟು ಅದನ್ನು ಒಂದು ಒಪಿನಿಯನ್ ಕೊಡ್ತೀವಿ. ಇದು ನಾನ್ ಪೆನೆಟ್ರೇಟಿವ್ ಇದರಲ್ಲಿ, ಅದೆಲ್ಲ ಪೆನೆಟ್ರೇಟಿವ್ ಎಲ್ಲ ಆಯಿತು. ಈಗ ನಾನ್ ಪೆನೆಟ್ರೇಟಿವ್ ಇದರಲ್ಲಿ ಏನು ಬಂದಿದ್ದೀವಿ, ಸಕಿಂಗ್ ಮಾರ್ಕ್ಸ್ ಇದ್ರೆ ಸಬ್ಕ್ಯೂಟೇನಿಯಸ್ ಇನ್ನೊಂದು ಏನು ಪ್ರೆಸೆಂಟ್ ಇದ್ರೆ there are signs suggestive of sucking marks on the site. ಯಾವ ಸೈಟ್ ಅಂತ ಬಂದ್ಬಿಟ್ಟು ಟೈಮ್ ಇಂಜುರಿ ಬರ್ದಿರ್ತೀವಿ. Forceful fondling with presence of bruises and continuous with or without fingernail marks. There are signs suggestive of forceful physical injuries. ಏನಂದ್ರೆ ನಾವು ಒಪಿನಿಯನ್ ಬರೆಯೋದನ್ನ ಕಲ್ತ್ಕೋಬೇಕು. ಒನ್ ಈಸ್ ಪೆನೆಟ್ರೇಟಿವ್, ಒನ್ ಈಸ್ ನಾನ್ ಪೆನೆಟ್ರೇಟಿವ್. ಒನ್ ಸ್ಟೋನೋಗ್ರಫಿಯಲ್ಲಿ ನಾವೇನು ಇದು ಮಾಡೋದಿಲ್ಲ. ಇದೆರಡನ್ನೂ ಕಲ್ತ್ಕೊಂಡ್ರೆ ಇಲ್ಲಿರೋ ಮೋಸ್ಟ್ಲಿ ಇಫ್ ನಾಟ್ ಈಗ ಒಂದು 5% ಆಫ್ ದ ಪೀಪಲ್ ಆರ್ ಡೂಯಿಂಗ್ ಇಟ್ ಫೋರ್ಸ್ಫುಲಿ, ಎನ್ಫೋರ್ಸ್ಡ್ ಡೂಯಿಂಗ್. ಅದು ಫೋಕ್ಸೋ ಮಾಡೋದಾದ್ರು ಯಾರು ವಾಲಂಟ್ರಿ ನಾ ಮಾಡ್ತೀನಿ ಅಂತ ಯಾರು ಮಾಡೋದೇ ಇಲ್ಲ. ಫೋರ್ಸ್ಫುಲಿ ನಾನು ಏನು ಡ್ಯೂಟಿ ಇದೆ ಮಾಡಲೇಬೇಕು, ನನ್ನ ಕರ್ಮ ಅನ್ಕೊಂಡು ಮಾಡೋದನ್ನು ಬಿಟ್ಟು ಇದು ಗೊತ್ತಿದ್ರೆ ಫ್ರಮ್ ಟುಮಾರೋ ವಿ ಸ್ಟಾರ್ಟ್ ರೈಟಿಂಗ್ ಒಂದು 50%. ಇವ್ರು ಮಾಡ್ತಾ ಇದ್ದಾರೆ ನಾವು ಮಾಡ್ತಾ ಇಲ್ಲ ಅಂತ ವಿ ಸ್ಟಾರ್ಟ್ ಡೂಯಿಂಗ್ ಟುಮಾರೋ. ಅವರಿಬ್ರು ಮಾಡ್ತಾ ಇದ್ದಾರೆ ಅಂತ ಸರ್ ನಾಡಿದ್ದು ಇವ್ರು ಸ್ಟಾರ್ಟ್ ಮಾಡ್ತಾರೆ. ವಿತಿನ್ ಸಮ್ ಟೈಮ್ನಲ್ಲಿ ಒಂದು 60 to 70% ಅಥವಾ 80% ದೇ ವಿಲ್ ಸ್ಟಾರ್ಟ್ ಡೂಯಿಂಗ್ ಇಟ್. ದೆನ್ ವಿ ಆರ್ ಗೈಡಿಂಗ್ ದಿ ಯಂಗ್ಸ್ಟರ್ ಹೂ ಕೇಮ್ ವೆರಿ ಇದು ಈಗ ತಾನೇ PG ಮುಗಿಸ್ಬಂದಿರ್ತಾರೆ ಅಥವಾ MBBS ಮುಗಿಸ್ಕೊಂಡು PG PSC ಸೇರಿರ್ತಾರೆ ಅಥವಾ ಕ್ಲಿನಿಕ್ ಸ್ಟಾರ್ಟ್ ಮಾಡಿರ್ತಾರೆ. ದೇ ವಿಲ್ ಸ್ಟಾರ್ಟ್ ರೈಟಿಂಗ್. ಇಲ್ಲ ನಾನು ಮಾಡ್ತೇನೆ ಬಿಡು, ಅದ್ರಲ್ಲೇನಿದೆ, ಒಂದಿನ ಕೋರ್ಟಿಗೆ ಹೋಗಿ ಬರೋದು ಇಷ್ಟೇ ತಾನೇ ಇರೋದು. ವಿ ಕ್ಯಾನ್ ಏನಂದ್ರೆ ನಾವು ಬರೀದೇ ಇರೋಂಥದ್ದು ಒಂದು ಒಪಿನಿಯನು. ಅವ್ರು ಕೇಳೋಂಥ ಕ್ವಶನ್ ಟೈಮ್ ಆಫ್ ಇಂಜುರಿ ಎಷ್ಟಾಗಿದೆ, ವೈ ಅಂತ ನಾವು ಒಂದು ಇಟ್ಕೊಂಡು ಹೋಗ್ಬಿಟ್ಟಿರ್ತೀವಿ. ಫಸ್ಟಿಗೆ ನಾವು ಸುಮ್ಮನೆ ನಾವು ಈ ಗುಂಡ್ ಸರ್ಟಿಫಿಕೇಟ್ ಇಟ್ಕೊಂಡು ಹೋಗ್ತಾ ಇದ್ವಿ, ಅಥವಾ ಒಂದೊಂದ್ಸರಿ ಅವನ ಹತ್ರನೇ ತಗೊಂಡು ಗುಂಡ್ ಸರ್ಟಿಫಿಕೇಟ್ ಪ್ರೆಸೆಂಟ್ ಮಾಡ್ತಾ ಇದ್ವಿ. ಸ್ವಲ್ಪ ಕಾಂಪ್ಲಿಕೇಟೆಡ್ ಕೇಸ್ ಅಲ್ಲಿ ನಾವು ಹೆಂಗೆ ಹೋಗ್ತೀವಿ, ನಮ್ಮ ಮೋದಿ, ನಮ್ಮ ನಾರಾಯಣ ರೆಡ್ಡಿ ಹಿಡ್ಕೊಂಡು ಹೋಗ್ತೀವಿ. ಸರ್ ಅವ್ರು ಏನೋ ಕೇಳ್ತಾ ಇರ್ತಾನೆ, ಜಡ್ಜಿಗೆ ಹೇಳ್ತಾರೆ ನಾವು, ಇಲ್ಲ ಸರ್ ಅವರ್ ಬುಕ್ ಸೇಸ್ ಲೈಕ್ ದಿಸ್, ವೈ ವಿ ಹ್ಯಾವ್ ರಿಟನ್ 7 days ಬಿಕಾಸ್ ದಿಸ್ ಈಸ್ ದ ಥಿಂಗ್. ವೈ ವಿ ಹ್ಯಾವ್ ರಿಟನ್ ಫಾರ್ 3 days, ವೈ ವಿ ಹ್ಯಾವ್ ರಿಟನ್ ಫ್ರೆಶ್ ಇಂಜುರಿ ಅಂತ ಬರ್ದಿರ್ತೀವಲ್ಲ, ಅದಕ್ಕೆ ನಮಗೆ ನೀನು ಅವ್ರೇನು ಅವ್ನ ಲಾ ಯಾರು ಮಧ್ಯಪ್ರದೇಶದಲ್ಲಿ ಹಿಂಗಾಯ್ತು, ಪಂಜಾಬ್ನಲ್ಲಿ ಹಿಂಗಾಯ್ತು ಅಂತ ಅವ್ನು ಹೇಳ್ತಾ ಇರ್ತಾನೆ. ನೋ, ಐ ಆಮ್ ಎ ಮೆಡಿಕಲ್ ಸ್ಟೂಡೆಂಟ್, ಐ ಆಮ್ ಎ ಮೆಡಿಕಲ್ ಡಾಕ್ಟರ್, ಮೈ ಬುಕ್ ಸೇಸ್ ಲೈಕ್ ದಿಸ್ ಅಂಡ್ ಐ ಆಮ್ ಟಾಟ್ ಲೈಕ್ ದಿಸ್, ಐ ಆಮ್ ಟಾಟ್ ಅಂಡ್ ಐ ಆಮ್ ರೀಡಿಂಗ್ ಲೈಕ್ ದಿಸ್ ಅಂತಾನೆ. ಅದನ್ನ ಹೇಳಿದಾಗ ಇವನ್ ಜಡ್ಜ್ ವಿಲ್ ಕೀಪ್ ಕ್ವೈಟ್. ಇದು ನಿಮ್ದು ಬುಕ್ಕೇ ಇದೆ, ಗವರ್ಮೆಂಟ್ ಆಫ್ ಇಂಡಿಯಾ ರಿಲೀಸ್ ಮಾಡಿರೋ ಬುಕ್. ನಾ ಏನು ಹೊಸದಾಗಿ ಏನು ನಾವು ಮಾಡಿರೋದೇನೋ ಅಲ್ಲ, ಎಕ್ಸ್ಪೋರ್ಟ್ ಮಾಡಿರೋದು ಅಲ್ಲ, ಗವರ್ಮೆಂಟ್ ಆಫ್ ಇಂಡಿಯಾನೇ ರಿಲೀಸ್ ಮಾಡಿದೆ ವಾಟ್ ವಿ ಶುಡ್ ರೈಟ್ ಅಂತ. ಇದನ್ನ ಇಟ್ಕೊಂಡು ಹೋಗ್ಬಿಟ್ರೆ ದೇ ವಿಲ್ ನಾಟ್ ಆಸ್ಕ್ ಯು ಎನಿಥಿಂಗ್.
Dr. Geeta ma'am and the chairperson on dais to honor speaker. I request Dr. Geeta ma'am and Dr. Soumya ma'am to honor the chairperson on the dais. Thank you so much.
CME to kindly take their seats on the dais.
Next up is Dr. Harish Delangvettu sir, President-elect IMA Karnataka. Next, Chitradurga. BMCH Chitradurga. Chitradurga. Dr. Narayan Murthy sir, HOD Department of Pathology, BMCH Chitradurga. Hospital Chitradurga. Next, Dr. Lata Njima, President, COG. Next, Dr. Geeta Yashusman, Professor, Unit Chief, Department of Obstetrics. And organizing committee members on the dais. Gynaecology, Chitradurga.
Respected dignitaries in the dais, esteemed guests of honor, honorable patrons, distinguished faculty, dear IMA and KOGA members, dear postgraduate students and interns, a very good morning to one and all. It gives me immense pleasure and pride to welcome you all to the Medicolegal Cme on safe care and secure practice. It's jointly organized by KOGA and IMA Chitradurga in association with Basaveshwara Medical College, Chitradurga. Today's CME is a timely and a relevant academic initiative aimed at strengthening our understanding of medical legal responsibilities and ensuring safe, ethical and legally sound medical practice. At the outset, it's my honor to respectfully acknowledge our patrons whose guidance and support have made this event possible. We are deeply grateful to Sri Shivayogi C. Kalsar, retired IAS President, Administrative Committee, SJM Vidyapita, Chitradurga. Dr. Basavkumar Swamiji, Dr. P.S. Shankar, Sri S.N. Chandrasekhar, members of Administrative Committee, SJM Vidyapita. Next, I would like to welcome Dr. Prashant G. Dean, sir, who is the Dean of the BMCH, and Dr. Rajesh M.S., Medical Superintendent, BMCH. We are pleased to welcome our guests of honor, distinguished leaders of the medical fraternity, Dr. T.A. Veerabhadraya, President, IMA Karnataka. Welcome you, sir. Dr. Harish Delangvettu, President, IMA Karnataka. We welcome you, sir. We were expecting Dr. Durgadas Astanna, President of Kasoga, but due to unavoidable circumstances, he could not join us. Your presence today truly adds grace and value to this academic gathering. We are honored to welcome an eminent panel of speakers who have travelled all the way from their different places to share their knowledge with us. The chairpersons, moderators who will be sharing their knowledge along on the medical legal topics throughout the day. Once again, I extend a warm and heartfelt welcome to all the guests, members of IMA, KOGA, postgraduate students, interns, and all the delegates who are present over here. I would also like to acknowledge and appreciate our organizing committee whose dedication and teamwork have ensured smooth conduct of this CME. I welcome Dr. Palakshaya sir, our IMA president, Dr. Pahalad sir, secretary IMA, Dr. Basaveshwara KM sir, treasurer IMA, Dr. Lata V madam, HOD, Basaveshwara Medical College, Dr. Geeta HH professor, organizing committee, and Dr. Narayan Murthy sir, HOD pathology. So once again, a warm welcome to one and all. Thank you, and I wish the program a grand success.
ಎಲ್ಲರೂ ದುಃಖದಿಂದ ಮುಕ್ತವಾಗಿರಲಿ, ಎಲ್ಲ ಆಸೆ ಆಮಿಷಗಳನ್ನು ಮೀರಿ ಗುಣಪಡಿಸುವವರು ಡಾಬಾಗಿರಲಿ. ಈಗ ನಾನು ಧ್ವಜವಂದನೆ ನಾನೇ ಮಾಡ್ತೇನೆ, ಯಾರು ಹೇಳುವ ರಿಪೀಟ್ ಮಾಡುವ ಅವಶ್ಯಕತೆ ಇಲ್ಲ. ಭಾರತೀಯ ವೈದ್ಯಕೀಯ ಸಂಘದ ಸದಸ್ಯರಾದ ನಾವು ನಮ್ಮ ರಾಷ್ಟ್ರಧ್ವಜಕ್ಕೆ ವಂದನೆ ಸಲ್ಲಿಸಲು ಇಲ್ಲಿ ನಿಂತಿದ್ದೇವೆ. ಅದರ ಗೌರವ ಮತ್ತು ವೈಭವವೇ ನಮ್ಮ ಬೆಳಕು ಮತ್ತು ಶಕ್ತಿ, ಮತ್ತು ಅದರ ಪದವೇ ನಮ್ಮ ಪಥವು. ಈ ರಾಷ್ಟ್ರೀಯ ಸಂಸ್ಥೆಯ ಮಾನ್ಯತೆ ಪಡೆದ ಸದಸ್ಯರಾದ ನಾವು ನಮ್ಮ ಜವಾಬ್ದಾರಿಗಳನ್ನು ಅರಿಯುವ ಮೂಲಕ ಅದಕ್ಕೆ ನಮ್ಮ ನಿಷ್ಠೆಯನ್ನು ತೋರಿಸುವ ಪ್ರತಿಜ್ಞೆ ಮಾಡುತ್ತಿದ್ದೇವೆ. ದೇಶ ಸಮೂಹಗಳ ನಡುವೆ ನಮ್ಮ ರಾಷ್ಟ್ರಧ್ವಜವು ಉನ್ನತ ಮಟ್ಟದಲ್ಲಿ ಹಾರಾಡುವ ಸಲುವಾಗಿ ನಮ್ಮ ಅಧಿಕಾರದಲ್ಲಿರುವ ಎಲ್ಲವನ್ನೂ ಅದಕ್ಕೆ ಸಮರ್ಪಿಸುವ ಪ್ರಮಾಣ ಮಾಡುತ್ತಿದ್ದೇವೆ. ಐಎಂಎ ಚಿರಾಯುವಾಗಲಿ. ನಮಸ್ಕಾರ.
We request Dr. Mahesh sir to water the plant. Thank you, sir.
Medicolegal Cme ಒಂದು ಥೀಮ್ ಸೇಫ್ ಕೇರ್ ಸೆಕ್ಯೂರ್ ತುಂಬ ಸಂತೋಷದ ವಿಚಾರ. ಈ ಒಂದು ಸಭೆಯ ಪ್ರೆಸಿಡೆಂಟ್ ಎಲೆಕ್ಟ್ ಆದಂಥ ಡಾಕ್ಟರ್ ಹರೀಶ್ ಅವರೇ ಮತ್ತು ಬಸವೇಶ್ವರ ಮೆಡಿಕಲ್ ಕಾಲೇಜ್ ಹಾಗೂ ಈ ಒಂದು ಆರ್ಗನೈಸಿಂಗ್ ಕಮಿಟಿಯ ಮತ್ತು ಭಾರತೀಯ ವೈದ್ಯಕೀಯ ಸಂಘ ಚಿತ್ರದುರ್ಗ ಶಾಖೆಯ ಅಧ್ಯಕ್ಷರಾದಂಥ ಮತ್ತು ನನ್ನ ಸಹಪಾಠಿ ಡಾಕ್ಟರ್ ಪ್ರಹ್ಲಾದ್ ಅವರೇ ಹಾಗೂ ನನ್ನ ಸ್ನೇಹಿತರು ಮತ್ತು ಖಜಾಂಚಿಯಾದಂಥ ಡಾಕ್ಟರ್ ಬಸವರಾಜ್ ಅವರೇ, ಆರ್ಗನೈಸಿಂಗ್ ಕಮಿಟಿಯ ಇತರ ಸದಸ್ಯರಾದ ಡಾಕ್ಟರ್ ಲತಾ ಅವರೇ, ಡಾಕ್ಟರ್ ರಶ್ಮಿ, ಸೌಮ್ಯ, ಲತಾ ವಿ, ಗೀತಾ HH ಮತ್ತು ಸ್ನೇಹಿತರಾದ ನಾರಾಯಣ ಮೂರ್ತಿಯವರೇ, ಹಾಗೂ ಈ ದಿನ ನಮಗೆ ಟಾಕ್ ಕೊಡಲಿಕ್ಕೆ ಬಂದಂಥ ಉತ್ತಮ ಟಾಪಿಕ್ಗಳಿದೆ. ಅದರಲ್ಲಿ ನಮ್ಮ ಗೋಪಿನಾಥ್ ಶೆಣೆಯವ್ರನ್ನ ಮತ್ತು ಪವನ್ ಕುಮಾರ್ ಮತ್ತು ಇವರೆಲ್ಲ ತುಂಬ ಚೆನ್ನಾಗಿ ವಿವೇಕ್ ದೊರೆ, ಗೋಪಿನಾಥ್ ಶೆಣೆಯವ್ರನ್ನ ಭಾಳ ದಿವಸ ನೋಡಿದ್ದೀನಿ. ಈಸ್ ಅ ವೆರಿ ಎಮಿನೆಂಟ್ ಅಡ್ವೊಕೇಟ್ ಆ್ಯಂಡ್ he was a gynecologist turned advocate now. He practices with our KMC also. Welcome you, sir. I am happy to be here with you. And ಇಲ್ಲಿ ನಡೆದಿರ್ತಕ್ಕಂಥ ಎಲ್ಲ ಹಿರಿಯ ಮತ್ತು ಕಿರಿಯ ಸ್ನೇಹಿತರೆ, ತಾವು ಸೇಫ್ ಅಂಡ್ ಸೆಕ್ಯೂರ್ ಪ್ರಾಕ್ಟೀಸ್ ಮಾಡಬೇಕು ಅಂದರೆ ಈ ಥರದ ಕಮ್ಮಟಗಳು ಸಾಕಷ್ಟು ನಡಿಬೇಕು. ಜೊತೆಯಲ್ಲಿ ನಾವು ಸುಮ್ಮನೆ ಬರ್ತೀವಿ, ಕೇಳ್ಕೊಂತೀವಿ, ಹೋಗ್ತೀವಿ. ಆದರೆ ನಾವು ಮೆಡಿಕಲ್ ಕೌನ್ಸಿಲಲ್ಲಿ ನೋಡ್ತಾ ಇದ್ದೀವಿ ಸಾಕಷ್ಟು ತಪ್ಪುಗಳನ್ನ ನಮ್ಮ ವೈದ್ಯರುಗಳು ಮಾಡ್ತಾ ಇರ್ತಾರೆ. ಏನಂದರೆ ಮೊದಲನೇದು ಡಾಕ್ಯುಮೆಂಟೇಶನ್. ವಾಟ್ ಎವರ್ ವಿ ಡೂ ವಿ ಹ್ಯಾವ್ ಟು ಡಾಕ್ಯುಮೆಂಟ್. ನಾವು ವಿ ಆರ್ ಫೇಲಿಂಗ್ ಇನ್ ಡಾಕ್ಯುಮೆಂಟಿಂಗ್ ಅವರ್ ಡೀಡ್ಸ್, ವಾಟ್ ಎವರ್ ವಿ ಡೂ. ಇಫ್ ಸಮ್ ಡೆತ್ ಹ್ಯಾಪನ್ಸ್, ದೆನ್ ವಿ ಥಿಂಕ್ ಆಫ್ rewriting cash sheet, everything. So it is not good practice. Actually, in some cases, police will come, they capture your case sheet, everything, every document, and they will go off, and you will have nothing left to write. ಸೊ ಇನ್ನು ಕೆಲವರು ಏನು ಮಾಡ್ತಾರೆ, ಪೊಲೀಸರು ಇನ್ನೂ ಬಂದಿಲ್ಲ ಅಂತ ಹೇಳ್ಬಿಟ್ಟು ಕೇಸ್ ಶೀಟ್ ತಗೊಂಡು ಕೇಸ್ ಶೀಟಲ್ಲಿ ತಿದ್ದುತ್ತಾ ಹೋಗ್ತಾರೆ. ಏನೇನು ಅದು ಅಭ್ಯಾಸ ಗೊತ್ತಾಗುತ್ತೆ, ಏನೇನು ತಿದ್ದಿದ್ದೀರಿ, ಏನು ಮಾಡಿದ್ದೀರಿ ಅಂತ ಕುಕ್ಕಪ್ ಮಾಡಕ್ಕೆ ಹೋಗ್ತೀರಿ. ಆ ಕುಕ್ಕಪ್ ಮಾಡೋ ಟೈಮಲ್ಲಿ ಸಾಕಷ್ಟು ನಾವು ನೋಡ್ತಾ ಇರೋದ್ರಿಂದ ನಾನು ಹೇಳ್ತಾ ಇರೋದು. ದಿನ ಬೆಳಗ್ಗೆ ಎದ್ದರೆ ಮೆಡಿಕಲ್ ಕೌನ್ಸಿಲಲ್ಲಿ ನಮ್ಮ ವೈದ್ಯರುಗಳು ಮಾಡ್ತಕ್ಕಂಥ ತಪ್ಪುಗಳನ್ನೇ ನಾನು ನಿಮ್ಗೆ ಹೇಳ್ತಾ ಇದ್ದೀನಿ ಅಷ್ಟೇ. ನಾನು ಸೃಷ್ಟಿ ಮಾಡ್ಕೊಂಡು ಹೇಳೋ ಅಂಥದ್ದು ಏನಿಲ್ಲ. ನಾವೊಂದು ಉದಾಹರಣೆ ಕೊಡಬೇಕಂದ್ರೆ, ಒಂದು ಇದು ಮೆಡಿಕಲ್ ಕೌನ್ಸಿಲ್ಗೆ ಬರೀ ಪ್ರೈವೇಟ್ ಡಾಕ್ಟರ್ಸ್ಗೆ ಅಷ್ಟೇ ಕೇಸ್ಗಳು ಬರಲ್ಲ, ಗೌರ್ಮೆಂಟ್ ಡಾಕ್ಟರ್ಸ್ಗೂ ಬರುತ್ತೆ. ಒಂದು ಗೌರ್ಮೆಂಟ್ ಆಸ್ಪತ್ರೆದು ಕತೆ ಹೇಳಬೇಕು ಅಂದರೆ, ಆ ಕೇಸ್ ಶೀಟಲ್ಲಿ ಅವ್ರದ್ದು ಅಡ್ರೆಸ್ ಮಾಡಿರೋದು ಒಂದು ಮಗುದು ಪಿಡಿಯಾಟ್ರಿಷನ್ದು. ಆಮೇಲೆ ಕೊನೆಗೆ ಡೆತ್ ಡಿಕ್ಲೇರ್ ಮಾಡಬೇಕಾದ್ರೆ ಅವರು CPR ಕೊಟ್ಟೆ ಅದು ಕೊಟ್ಟೆ ಅಂತ ಬರೀತಾರೆ. ಇನ್ ಬಿಟ್ವೀನ್ ಏನೂ ಇಲ್ಲ, ಡಯಾಗ್ನೋಸಿಸ್ ಇಲ್ಲ, ಅದು ಸಿಂಟಮ್ಸ್ ಇಲ್ಲ, ಸೈನ್ಸ್ ಇಲ್ಲ, ಎಂಥದ್ದಿಲ್ಲ, ಇನ್ವೆಸ್ಟಿಗೇಷನ್ ಬರ್ದಿಲ್ಲ, ಏನು ಬರ್ದಿಲ್ಲ. ಕೇಸ್ ಶೀಟಲ್ಲಿ ಇಷ್ಟು ಮಾತ್ರ ಇದೆ. ಮಗುದು ಅಡ್ರೆಸ್ ಇದೆ ಒಂದು ಪೇಜಲ್ಲಿ, ಇನ್ನೊಂದು ಪೇಜಲ್ಲಿ ಲಾಸ್ಟಿಗೆ ರಿಸಸಿಟೇಷನ್ ಮಾಡಿದ್ವಿ, ಇನ್ಸ್ಪೈಟ್ ಆಫ್ ದಟ್ ಡಿಕ್ಲೇರ್ಡ್ ಡೆಡ್ ಅಂತ ಅಷ್ಟೇ ಬರ್ದಿದ್ದಾರೆ, ಬೇರೆ ಏನೂ ಇಲ್ಲ. ಮತ್ತೆ ಅದ್ರ ಏನು ಡಿಫೆಂಡ್ ಮಾಡ್ಕೋತೀರಿ? ಏನು ಕಾಯಿಲೆ ಅಂತಲೇ ಗೊತ್ತಿಲ್ಲ, ಡೆತ್ ಡಿಕ್ಲೇರ್ ಮಾಡಿದ್ದೀರಿ. ಸೊ ಕಾಸ್ ಆಫ್ ಡೆತ್ನೂ ಗೊತ್ತಿಲ್ಲ. ಈ ಥರದ ಅವಘಡಗಳನ್ನ ನಾವೇ ಸೃಷ್ಟಿ ಮಾಡ್ಕೊಳ್ಳೋವಂಥದ್ದು. ಯಾಕಂದ್ರೆ ನಾವೇ ಕಲ್ತಿರ್ತೀವಿ, ಕಲ್ತಿರೋದನ್ನ ಪೇಷಂಟ್ ಬರ್ತಿದ್ದ ಕೂಡಲೇ ನಾವೇನು ಮಾಡ್ತೀವಿ, ಹಿಸ್ಟ್ರಿ ತಗೋತೀವಿ, ಎಕ್ಸಾಮಿನೇಷನ್ ಮಾಡ್ತೀವಿ, ಇನ್ವೆಸ್ಟಿಗೇಷನ್ಸ್ ಮಾಡ್ತೀವಿ. ಅದು ಏನೇನು ಮಾಡ್ತೀವಿ, ಮಾಡಿದ್ದನ್ನೆಲ್ಲ ಕ್ರೊನಾಲಜಿಕಲ್ ಆರ್ಡ್ರಲ್ಲಿ ಬರೆದುಬಿಟ್ರೆ ಸಾಕು, ಯು ಆರ್ ಸೇಫ್. ಆಮೇಲೆ ಕೆಲವು ಸರ್ಜರಿ ಮಾಡ್ತೀರಿ, ಗೈನಕಾಲಜಿ ಇರ್ಬೋದು, ಜನರಲ್ ಸರ್ಜರಿ ಇರ್ಬೋದು, ಬೇರೆ ಯಾವುದೇ ಸೂಪರ್ ಸ್ಪೆಷಾಲಿಟಿ ಇರ್ಬೋದು. ಅದು ಮಾಡುವಾಗ ಏನೇನು ಪ್ರೊಸೀಜರ್ಸ್ ಮಾಡಿರ್ತೀನಿ ಅನ್ನೋದನ್ನ ನೀಟಾಗಿ ನಮೂದು ಮಾಡಿದ್ರೆ ನಾಳೆ ಕೋರ್ಟ್ ಆಫ್ ಲಾ ಅಲ್ಲಿ ಎಲ್ಲಿಗಾದರೂ ಹೋಗಲಿ ನಾವು ನಮ್ಮನ್ನು ಡಿಫೆಂಡ್ ಮಾಡ್ಕೊಳ್ಳೋಕ್ಕೆ ಅನುಕೂಲ ಆಗ್ತದೆ. ಸೊ ಇಟ್ ಈಸ್ ಮೋಸ್ಟ್ ಇಂಪಾರ್ಟೆಂಟ್ ಟು ಡಾಕ್ಯುಮೆಂಟ್ ವಾಟ್ ಎವರ್ ಯು ಡೂ ಆನ್ ದ ಪೇಷಂಟ್. ಸೊ ಡಾಕ್ಯುಮೆಂಟೇ ನಿಮ್ಮನ್ನು ಕಾಪಾಡೋವಂಥದ್ದು. ಆಮೇಲೆ ಬಂದ್ಬಿಟ್ಟು ನಮಗೆ ಇನ್ಫ್ಲೂಯೆನ್ಸ್ ಮಾಡೋದು, ಪೊಲೀಸರಿಗೆ ಇನ್ಫ್ಲೂಯೆನ್ಸ್ ಮಾಡೋದು, ಕೋರ್ಟಲ್ಲಿ ಇನ್ಫ್ಲೂಯೆನ್ಸ್ ಮಾಡೋಕ್ಕೆ ಟ್ರೈ ಮಾಡೋದು, ಏನೇನೋ ಆಗ್ತದೆ. ಕನ್ಸ್ಯೂಮರ್ ಕೋರ್ಟಿಗೆ ಹೋಗ್ತದೆ, ಅಲ್ಲೆಲ್ಲ ಅವಾರ್ಡ್ ಆಗ್ತದೆ. ಸೊ ಇವಕ್ಕೆಲ್ಲ ಮೂಲ ನಾವು ಮಾಡ್ತಕ್ಕಂಥ ದಾಖಲೆ ನಮ್ಮ ರಕ್ಷಕ. ಅದನ್ನು ಅಚ್ಚುಕಟ್ಟಾಗಿ ಮಾಡಿ ಅಂತ ಹೇಳ್ಬಿಟ್ಟು ನಾನು ತಮ್ಮೆಲ್ಲರಲ್ಲೂ ಮನವಿ ಮಾಡ್ಕೋತೇನೆ. ಮತ್ತು ಅದೇ ರೀತಿ ನಮ್ಮ IMA ಇಂದ ಒಂದು ಕರ್ನಾಟಕ ಪ್ರೊಫೆಷನ್ ಪ್ರೊಟೆಕ್ಷನ್ ಸ್ಕೀಮ್ ಇದೆ. ಅದು ನಾವು 3,500 ರೂಪಾಯಿ ಕೊಟ್ಟು ರಿಜಿಸ್ಟರ್ ಆಗೋಂಥದ್ದು, ಪ್ರತಿ ವರ್ಷ 500 ರೂಪಾಯಿ ಕೊಟ್ಟು ರಿನ್ಯೂ ಮಾಡೋ ಅಂಥದ್ದು. ಇಟ್ ಕವರ್ಸ್ 1 crore rupees. ಕನ್ಸ್ಯೂಮರ್ ಕೋರ್ಟಿಂದ ಏನಾದರೂ ನಮಗೆ ಅವಾರ್ಡ್ ಆದರೆ ಅಪ್ ಟು 1 crore ಅದು ರಕ್ಷಣೆ ಕೊಡ್ತದೆ. ಅದೇ ರೀತಿ ನಿಮಗೆ ಅಡ್ವೊಕೇಟ್ ಸೇವೆಯೂ ಸಹ ಈ KBPS ವತಿಯಿಂದ ವಹಿಸ್ಕೊಡ್ತಾರೆ. ಇದೊಂದು ಉತ್ತಮವಾದ ಸ್ಕೀಮ್. ಈ ಸ್ಕೀಮನ್ನು ತಗೊಳ್ಳಿ. ನಾನು ಯಾಕೆಂದರೆ ಈ ವಿಚಾರಕ್ಕೆ ಮಾತ್ರವೇ ಸೀಮಿತ ಆಗಿ ಮಾತಾಡ್ತಿದ್ದೀನಿ. ನಾನು IMAದು ಇನ್ನೂ 2 ಸ್ಕೀಮ್ ಇದೆ, ಅದ್ರ ಬಗ್ಗೆ ಈ ವೇದಿಕೆ ಸರಿಯಲ್ಲ ಅಂದ್ಕೊಳ್ತೀನಿ. ಆದ್ರೂ ಕರ್ನಾಟಕ ಸೋಷಿಯಲ್ ಸೆಕ್ಯೂರಿಟಿ ಸ್ಕೀಮ್ ಮಾತ್ರ ತುಂಬ ಒಳ್ಳೆಯದಿದೆ. ಯಾಕೆಂದರೆ ನಮ್ಮನ್ನು ನಂಬಿರೋರು ಇವತ್ತು ಒಳ್ಳೆ ಪ್ರಾಕ್ಟೀಸ್ ಆಗ್ತಾ ಇರ್ತದೆ, ಅಥವಾ ಆಲ್ ಆಫ್ ಎ ಸಡನ್ ನಮ್ಮ ಪ್ರಾಕ್ಟೀಸ್ ನಿಂತೋಗುತ್ತೆ, ಒಂದು 5 day ಐ ಡೈ. ನನ್ನನ್ನು ನಂಬ್ಕೊಂಡಿರೋರಿಗೆ ನಾವೇನು ಮಾಡಿರೋದಿಲ್ಲ. ಸೊ ಅದಕ್ಕೆ ಅವ್ರಿಗೇನಾದರೂ ನಾವು ಬಳುವಳಿ ಕೊಟ್ಟೋಗ್ಬೇಕು ಅಂದರೆ ಈ KSS ಅಂದರೆ ಕರ್ನಾಟಕ ಸೋಷಿಯಲ್ ಸೆಕ್ಯೂರಿಟಿ ಸ್ಕೀಮಲ್ಲಿ ನಾವು ಮಾಡುತ್ತೆ. 2 ಸ್ಕೀಮ್ ಇದೆ, ಓಲ್ಡ್ ಆ್ಯಂಡ್ ಸಿಲ್ವರ್ ಜೂಬ್ಲಿ ಅಂತ. 2 ಸ್ಕೀಮಿಂದ ಸೇರಿಸಿ ನಾವು ಮರಣ ಹೊಂದಿದ್ರೆ ನಿಯರ್ಲಿ 1 crore rupees ನಮ್ಮ ಡಿಪೆಂಡೆಂಟ್ಸ್ಗೆ ನಾವು ಯಾರಿಗೆ ನಾಮಿನೇಟ್ ಮಾಡಿರ್ತೀವಿ ಅವ್ರಿಗೆ ಸಿಗ್ತದೆ. 1 ಕೋಟಿ ರೂಪಾಯಿ ಇಸ್ ನಾಟ್ ಎ ಸ್ಮಾಲ್ ಅಮೌಂಟ್ ವೆನ್ ವಿ ಡೈ ಆ್ಯಂಡ್ ಗಿವಿಂಗ್ ಗಿಫ್ಟ್ ಟು ಅವರ್ ಡಿಪೆಂಡೆಂಟ್ಸ್. ಸೊ ಇದನ್ನೊಂದು ಎಲ್ಲರೂ ಮಾಡಬೇಕು. ಮತ್ತು ಯಂಗ್ಸ್ಟರ್ಸ್ ತುಂಬ ಇದ್ದಾರೆ, ನಂಗೆ ಖುಷಿ ಆಗುತ್ತೆ ನೋಡೋಕ್ಕೆ. ಯಂಗ್ಸ್ಟರ್ಸ್ ಎಲ್ಲರೂ IMAಗೆ ಮೆಂಬರ್ಸ್ ಆಗಿ. ಆ್ಯಂಡ್ IMA ಪ್ರೆಸಿಡೆಂಟ್ ಸೆಕ್ರೆಟರಿ ಅವ್ರ ಮನವಿ, ಹೆಚ್ಚು ಯಂಗ್ಸ್ಟರ್ಸ್ನ ನಮ್ಮ ಸ್ಟ್ರೀಮ್ಗೆ ಕರ್ಕೋಬೇಕು. ಎಲ್ಲ ನಾವು ವಯಸ್ಸಾಗಿರೋರೇ ಇರ್ತೀವಿ, ನಾವೇ ಏನೋ ಮಾತಾಡ್ಕೋತೀವಿ, ಹೋಗ್ತೀವಿ. ಆದರೆ ಯಂಗ್ಸ್ಟರ್ಸ್ಗೆ IMA ಅಂದ್ರೆ ಏನು, IMA ನಮಗೆಲ್ಲ ಏನೇನು ಮಾಡ್ತದೆ, ಅದ್ರ ಬಗ್ಗೆ ಸ್ವಲ್ಪ ಅವಕಾಶಗಳು ಸಿಕ್ಕಾಗೆಲ್ಲ ಹೇಳ್ಬೇಕು. IMAಯಿಂದ ತುಂಬ ಅನುಕೂಲ ಇದೆ. ನಾವು ಮೆಡಿಕಲ್ ಸ್ಟೂಡೆಂಟ್ಸ್ ನೆಟ್ವರ್ಕ್ ಇದೆ. ಮೆಡಿಕಲ್ ಸ್ಟೂಡೆಂಟ್ಸ್ಗೆ ಏನಾದರೂ ತೊಂದರೆಗಳಾದರೆ ನಾವು ಇಂಟರ್ವ್ಯೂನ್ ಆಗ್ತಾ ಇದ್ದೀವಿ. ಮತ್ತು ಜೂನಿಯರ್ ಡಾಕ್ಟರ್ಸ್ ನೆಟ್ವರ್ಕ್ ಇದೆ. ಅಲ್ಲಿ ಜೂನಿಯರ್ ಡಾಕ್ಟರ್ಸ್ ಅಂತಂದರೆ ಇಂಟರ್ನ್ಸ್ ಇರ್ತಾರೆ, ಹೌಸ್ ಸರ್ಜನ್ಸ್ ಇರ್ತಾರೆ, ಮತ್ತು PGs ಇರ್ತಾರೆ, ಮತ್ತು ಏನು ರೆಸಿಡೆಂಟ್ಸ್ ಎಲ್ಲ ಇರ್ತಾರೆ. ಸೊ ಅವರೆಲ್ಲರೂ ನಾವು ಜೂನಿಯರ್ ಡಾಕ್ಟರ್ಸ್ ನೆಟ್ವರ್ಕಲ್ಲಿ ತಗೋತೀವಿ, ಮತ್ತು ಅವ್ರಿಗೆ ಆಗ್ತಕ್ಕಂಥ ಸಮಸ್ಯೆಗಳ ಬಗ್ಗೆ ನಾವು ಹೆಚ್ಚಿನ ಗಮನ ಕೊಡ್ತೀವಿ. ಉದಾಹರಣೆಗೊಂದು ಬೆಂಗಳೂರಿನಲ್ಲಿ ಒಂದು ಪ್ರತಿಷ್ಠಿತ ಕಾಲೇಜಿನಲ್ಲಿ ಒಬ್ಬರು ಸ್ಟಾಫ್ ಸರ್ಜರಿ ಸ್ಟೂಡೆಂಟ್ಸಿಗೆ ನಮಗೆ ಲ್ಯಾಪ್ರಾಸ್ಕೋಪ್ ಯೂನಿಟ್ ತಂದ್ಕೊಡ್ರಿ ಅಂತ ಹೇಳ್ಬಿಟ್ಟು ಪದೇ ಪದೇ ಹಿಂಸೆ ಕೊಡ್ತಾ ಇದ್ರು ಅಂತ ಹೇಳ್ಬಿಟ್ಟು ಆ ಹುಡುಗರು ನಮಗೆ ಕಂಪ್ಲೇಂಟ್ ಮಾಡಿದ್ರು. ಸೊ ನಾವು ಆ ಡೀನ್ ಜೊತೆ ಮಾತಾಡಿ ಮತ್ತು MCನವ್ರ ಜೊತೆ ಮಾತಾಡಿ ಎಲ್ಲ ಅವರಿಗೆ ಸೂಕ್ತ ಕ್ರಮ ತಗೋಬೇಕು ಅಂತ ಹೇಳ್ಬಿಟ್ಟು ತಾಕೀತು ಮಾಡಿದ್ದೀವಿ. ಅದೇ ರೀತಿ ಕ್ರಮ ಜರುಗ್ತಾ ಇದೆ. ಸೊ ನಾನು ಉದಾಹರಣೆಗೆ ಹೇಳ್ತಾ ಇರೋದು, IMA ಜೂನಿಯರ್ಸ್ಗೂ ಸಹ ನಾವು ಇದ್ದೀವಿ, ಅವ್ರಿಗೂ ಸೇವೆ ಮಾಡ್ತಾ ಇದ್ದೀವಿ ಅಂತ ಹೇಳಲಿಕ್ಕೆ ಇಷ್ಟಪಡ್ತೀನಿ. ಆಮೇಲೆ ಇತ್ತೀಚೆಗೆ ನಾವು ಒಂದು ಸಾಧನೆ ಮಾಡಿದ್ವಿ. ತಮಗೆಲ್ಲ ಗೊತ್ತಿರೋ ಹಾಗೆ ಫೈರ್ ಸೇಫ್ಟಿ ಬಗ್ಗೆ NOC ತಗೊಳ್ಳೋದು ತುಂಬ ಕಷ್ಟ ಆಗ್ತಾ ಇತ್ತು, ಫೀಸ್ ಎಲ್ಲ ತುಂಬ ಹೆಚ್ಚಾಗಿರ್ತಾ ಇತ್ತು. ಅದನ್ನೆಲ್ಲ ಸರಳೀಕರಣಗೊಳಿಸಿ, ಮತ್ತು ತಮಗೆಲ್ಲ ಗೊತ್ತಿರಬೇಕಿತ್ತು, ಒಂದು ಆಸ್ಪತ್ರೆ ಅಂದರೆ ಒಂದು ಫೈರ್ ಎಂಜಿನ್ ಓಡಾಡಲಿಕ್ಕೆ ಜಾಗ, ಮತ್ತು ಸಂಪಲ್ಲಿ ಒಂದು 2 ಲಕ್ಷ ಲೀಟ್ರ್ ನೀರು ಹಿಡಿಯೋಂಥ ಸಂಪು, 2 ಲಕ್ಷ ಲೀಟ್ರ್ ನೀರು ಹಿಡಿಯೋಂಥ ಓವರ್ ಹೆಡ್ ಟ್ಯಾಂಕ್ ಇರಬೇಕು, ಮತ್ತು ಹೋಸ್ ಪಂಪ್ಗಳು ಎಲ್ಲ ಕಡೆ ಇರಬೇಕು. ಆ ಥರ ಎಲ್ಲ ತುಂಬಷ್ಟು ರೆಸ್ಟ್ರಿಕ್ಷನ್ಸ್ ಇತ್ತು, ತುಂಬ ಕಠಿಣವಾದಂಥ ನಿಯಮಗಳಿತ್ತು. ಆ ನಿಯಮಗಳನ್ನೆಲ್ಲ ಸರಳೀಕರಣ ಮಾಡಿಸಿ ನಾವೊಂದು ಸರ್ಕಾರದಿಂದ ಹೋಮ್ ಡಿಪಾರ್ಟ್ಮೆಂಟ್ನ ಒಂದು ಆದೇಶನ ಮಾಡಿಸ್ಲಿಕ್ಕೆ ಯಶಸ್ವಿಯಾದಿ. ಈ ಯಶಸ್ವಿ ಆಗಲಿಕ್ಕೆ ಕೈ ಜೋಡಿಸಿದಂಥ ಎಲ್ಲ ನನ್ನ ಸಹೋದ್ಯೋಗಿಗಳು ಅಂದರೆ IMA ಸದಸ್ಯರುಗಳು, ಹಿರಿಯರು ಕಿರಿಯರು ಎಲ್ಲರೂ ಕೈ ಜೋಡಿಸಿದ್ದಾರೆ. ಅವರೆಲ್ಲರಿಗೂ ನಾನು ಧನ್ಯವಾದಗಳನ್ನು ಅರ್ಪಿಸ್ತೇನೆ. ಮತ್ತು ಇದರಿಂದ ಸಾಕಷ್ಟು ಆಸ್ಪತ್ರೆ ಓನರ್ಸ್ಗೆ, ಎಸ್ಪೆಷಲಿ ಕ್ಲಿನಿಕ್ಕು ಪಾಲಿಕ್ಲಿನಿಕ್ ಅವ್ರಿಗಂತೂ ತುಂಬಾ ಅನುಕೂಲ ಆಗ್ತದೆ ಇದರಿಂದ. ಸೊ ಈ ರೀತಿ ನಾವು IMA ಕಡೆಯಿಂದ ಸಾಕಷ್ಟು ಹೋರಾಟಗಳನ್ನ ಮಾಡಿಕೊಂಡು ನಿಮ್ಮ ಸೇವೆಗಾಗಿ ನಾವಿರ್ತೀವಿ. ಅದೇ ರೀತಿ ನೀವು ಸಹ IMA ಏನು ಮಾಡೋದಂತ ಕೇಳೋಕ್ಕಿಂತ ಹೆಚ್ಚಾಗಿ IMA ನನ್ನ ಕೊಡುಗೆ ಏನು ಅಂತಲೂ ನೀವು ಯೋಚಿಸಬೇಕಾಗ್ತದೆ. ಯೋಚಿಸಿ ಹೆಚ್ಚಿನ ಸದಸ್ಯರನ್ನ ಈ ಒಂದು ಸ್ಟ್ರೀಮ್ಗೆ ತಂದರೆ, ಯಾಕೆಂದರೆ ನಾನು ಹೇಳ್ತಿರೋದು ನಮ್ಮ ಕರ್ನಾಟಕ ಮೆಡಿಕಲ್ ಕೌನ್ಸಿಲಲ್ಲಿ ರಿಜಿಸ್ಟರ್ ಆಗಿರ್ತಕ್ಕಂಥ ಪ್ರಾಕ್ಟಿಷನರ್ಸ್ ಸಂಖ್ಯೆ 1,92,000 ಇದೆ. ಆದರೆ ನಮ್ಮ IMAಗೆ ರಿಜಿಸ್ಟರ್ ಆಗಿರ್ತಕ್ಕಂಥ ವೈದ್ಯರ ಸಂಖ್ಯೆ ಕೇವಲ 35,000 ಇದೆ. ಸೊ ತುಂಬ ಅಜಗಜಾಂತರ ಇದೆ. ಅದಕ್ಕೆ ಎಲ್ಲರೂ ಸದಸ್ಯರನ್ನ ಹೆಚ್ಚಿನದಾಗಿ ಮಾಡಿಸ್ಬೇಕು. ನಮ್ಮ ಸದಸ್ಯತ್ವದಲ್ಲೇ ನಮ್ಮ ಶಕ್ತಿ ಅಡಗಿದೆ. ನಾವು ಸರ್ಕಾರದ ಮುಂದೆ ಏನಾದರೂ ಬೇಡಿಕೆ ತಗೊಂಡು ಹೋಗ್ಬೇಕು ಅಂತಂದ್ರೆ ನಿಮ್ಮ ಸ್ಟ್ರೆಂತ್ ಎಷ್ಟಿದೆ ಅಂತ ನೋಡ್ತಾರೆ. ಸೊ ನಾಳೆ ದಿವಸ ನಮ್ಮ ಸ್ಟ್ರೆಂತ್ ಜಾಸ್ತಿ ಇದೆ ಅಂತ ಹೇಳ್ಬಿಟ್ಟು ನಾವು ತೋರಿಸಿದಾಗ, ಅಯ್ಯೋ ಇವ್ರದ್ದು ದೊಡ್ಡ ಸಂಘ ಇದೆಯಪ್ಪ, ಇವ್ರಿಗೆ ಏನಾದರೂ ಬೇಡಿಕೆಗಳು ಬಂದರೆ ತಕ್ಷಣ ನಾವು ಸೆಟ್ಲ್ ಮಾಡಬೇಕು ಅಂತ ಹೇಳ್ಬಿಟ್ಟು ಸರ್ಕಾರಕ್ಕೆ ಮನಸ್ಸಿಗೆ ಬರ್ತದೆ. ಯಾರೇ ಇರಲಿ ಅಧಿಕಾರದಲ್ಲಿ ಅವರು ಯೋಚನೆ ಮಾಡ್ತಾರೆ, ಇಂಥ ದೊಡ್ಡ ಸಂಘಟನೆನ ಎದುರಾಕಬಾರ್ದು ಅಂತ. ಸೊ ಆ ನಿಟ್ಟಿನಲ್ಲಿ ಎಲ್ಲರೂ ಹೆಚ್ಚಿನ ಸಂಖ್ಯೆಯಲ್ಲಿ ನಮ್ಮ ಭಾರತೀಯ ವೈದ್ಯಕೀಯ ಸಂಘಕ್ಕೆ ಸದಸ್ಯರನ್ನಾಗಿ ಮಾಡಿಸಿ, ಮತ್ತೆ ಎಲ್ಲ ಸ್ಕೀಮ್ಗಳಲ್ಲೂ ನೀವು ತೊಡಗಿಸ್ಕೊಂಡ್ರೆ ತುಂಬ ಅನುಕೂಲ ಆಗುತ್ತೆ. ಕೆಲವರೆಲ್ಲ ಹೇಳ್ತಾರೆ, ನೀವು ಪ್ರೀಮಿಯಂ ಎಲ್ಲ ತುಂಬ ಜಾಸ್ತಿ ತಗೋತೀರಿ, ಕೆಲವು ಸಾರಿ 20,000 ಎಲ್ಲ ಬರ್ತದೆ, ಅಷ್ಟೊಂದೆಲ್ಲ ಯಾಕೆ ಕಟ್ಟಬೇಕು, ನಾನು ಸತ್ತರೆ ತಾನೇ ನಮ್ಮ ಮನೆಯವ್ರಿಗೆ ತಾನೇ ಬೆನಿಫಿಟ್ ಆಗೋದು, ನನಗೇನು ಬೆನಿಫಿಟ್ ಆಗಲ್ಲಲ್ಲ, ಯಾಕೆ ಈ ಸ್ಕೀಮ್ಗಳಿಗೆಲ್ಲ ತೊಡಗಿಸ್ಕೋಬೇಕು ಅಂತ ಕೇಳೋರು ಇದ್ದಾರೆ. ಆದರೆ ಇದೇನು ಗೊತ್ತಾ, ಮ್ಯೂಚುವಲ್ ಬೆನಿಫಿಟ್ ಬರೋ ಅಂಥದ್ದು. ನಾವೆಲ್ಲರೂ ಸೇರಿ ನಮ್ಮ ಸಂಘದ ಸದಸ್ಯರ ಕುಟುಂಬಕ್ಕೆ ಅನುಕೂಲ ಮಾಡಿಕೊಡ್ತಂಥದ್ದು. ಸೊ ಆ ನಿಟ್ಟಿನಲ್ಲಿ ಎಲ್ಲರೂ ಕೈ ಜೋಡಿಸಿ ಒಬ್ಬರಿಲ್ಲ ಒಬ್ಬರ ಕುಟುಂಬಕ್ಕೆ ಸಹಾಯ ಹಸ್ತ ನೀಡೋಣ ಅಂತ ಹೇಳಿ ಆಶಿಸ್ತಾ, ಈ ಒಂದು CME ತುಂಬ ಅಚ್ಚುಕಟ್ಟಾಗಿ ಮೂಡಿ ಬರಲಿ. ಒಳ್ಳೊಳ್ಳೆ ಸ್ಪೀಕರ್ಸ್ ಇದ್ದಾರೆ ಇನ್ನೂ ಸಹ, ಅವರೆಲ್ಲರೂ ಮಾತಾಡಲಿ. ನಮಗೆ ಇಷ್ಟೊಂದು ಮಾತಾಡಲಿಕ್ಕೆ ಅವಕಾಶ ಮಾಡಿ. ವಿನಯ್ ಕುಮಾರ್ ಇದ್ದಾರೆ, ಅವರು ತುಂಬ ಮೊನ್ನೆ ಒಂದು CME ಮಾಡಿದ್ವಿ ಆನ್ಲೈನ್, ತುಂಬ ಜನ ರಿಜಿಸ್ಟರ್ ಆಗಿದ್ರು. ನಮ್ಗೆ ಯೂಶಲಿ ಆನ್ಲೈನ್ CME ಅಂದರೆ ಬಹಳ ಕಡಿಮೆ.
Blessing of His Holiness, first of all, I welcome all the dignitaries on the dais on behalf of Basaveshwara Medical College and Hospital. It is indeed a great pleasure to invite all of you to the Basaveshwara Medical College for this newly constructed auditorium which has recently been done, and I can able to say that this is the second time we are utilizing the IMA for this auditorium purpose. So definitely I welcome Dr. Veerbhadraya sir, the President IMA, and Dr. Harish sir, and all the dignitaries, the IMA bearers of the Chitradurga, the doctors, my colleagues, the PG students, and all the things, and all the IMA members who have travelled all across from Karnataka over here. It is indeed this CME is indeed a need of the hour, because so many aspects we have to be enlightened, because we are facing so many medical legal aspects day to day. In this sense, it becomes an eye-opener for us to have so many thoughts and other things which we can inculcate in our practice, so that our practice becomes hassle-free and we can concentrate on our practice rather than other things which will bother us from the people who are the mediators, who can force us to do many things. In this sense, definitely it is a welcome move from the Society of Obstetrics, who have taken the lead from organizing this one and choosing Basaveshwara as a part of it. I really glad that in henceforth also, we will be definitely a part of this IMA activities and in future conference also. It's already been late. It is already so many speakers are waiting. In that sense, I don't want to take much time. So I wish this conference a grand success. Thank you.
Of His Holiness, respected Dr. Virubhadraya, President IMA, Dr. Harish, respected dignitaries on the dais, dear friends. There's a need of the hour is medical legal aspect in medical field. Many of you don't know probably this Consumer Act came into being in I think UK because at some point of time there was a lot of discordance between the care given by doctors as well as what the patient was suffering from. At any time, the state or the court step in only when there is lack of organization among ourselves. It is sad to say that the least amount of unity is among the doctors. That is the reason for the state we are in now. What court said before this Consumer Act came into being was, heal thyself. That means at some point of time there was no inherent rules among the doctor profession. That is why Consumer Court came into being, and medical fraternity was inducted. We also became consumer providers. That is, we were classified as providing some, like a shopkeeper selling some goods. We were classified as such. As doctors, the main person who is going to instigate in any of this medical legal aspect is one of our colleagues itself. Unless one of our colleagues points out to a deficiency, no court can come to know, nobody will come to know that the mistake has been committed. So, the main person, instigating person is a colleague among us only. So we all need to become united, at least now, so that we don't face more cases in future, as well as also there is a lot of competition among ourselves, which is going to make our colleagues itself to voice their voice against us itself. So all of us have to be very good in our subject, as well as to implement what we learn in an ethical manner. Without being ethical, we are not going to have a day's rest or peaceful sleep. In addition, this medical legal aspect He is going to stay as long as humanity is there, as long as medical profession is there. So to prevent ourselves, especially the new doctors who are coming, any patient that comes, we have to put in a provisional diagnosis and treat as per the provisional diagnosis. We cannot put a blanket treatment for anybody. That is very important. And ultimately at the time of discharge, we have to go for a definitive diagnosis before giving discharge. And when we give a diagnosis, it should be as per the investigations we have done. Nowadays, most of you must have noticed that Ayushman cases, they are being rejected because whatever provisional diagnosis we are putting for any case, it is not coinciding with the investigations we have asked for. So we cannot just put any provisional diagnosis and put treatment. In that aspect also we have to be very careful. We have a lot of speakers ahead of me now, so I would like to conclude my speech with these few words. Thank you one and all.
Good afternoon everyone. It's indeed a great honor to stand over here and present my vote of thanks for all the dignitaries who have come over here and the delegates and staff members for attending this CME. With great respect, I would first like to thank the Administrative Committee of SJM Vidyapeetham, Shri Basakumar Swamiji, Shri Kalsat sir, Dr. P.S. Shankar sir and Dr. S.N. Chandrasekhar sir for their invaluable support and institutional support given for this CME. I would like to sincerely extend my thanks to Dr. Veerbhadraya sir, President IME Karnataka, for graciously being present over here and for his inspiring leadership and constant guidance to the medical fraternity. I request Dr. Prashant sir to kindly provide the token of appreciation to Dr. Veerbhadraya sir. For his unwavering administrative support and for providing a strong academic platform for this program. A warm thanks to Dr. Rajesh sir, Medical Superintendent, Basaveshwara Medical College, for his cooperation and support in the smooth sir. My sincere thanks to Dr. Palakshay sir, President, IME Chitradurga, for his unconditional support. My thanks to Dr. Prahlad sir, Secretary, IME Chitradurga. I extend my thanks to Dr. Narayan sir for his cooperation during this My sincere sir and head of the department, Basaveshwara Medical College, Dr. OBG, for her unconditional support for this CME. Thank you for being over here.
We also appreciate the presence of the past president of IMA KSP, Dr. Madhusudan Karigandu, the chairman of IMA KPPs.
I kindly thank our CSOG Secretary Rashmi ma'am for organizing and helping for the CME.
ಹೇಳಲಿಕ್ಕೆ ಬರ್ತಿದ್ದೆ, ತುಮಕೂರಿನಲ್ಲಿ ಹಾಸ್ಪಿಟಲ್ ಬೋರ್ಡ್ ಆಫ್ ಇಂಡಿಯಾದೊಂದು ಕಾನ್ಫರೆನ್ಸ್ ಮಾಡ್ತಾ ಇದ್ದೀವಿ. ಆ ಕಾನ್ಫರೆನ್ಸ್ಗೆ ಹಾಸ್ಪಿಟಲ್ನ ಓನರ್ಸ್ ಎಲ್ಲರೂ ರಿಜಿಸ್ಟರ್ ಮಾಡಬೇಕು ಅಂತ ಹೇಳ್ಬಿಟ್ಟು ರಿಕ್ವೆಸ್ಟ್ ಮಾಡ್ತಿದ್ದೆ.
Whose behind the scenes effect are of invaluable thing. So and they have struggled a lot to ensure the smooth conduct of this program. Thank you one and all for attending this CME, and I wish the CME a very grand success. And
good morning to everybody. It will not fetch you mercy. So being aware of whatever laws are governing to our practice is quite essential. It is as good as what we study in our curriculum to treat the patients. So my first and foremost request to each and everyone, spend some time out of your busy schedules to read some part of the laws which govern to your practice. Whether it is Private Medical Establishment Act, whether it is PCPNDT, every law is available online now. At least read and form some gist of those laws, because in India the laws are made in such a way that the lawmakers read between the lines, between the words. You might not understand that. Can and shall, these are two words, meaning is same, but when it comes to court of law, it will be addressed in a different manner. So the laws are in such a way that I don't know, our Deputy Director Gynaecology is not there, so I can take the liberty of saying laws are made in such a way that there are loopholes for the law enforcer to take action against us, and there are, in the same law or same act, there are loopholes for us to get out of it. So unless you go through these laws, I might speak here for 20 minutes and go away, but how much people will grasp out of it and how much you will be benefited out of it, it hardly matters. So my humble request at the outset of my talk is, take some time, at least once in a week, go through different laws which are available online. Make those list of laws. You will be surprised. I was called to talk in Mumbai on various laws pertaining to healthcare. Even I thought initially when I came into IMA, Streamline and all, that probably around 8 to 10 laws are there which are governing to our practices. But when I took that topic as a speaker and did some research, to my surprise, and you will also be surprised, that there are 110 laws governing our practice. Whether it is a small law or a big law, whether it is enforced or not enforced, laws are there. But, so my humble request is, go through, at least make a list. If you are a specialist of some specialty, make a list on what are the laws governing to you. Go through them. Life is still long. Every week if you read one small sections of each law, you will be thorough in that. So I will be speaking here today on the Karnataka Private Medical Establishment Act and the recent amendments to that. And I know, can I ask how many of you have your own clinics or hospitals or diagnostic centers here? Okay, nice. So, how many of you have read KPMA Act out of all those? Okay, so you can see the discrepancies here. There are a lot of people who are registered under KPMA, but we don't know about the law. So, my humble request again, go through that law. So, who must register? Any person who wishes to have a practice outside, not in an institute, who wants to run a clinic, polyclinic, dental clinic, or a hospital or a diagnostic center, they must have a KPMA registration with the KPMA authority. Who is the KPMA authority? You all know, it is the local and district level, it is the DHO, and the DC is the signing authority. So all these establishments
like all private establishments without exception, even the medical colleges, the teaching hospitals, small clinics, everybody come in the preview of KPMA. There are different levels of mentioned in the recent KPMA. Based upon your type of practice, you will have to register under that level. The fees for different levels is also different. So don't think of just difference of 10,000 or 20,000 and say, I am having a super specialty, I operate super specialty surgeries in my hospital, but I will take level 2 permission, because the fees is just 10,000 difference or 20,000 difference. Please don't do that, because tomorrow if any untoward incident happens and you are questioned, then they will say you have taken level 2 permission, but you are practicing super specialty, so it is not allowed. So go through these level of hospitals and take appropriate permissions as per the KPMA rules. Again, in hospitals, they are divided as per the beds, as per the specialty, whether it is single specialty or there are 2-3 specialties of secondary care, or it is a tertiary level care hospital. Again, tertiary level care hospital with teaching and non-teaching, there are different classifications. Certain special situations. Earlier days it was all manual applications. Now after Dr. Vivek Dore took over as KPMA in charge, a lot of changes have been brought, useful for the doctors. Application, whether it is the new registration or for the renewal, it is all online now. You need not go to the DH office, everything has to be uploaded online, and even the payment can be done through online. And once you have done the payment, you keep the receipt with you, wait for the response of the KPMA officials. You need not run around the DH office to get these certificates. A lot of people do that. I have applied 1 month over, I have not got the certificate. Let me go and ask what happened. If you go there, then they will ask a number of things. You apply, whatever is necessary you upload, unless they write you back saying that you have not complied with this, like Pollution Control Board, this is not approved certificate. They should write back to you. Once they write back to you, you have to reply to them that I'll abide by this, I'll need some time. Then again you will have 3 months to abide by that. So don't sit silent when you receive a notice. You reply back saying that I need some time. That is a good communication which you maintain with the officials. Renewal is also online now. Lot of things have been changed since earlier. Earlier, every detail which we had to give for initial new registrations were mandatory for renewals also. With the help of IMA, lot of efforts of IMA, Karnataka State Branch, significant changes have been done for KPMA renewals. That is, all these compulsory certifications like trade license, other things, they are not being made mandatory now. The only thing which is being mandatory now is the fire thing, and even that has been resolved now because fire thing is still mandatory, but the process of getting these fire clearances, everything, fire safety norms getting implemented has been reduced. In case of change of, lot of people have this confusion. Today I have a clinic at one address, tomorrow I am shifting to a new address because the rent is high or whatever reasons. So my same name I can continue, the same number I can continue. No, that rule is, that provision is not there in KPMA. The moment you shift from this door to next door, you will have to apply for a new registration. Though the address might be same, just the number of the rented premises, say it is 21 is your clinic number, the rented premises number, you shift to 22. The next door clinic only you are shifting, still you will have to take a new registration. You cannot change just like that. Or you have changed the name, again you will have to do a new registration. Though you are the same doctor, KPMA registration has to be a new one. What are the prerequisites? Everybody know, it should have a hygienic and suitable premises, adequate space for service offered, qualified and registered doctors. This point, qualified and registered doctors, this has come up in a big way in the recent amendments that even hiring unqualified staff or doctors is a punishable offence under KPMA now. After the recent 2024 amendments, 25 amendments, which was recently passed in Belgaum Assembly, employing unqualified staff is a punishable offence. We are trying to get justifications from the government, but the Act has been passed. The rules and regulations are due to come. Necessary equipment and infrastructure, compliance with prescribed standards, valid provisional registration on EDAR, that is the online portal. Various boards are supposed to be displayed which are mandatory. One is the blue and green boards. Blue is for the allopathy practitioners and green is for Ayush practitioners. There is a standard format under which it has to be prescribed. Everything is circulated on WhatsApp. Most of you might be aware of that, what is the standard. Earlier it was one size of board for irrespective of the size of the hospitals. Now after our request which was given to the board, KPMA officials, they have changed. For clinics it is different size and for hospitals it is different size. This has been made mandatory. The first thing any official comes for inspection, they will see is this board. They will understand whether this is an allopathy establishment or an Ayush establishment. This is helpful for even the patients to identify whether it is Ayurvedic or allopathy. Display of hospital charges. This is again a mandatory thing which is very much required in every hospital or a clinic. Many of the hospitals, bigger hospitals may say, how can I display? My list of procedures, list of charges are too large. Whole of my reception area will be filled with only charges. You can simplify it in a way that you display only your OPD charges, the basic tests which are done regularly under your lab, basic investigation of imaging, and you can mention, you need not mention for appendectomy, lap appendectomy, my charge is this much, or a range from this much to this much. You need not mention. You mention the ward charges, you mention your OPD charges, you mention our charges of your OT. So that is one loophole again, where you can bill accordingly as per the patient demands. Say, suppose I say a patient of 20,000 is my bill for lap appendectomy. Tomorrow, for some reason, the bill goes up for 35,000. The patient will ask, you are displayed as 20,000 and why you have billed me 35,000? So to be safe, mention your OT charges not as a package. Nowhere it mentioned in under KPMA law that you should mention packages. It says you have to mention your charges. What the charges are, your OT per hour charges you define and display it. So some patients might require 2 hours of your OT. Some patients might get only 15 minutes of your OT. So depending upon that, you can bill your patients. And in the court of law also it is accepted. Display of certificates. All the necessary certifications like Pollution Control Board, KPMA, your registration, individual KMC registrations, all have to be displayed on your quite visible areas like reception area or something. Why it is essential is your KMC registration has a QR code. Anybody coming to your center scans the QR code, will have the link with the KMC server where your degree and other details are updated, whether it is renewed, not renewed, whether your degree is valid or not valid. Everything is there on that. Similar way, even the KPMA also are introducing a QR code where scanning can be done and all the facilities in your hospital will be displayed. I forgot to mention about the charges. You need not display every charge on that, but you should have a booklet or a soft copy. If demanded, you should be able to give that charge list to anybody who is demanding. Even that clause is there under KPMA Act. And the same rates have to be uploaded to KPMA portal as well. And it need not be that your renewal of KPMA happens once in 5 years and you have to change your charges once in 5 years. No. In my hospital, every year the charges are revised based on whatever is needed. And whenever you change the rates, your display board has to be changed and your online, whatever you have uploaded while you are renewing, has to be uploaded on and off whenever is needed. And any new consultant getting added to your hospital, you can upload his details on that portal. That provision is given under the KPMA portal. Then the last one, display of internal grievance committee. What is this? How many of you or hospitals have got NABH accreditation? At least few of them. If you have gone through NABH accreditation, this you will be aware, because even in an NABH they say before any patient complains to next appellate authority like DC or the district level or anybody, you should have your internal grievance mechanism. Normally in a single owner hospitals, they don't follow that, because anything happens, the patient comes to the owner only. But if you see, I have displayed one of my grievance boards, which is displayed in every floor of the building, and I have put my phone number also. Many of us feel that giving phone numbers to patients, they will trouble us. Believe me, this board with my personal phone number I have displayed, and probably I will get one call related to grievance in once in a year maximum. Otherwise, nobody calls me. So if you define that clearly, if you have this problem, if you are not attended within 10 minutes, whom to approach? If you are not attended within 20 minutes, whom to approach? If you are not attended within 30 minutes, whom to approach? People are well educated now, they know to read, they will approach the same person. So the escalation is there, and these things don't go to the higher authority unless you have your own internal mechanism to solve these problems. So this is very essential, you people can follow that, and that is even in KPMA Act also. It is clearly mentioned that before coming to the district grievance committee, they should have approached the internal grievance committee. That clause is mentioned in KPMA. Recent provisions, that is provisional registration. This is just passed in assembly. Still rules and regulations are due to be formed, and we have requested the health minister to include us in forming these rules and regulations, so that lot of discrepancies are there in the old act and the new amendments. Like they have introduced something called as provisional registration. This thing came up only because we had requested that a doctor takes up a rental premises or constructs a hospital, and till the registration he cannot see any patients. Sometime getting a registration might take 1 month, 2 months. Till that time he has to pay his employees, he has to pay the rent of the premises, he has to pay the electricity. All this was causing a lot of problem. So we gave a request that we should come up with something called as provisional registration and give us some time so that we continue practicing. But all of a sudden some new things have come up in these amendments, which we have raised our voices to the minister as well as the officials, and probably these will be rectified when we form the rules and regulations for the new KPMA. In this they have included as provisional registration. Once you establish your new setup, you give an application with all the necessary documents with your registration certificate of KMC also. Based on that, within 10 days they will give you a provisional registration. Following that, you will have 6 months time to fulfill all the necessary other documents like pollution control board, fire and other things, so that you can have a breathing space of 6 months to comply with those certifications and submit it to the authorities. Once you submit all the documents, you will be given a permanent registration. That is again valid for 5 years. Suppose in 6 months you don't fulfill all those, automatically your provisional registration stands cancelled, and that list of cancelled registrations will be displayed on all the portals and the newspaper. This is a new thing which has come up. Still rules and regulations are due to come. Permanent registration and approval timeline. Applications under section 5C, authority to decide within 90 days. Earlier amendments, it was 90 days. So once you apply online, the DHO or the THO had to come inspect your center and then approve your KPMA renewal. If they don't do so within 90 days, it was called as deemed approved. So they had to issue you a certificate. Registration valid for 5 years, and this one sentence has been added in the new amendment, where it is not clear whether it is for the new registrations or whether it is for the renewals. So that clarity we have asked from the government. Probably what they meant was for renewals, those hospitals which are having different types of accreditations, whether it is ISO, NQAS or NABL, such type of establishments qualify for automatic renewals without any inspection or without any much documentation. Again, deemed approved, as I told, doctors must actively track timelines. This is very important points. How many of you are aware of your expiry date of your KPMA, those who are having your establishments here? How many of you have seen? So it is very essential. Those who have not seen, please go back today and check when is your expiry, because the moment today is your expiry and tomorrow you go to renew it, it is not possible. It is again a new registration which has to happen, and you will have to pay double the fees. All the documentation is as good as a new registration. Apart from all this, a new KPMA number is given to you. Suppose you are registered with some insurance companies or government schemes where you are given your KPMA registration certificate and number. All those MOUs have to be changed because the earlier MOU doesn't stand good, because your number of registration certificate changes. So take care that you know the expiry date, and well before your expiry, say at least 3 months before your expiry, you are eligible to apply for your renewals. Again, same, apply 90 days before the expiry, renewal validity is 5 years. Okay. Punishments. What are the punishments and penalties? Running without registration is an offence and can amount to immediate closure. Employing unqualified doctors or staff is punishable. Imprisonment up to 3 years, fine up to 1 lakh or both. Applies to owner, manager and person in charge. Last 2 slides. Again, grievance redressal authority. Every district should have a grievance redressal authority where there is one IMA member as a representative. The term is 2 years. And one member from the Private Medical Establishment Association, and one woman member of 10 years experience in medical background. She can be a doctor or non-doctor. So take care that you approach your DHO, who is the member secretary of this committee, and represent one of your amongst you as a committee member. And whoever goes to this committee, please take care that it should not be just for the namesake that I am part of grievance committee. They should take active part in these committees meeting and address the problems of the doctors. One last point I would like to mention here: whenever there is a grievance or whenever there is a violence or there is a mishap in the hospitals, most of us forget that no authority can take away your medical documents then and there. You have sufficient time of 72 hours to hand over these documents, and that too on a written request from the authority. Whether it is police, whether it is court, whether it is the grievance committee, they cannot seize your documents. And the practical issues with this, we have already explained, because this point has been added in the new amendments that the DHO or the inspecting member can seize your documents. This we have given n number of examples that suppose there is an on-table death, you have resuscitated everything and the galata starts outside. During that period, you have not written any of your OT notes, you have not written any of your resuscitation notes. Somebody comes and takes away your document. That becomes a legal document in court of law, and they might say, you have not done the surgery, you have not done anything, you have not done any resuscitative measures because it is not written. Still, you can justify yourself saying, I was in OT, after that we were supposed to write. You can justify, but document is document. So, whenever you are requested to give the documents, take some time, cross-check your documents and then hand over to the appropriate authority whoever has demanded. And only if it is an official authority like police, court or the DH office, you are supposed to give the documents of any patient. Apart from that, if anybody comes, like insurance company comes, they say we are investing on that one case, I want this case paper of this patient. Don't give unless the consent of the patient is there. Be very careful. The patient can sue on you that you have breached the confidentiality of the patient. Whatever, simple case, not only related to HIV or any other things, any simple case also, if you give the case papers without the consent of the patient, you are liable to be sued. Key take-home messages are: registration under KPM is mandatory, know your timelines, prevention is better than closure. Provisional registration is not deemed approval as of now, but there can be some changes in that. Renew on time, maintain documentation. Understanding the law reduces panic and protect practice. There is a new, just 2 days back, there is a new notification which has come. Every act, if you go through, there is a last one paragraph saying the state can make certain rules and regulations or make some changes which are governed as per this act. This statement is there in most of the acts or laws. This is to safeguard themselves, one, and make necessary notifications and rules pertaining to this. If there is any omission or deletion within the act, that will need an amendment. See, for example, this, they have clearly in exercise of powers conferred 11B of Karnataka, that 11B itself says that they can make some rules and regulations pertaining to that act. So as per that, recently because of the lot of menace of snake bites and dog bites, they have brought this as a rule. So if you receive any, this has come as a rule now under KPM. If any clinic or hospitals receive a snake bite or a dog bite case, you are supposed to give the first aid. You cannot just say, go away, go to a government hospital, go to this hospital. You cannot say. The basic first aid has to be given. This has come as a rule in KPM now. So this is the recent no. And keep a watch on recent updates on whatever KPMA brings in. A lot of things are coming up. Keep an update. Nowadays communication has become very easy. A lot of WhatsApp forwards are there. And whatever comes, please don't believe it. Authenticate it. Do some homework. If you are not understanding or well versed, there are a lot of people to help you. So you can contact any one of us. We will be able to guide you. So I know a lot of people will have questions about KPMA and practice laws. So the session is open. You can ask questions, or you can mail me, or you can send me a message also. I'll be able to help you out. One last thing, as our IMA state president was saying, it is an honor for us as a state to host the national conference for Hospital Board of India. That is an IMA wing, where various aspects of hospitals are dealt with. I was part of it for almost 3-4 years. Lot of good activities. There are certain laws which are formed to the hospitals in the center, like pollution control was a central act. KPMA is a state act. So the Hospital Board of India looks into all these matters as a central body, and in this conference we will have both our state, like KPMA will also be there, then labor laws will be there. All these are discussed in this conference. It will be a very enlightening conference. We are getting speakers from outside the state as well as within the state. It will be a 2-day program, lot of panel discussions. IMA Tumkur is taking a lot of pain to organize it in a very beautiful way, and I request a lot of people to take part. It is not far away from your place. So take part in this conference, register as large as possible. This is the Google form for registration. You can scan, it will be circulated to you also. Individual members, those who are having clinics also can register. Probably shortly they will come out with that also, if you are interested. Thank you. And I thank once again the IMA Chitradurga and OBG Association for giving me this opportunity. Thank you.
Now I request Dr. Geeta ma'am and Dr. Rashmi ma'am.
Thank you so much once again to the speaker and chairpersons on dais. Now, moving on to the next session, it's going to be medical certificate and medical negligence. And this session is going to be chaired by Dr. Malingappa sir, Dr. Manjunath sir, and Dr. Rudraya sir, Department of Surgery, Unit Chief, Basaveshwara Medical College and Hospital. And the speaker for this session is going to be Dr. Sudesh Bhagavat sir.
With your permission, can I start? Okay, now brought the body back to the hospital, kept the body in front of the hospital, and created a mess, and forced the police to make an FIR. And imagine, he's a politician, and the police almost went to arrest her to that level, and finally, unfortunately, Archana committed suicide. And this can happen to anybody. Anyhow, the second session discussed about the Jacob Matthew versus State of Union of India. That is very clear. If there is a rash and negligent act causing a death of a person, then the police cannot take the case directly. They have to investigate, take the dead body and form the post-mortem. They have to get it post-mortem done. They have to get an opinion from the other doctor or maybe the board regarding whether there is a prima facie or case of negligence is there. Then only they can file an FIR. They can file an FIR. They cannot arrest the doctor unless they believe that this doctor is going to escape. Then only they can arrest. So this has been clearly laid out. But unfortunately, if you do not know the criminal negligence, then it will happen. So this is the suicide note written by our doctor. And she has written like this: I love my husband and children very much. Please do not trouble my husband and children after my death. I did not commit any mistake and did not kill anyone. PPH is a severe complication. Stop harassing doctor. My death may prove innocence. Don't harass innocent doctor, please. Please don't let my kids feel the absence of their mother. So these are the words written by her. Imagine for a moment, keep this case aside. Tomorrow in Chitradurga, a newspaper makes a headline: a lady doctor killed the mother. And even in the court of law, the lawyer will tell the judge, they will utilize this. Nodi sir, the doctor Helmoglu, Oblu Taina Palema. Mogunu Soto sir, Mogusan Kudu sir. Adu Nimogune Budu Saratan. Judges will pay us, sir, Momugu Budu Saratan. See, once you raise emotion in the population or in the judge, you will lose the case. The emotions rule, not the logic. So invariably, the maximum cases are against gynecologists because they deal with two life, mother and the child. And there is high emotions involved because pregnant woman, newborn child. So unfortunately, they will be at the victim of abuse. So this is common. So why I am telling you about this is because whenever there is a case against a gynecologist or any doctor, it can be physical abuse, verbal abuse, economical abuse, they will start fighting. I will not pay 10,000 or I will not pay 40,000. They will try to negotiate. So any kind of abuse is there. There is a doctor inside will be killed. What happens? Why it happens? Invariably, the Kubler-Ross is the doctor, the psychiatrist who talked about grief. Imagine there is a death in your family. If there is a death, there is a shock. How can it happen to me? Then denial. How can my father die? Yesterday was fine. Then you will be angry and bargaining, and finally depression and acceptance. It takes almost 2 weeks to accept it. That is the reason now Kaila Samaradina eradu vara agmane itkoldu. By the time the family recovers. Similarly, if the patient dies, the family also will react like this. There will be shock, denial, there will be anger. This is you need to know. They will become angry, the relatives will be attacking you. So this is, if you know that, then after some time they will start bargaining and they will accept it over a period of time. Because this is the mob violence starts here, anger. But you also need to understand if there is a death occurs, the same grief you also will go through. You are a second victim. Primary victim is the family. The secondary victim is the doctor and the. So what will happen here? You will also feel angry. Imagine you are one of the cases which occurred in Bangalore. Everything is fine. The baby was born. They were about to get discharged. As per the hospital package, they have to teach the mother how to give birth to the child. Unfortunately, the ayah took the child, took the mother, put the child directly in front of the geyser. The geyser came out with the boiling water. The child sustained, the unit sustained severe burns. Later the child died and there was a case in the whole hospital. The doctor was furious because the doctor is now pulled into the case. The doctor had discharged the case actually. So somebody else made a mistake, so you will become angry, you will be exploding. You may have, sometimes some doctors do not have any emotions. Because the doctor in them has already died because of multiple cases against them. Or else it will be delayed. After later you may get the emotions. Or protracted, oscillating. Why it is oscillating? Imagine there is a death and social media, everybody started posting it. And your own colleague will repost it to provoke you. And many of your colleagues are very happy that they have a case against. They will talk to you or they may not talk to you because they believe that you are an accused now, you are a criminal. We will treat a terrorist who has killed many people, but our own colleague who has got a case, we don't want to talk to them and they also don't want to avoid. And you have a case, imagine, and you have to tell your child, I have a case, and you have to talk to your husband or a wife that I have a case. How will you deal for next 1 week? Then the death occurs, death of a doctor occurs. And what happens if there is a death? You will go into depression, suicide, anxiety, drug abuse, alcohol use, personality change, defensive practice. And many times that case will have repercussion on the next patient when he comes. You will start shouting at them. As a doctor, you will see, this case does not have anything against the previous, but unfortunately the same doctor, no, they will be carrying on. They will have repercussions. So why I am talking? Because I was the chairman for this National Task for Mental Health and Wellbeing. I was the chairman and we did a study with NMC. NMC has published this, the whole thing. 15% of our doctors have depression, drug abuse, alcohol use. 30% of our UG has. They are diagnosable mental illness. And number of doctors committing suicide is increasing day by day. And no doctor should die. That is my aim and goal. That is the reason I took it up. But anyhow, after that we worked on the various professional misconduct related cases. I was a medical legal advisor for the National Medical Commission. So these are the publications we have done. These are all case series which the NMC has faced. The cases which have been appealed to NMC. So they are available. I will be circulating to Dr. Lata. She will be able to circulate for you people. All these are available, expert training and professional conduct training. So what we have to know now? The medical negligence. What is medical negligence? Medical negligence has 4 components. They are very simple. One is there should be a duty of care. In emergency, you have to provide care. Already the doctor has said, the previous speaker, Permanent Katara versus Union of India. In emergency, you cannot refuse the case. Let's be very clear about that. If it is not an emergency, you can refuse the case. So duty of care means when the patient comes and by chance your secretary opens a slip in the patient's name, the duty of care exists. Because on your behalf, the secretary has opened the slip, the duty of care exists now. Once the duty of care exists, you have to provide care. And if there is any deviation in the care, what is the deviation? Standard of care. If a gynecologist in Chitradurga does some care, another gynecologist should accept it. Then we call it a standard of care. The court does not expect you to provide AIMS level of care or a THC level of care. Standard of care, what is possible at Chitradurga, you have to provide that. Not very high, or very low. That breach of duty, that is the standard of care, and because of the breach of duty, there should be damage. And the damage should be proximate, not remote. What is that proximate and remote? Let me give an example. Dr. Pawan just now gave a good, wonderful talk. Dr. Pawan was seeing a patient. He gave a paracetamol tablet because the patient had a headache. The patient took the paracetamol tablet. He came out of the hospital and he was crossing the road. Suddenly the car comes and hits him. The patient dies on the spot. If there is a RTA case, maximum maybe 25 lakh rupees. Okay. An intelligent lawyer like our Gopinath sir will say, Gopinath Shah said, let's put a case on Pawan sir. Because the doctor gave the tablet and he did not explain him about the side effect, the patient felt dizzy and fell in front of the fast moving jeep or car. Because one of the worst decisions which was given by our Karnataka judge, that is Kunal Shah was a CMRI hospital, it was only 6 crore compensation with interest 12 crore. 12 crore you have to pay. And imagine if we are able to prove that there is a medical negligence and that fellow was earning something around 2 to 3 lakhs per month, you may have to shell out 10 to 12 crore. And let me tell you one another important thing, the recent Supreme Court and also the Consumer Protection Act. Imagine you are a doctor and you are not imagine you are a doctor. You have a case against you and you commit suicide because of the case. Will the case will be dropped? No. Criminal case will be dropped. The consumer case will run against you even after your death because the legal hire you have to pay the money. That means the compensation will be from your property will be given. Don't be under that impression if you die, the criminal case will also go civil. No. Consumer case will run in spite of your death. It may be after 20 years also, the Supreme Court will tell from your property, this money has to be given to the patient. That means if you have 3 children, the 4th will be to the patient. So that is the problem now, so don't kill yourself. You have to fight the case. That's what So coming to the damage should be clearly established because of the breach. So now the question comes, sir, how to establish this standard of care? The standard of care is established again by a Bolam's test. Most of the senior doctors know, but since there are many youngsters, I talk about Bolam's test. The Bolam test was the first time in 1952, 53, 50, the case was decided in 57. This is a case, a patient named as Bolam goes to a doctor in UK, Frederick Hospital. He is suffering from depression and he says, sir, I am suffering from depression, please provide me treatment. It is 1957. Go back in time. So in 1957 he goes there for treatment. So he has suicidal ideas. They will say, okay, we will start shock treatment, electroconvulsive therapy. The electroconvulsive therapy at that time, the belief was if you induce a seizure by any means, either by giving electrical current or giving camphor or giving insulin, psychosis and depression will go away. So we have to induce seizure, so they did ECT. The first ECT, nothing happened. Second ECT, depression improved, but unfortunately he developed vestibular fracture. Now his depression is cured. Now he goes back to the court and says, I went for depression treatment. The doctor gave us a discount vestibular fracture. Like Deepavali or Yugadi Abhuda, discount kotage kotinare. So now the judge, being the Judge McNair, imagine in 1957 you are the judge and you have to decide whether the doctors are negligent in this hospital or not. What will you do? The judge did not have any case available at that time which is established formula to say the doctor is negligent or not. So the Judge McNair, what he did was, he called the experts. The experts said, sir, yes, in depression we give shock treatment, but shock treatment is given with anesthesia and muscle relaxant. The other group said, no sir, we don't give anesthesia, muscle relaxant. In 1952-53, anesthesia was starting. And patient used to die because of anesthesia. So if you give anesthesia at that time or muscle relaxant, patient will die. So imagine the experts were divided. Half of the experts said we will use anesthesia, sir, like corporate hospital and muscle relaxant. We have every equipment. The other group of the psychiatrists said, no, sir, we don't have anesthesia. It is very dangerous. Ether was given at that time. Muscle relaxant was very, very poor at that time. Patient will not come out of the anesthesia only. Why should we do? And you have to give every alternative for ECG. Now the Judge McNair is again confused. What should be done? So Judge McNair gave a landmark judgment in 1957. If the doctor followed the two procedure which is prevalent at that time, he is not negligent. Either give anesthesia with muscle relaxant and ECT, or without muscle relaxant is acceptable. So at that time he made a very important note. The doctor should follow the reasonable degree of care. What is that reasonable degree? The doctor at the same time, prevalent practice if you are following. That means if the Gynaecology Association of India forms certain guidelines, if you are following that, you are not negligent. If you are, but don't follow the international guideline because we are following Indian law, so Indian guidelines are essential. So if you are able to follow that, you are not negligent. So any doubt about this reasonable degree of practice? But however, that is called as bolance. In other words, if a responsible body of medical profession would support the doctor's action or treatment, the doctor is not negligent. Yes, sir, please.
Place and time.
Yeah, I'll come to that. One is reasonable degree means in Chitradurga, if a doctor, gynecologist has done certain treatment and there is a negative outcome, the other doctor will be called for an opinion. Invariably, they will ask for opinion from the State Medical Council. State Medical Council doctor may give it to BMC, Bangalore Medical College doctor, Gynaecology HOD. They will sit in the AC chamber. They will go through your records, not somebody else's records. And if you are good at writing, you have provided a good record. And in the AC chamber, they will write a report against you. Because they are colleague, your colleague. No. The doctor also, the expert has to go back in time. Go back to the place where it has happened. The BMC doctor who is giving the opinion, Bangalore Medical College, gynecologist, whoever is there, has to go back in time, place, and in that time, imagine at 2 o'clock in the night, it happened in Jagalur, not in Chitradurga. In Jagalur, there was no electricity on that day because of rain. 3 years back it happened. Anesthetist was coming on the road, met with an accident, and the gynecologist was waiting for our electricity to come, anesthetist to come, but unfortunately did not come. The patient died. Now the case is on the gynecologist telling that she did not operate. So you have to go back in time. So the expert has to do a time travel to that place. That's what the doctor said. The time travel has to be done. The experts, because nowadays our experts sitting in Bangalore are very, very superiors. They don't do this time travel because they don't have this machine. So they have to understand the circumstances around the event which has happened. That is, so although there is Boland test, but the Boland test talks about standard of care. The standard of care is, you may be the best gynecologist in the country. You ask them to go and practice in a village near Chitradurga, Devikere. Put them there without OT, without a assisting nurse. Let them do a good job. They can't. Because nowadays the healthcare system is dependent on many factors. But unfortunately the laws are Boland 1957. We are still using it, and that has been quoted many times in various Supreme Court judgments. So whenever the expert opinion is given, it has to be time travel exercise has to be done, go back in time, and then we have to give opinion. But unfortunately, there has one more case has come. ಸ್ವಲ್ಪ ಹೆಲ್ಪ್ ಮಾಡಿ ಗುರುಗಳೇ, ಕೈ ಕಟ್ತಾ ಇಲ್ಲ. ಆಯ್ತಾ? Okay. But the Bolan test ಅಲ್ಲಿ all lawyers started criticizing doctors because if you ask a doctor an opinion by another doctor, they are together, sir. ಒಬ್ಬರು ಡಾಕ್ಟರ್ಗೆ ಇನ್ನೊಬ್ಬರಿಗೆ ಒಪಿನಿಯನ್ ಕೊಡಲ್ಲ ಅಂತ the society believes. Is it true? ಇಲ್ಲ ಮೇಡಮ್, ದ ಡಾಕ್ಟರ್ ವಿಲ್ ವೇಟ್ ಫಾರ್ ಮೇಕಿಂಗ್ ಮಿಸ್ಟೇಕ್. ನಿಮ್ಮ ಮೆಡಿಕಲ್ ರೆಕಾರ್ಡ್ಸ್ನ ತೊಗೊಂಡ್ಬಿಟ್ಟು ಅವ್ರಿಗೆ ಕೊಡಿ, ಸಾಹೇಬ್ರಿಗೆ. ಸಾಹೇಬ್ರು ಹುಡ್ತಾರೆ, ಹಿಂಗೆ ಬರೀತಿದ್ದೆಲ್ಲ, ನಾನು ಇವು ಚಲೋ ಬರೀತಿದ್ದೆ. ಅವ್ರ ರೆಕಾರ್ಡ್ ತಗೊಂಡು ನಿಮಗೆ ಕೊಡಿ. ಯು ವಿಲ್ ಕ್ರಿಟಿಸೈಸ್. ಐ ಗಿವ್ ಒನ್ ಎಕ್ಸಾಂಪಲ್. ಇನ್ ನ್ಯಾಷನಲ್ ಮೆಡಿಕಲ್ ಕಮಿಷನ್ ವಿ ವರ್ ಸಿಟ್ಟಿಂಗ್ ದೇರ್. ಒನ್ ಆಫ್ ದ ಕೇಸ್, a death has occurred. Orthopedician has done a surgery, like Pawan Patil ತರ ಸರ್ಜರಿ ಮಾಡಿಬಿಟ್ಟಾರೆ. Patient had a fat embolism and died. Expert opinion ಕಳಿಸಿದ್ದಾರೆ. Expert opinion ಅಲ್ಲಿ expert saw everything and made a comment. I believe the doctor has done a good job, but he should have kept the medical records appropriately in the program. It was none of his business to talk about the medical records. ನಮ್ದು ತಲೆಯಾರಿಕೆ ನೋಡಿ, ನಾನು ಎಕ್ಸ್ಪರ್ಟ್ ಅಲ್ಲ, ನನಗೆ NMC ಅವ್ರು ಕರೆದಾರೆ, ಸ್ಟೇಟ್ ಮೆಡಿಕಲ್ ಕೌನ್ಸಿಲ್ ಕರೆದಾರೆ ಅಂತ ಬರೆದ್ಬಿಡ್ತೀನಿ ನಾನು ನೋಡಿ. That point went against the doctor. They filed an FIR. Further, medical records ಸರಿಯಾಗಿಟ್ಟಿಲ್ಲ. That means he is negligent. That kind of comments was not required. So the society believes the doctors will support another doctor. For that, there was another case in Bolito test. What is this Bolito test? Here again, a 2-year-old Patrick Bolito, a young child, suffering from severe cough. Whenever the child goes into cough, will become completely asphyxia and child becomes cyanosis. So ICU admit ಮಾಡ್ತಾರೆ child na. And the child is looked after by the doctors who are on duty in emergency. The child develops one episode of severe cough with cyanosis. They call the duty doctor, but the duty doctor cannot come. By the time they came, the child recovered. Second time ಅದೇ ತರ recover ಆಗುತ್ತೆ. Third time ಅಲ್ಲಿ ಅವರು busy ಇರ್ತಾರೆ doctors. Unfortunately, the child goes into severe hypoxia and brain injury. And after the family becomes very angry, nobody took care of our child, and they go to the court, and later the child dies. Now this goes, again the case goes to the court. This is in 1996. Bolan case na same apply ಮಾಡ್ತಾರೆ ಇಲ್ಲಿ ಕೂಡ. What is the Bolan? Bolan ಅಲ್ಲಿ ಏನು ಹೇಳ್ತಾರೆ? They will ask the opinion. The pediatrician is there, they will say, if I go to the emergency, I will do intubation and provide oxygen. One. Other group of pediatricians said, if I go to the ICU, I will not do it because child is already, larynx is irritable. Now, the severe laryngeal spasm, the child will immediately die. I will not do anything, I will just give oxygen. So, they said both are fine. The doctors would have chosen one of them, so they are not negligent ಅಂತ ಎಕ್ಸ್ಪರ್ಟ್ ಒಪಿನಿಯನ್ ಕೊಡುತ್ತೆ. ಬಟ್ ಇದರಲ್ಲಿ ಬೋಲಿತೋ ನೋಡಿ, ಬೋಲಾನ್ ಅನ್ನೋದು ಒಂದು ಟೆಸ್ಟ್. ಬೋಲಿತೋ ಟೆಸ್ಟ್ ಅಲ್ಲಿ ದ ಕೋರ್ಟ್ ಸೆಡ್ ದಟ್ ಇಫ್ ಯು ಹ್ಯಾಡ್ ಗಾನ್ ಟು ದ ICU, ಯು ಡಿಡ್ ನಾಟ್ ಗೋ ಟು ದ ICU ಓನ್ಲಿ. ಸೊ ದಿಸ್ ಬೋಲಿತೋ ಕೇಸ್ ಅಲ್ಲಿ ಏನು ಹೇಳ್ತಾರೆ, ಬೋಲಾನ್ ಟೆಸ್ಟ್ ನಲ್ಲಿಫೈಡ್ when the body of expert opinion cannot be logically explained. What is logically explained? You should have gone and examined the child. You are not examining, so Bolan test will not be hold good. The court, okay, adversarial remark. ಅಂದ್ರೆ ನಾವು ಕೊಡೋ ಒಪಿನಿಯನ್ ಹೇಗಿರಬೇಕು ಅಂದ್ರೆ ಲಾಜಿಕಲಿ ಎಕ್ಸ್ಪ್ಲೇನ್ ಮಾಡೋದಿರಬೇಕು ಕೋರ್ಟ್ಗೆ. ಯು ಶುಡ್ ಬಿ ಏಬಲ್ ಟು ಎಕ್ಸ್ಪ್ಲೇನ್ ಲಾಜಿಕಲಿ. ಡು ನಾಟ್, ಬಿಕಾಸ್ ಅನ್ಫಾರ್ಚುನೇಟ್ಲಿ ಮೆನಿ ಟೈಮ್ ದ ಮೆಡಿಕಲ್ ಎಕ್ಸ್ಪರ್ಟ್ ಒಪಿನಿಯನ್ ದ ಡಾಕ್ಟರ್ ಇಸ್ ನಾಟ್ ನೆಗ್ಲಿಜೆಂಟ್ ಅಂತ ಬರೆದುಬಿಡ್ತಾರೆ ಎಕ್ಸ್ಪರ್ಟ್. ದಟ್ ಈಸ್ ನಾಟ್ ರಿಕ್ವೈರ್ಡ್. That is the duty of the state medical council or the consumer court to give. Our job is to say whether the doctor provided a reasonable degree of care or not. Don't tell the child. Again, there was a POXO discussion as well. We are not supposed to give the verdict rape occurred or not. Similarly here, we have to talk about reasonable degree. So, the Bolito is very clear. The opinion given should be of clearly with logical explanation. So, with this, I will stop here. I would like to ask you to ask questions. the basics of medical negligence ಬಗ್ಗೆ ಮಾತಾಡಿದ್ವಿ and medical certificate ಬಗ್ಗೆ ಮಾತಾಡಕ್ಕೆ ಹೋದ್ರೆ ಮತ್ತೆ ಊಟ ಎಲ್ಲ ಸಿಗೋದಿಲ್ಲ ನಿಮಗೆ. Let's have couple of questions with the permission of the chairman. Any questions you can ask. Yes, sir, please.
Discuss the types of claims that arise in civil law and the two types of claims, the two broad categorizations of claims, and which category of claim a medical negligence claim under the Consumer Protection Act would fall under. The reason for doing this is understanding the kind of claim helps us understand what the ingredients of a successful claim needs to have, and identifying whether a complaint has those ingredients or not, and basing the defense on that. So the two broad claims are essentially contractual. Civil claims are essentially contractual claims, and what are known as tortious claims or torts, T-O-R-T-S. So contractual claims, as the name suggests, are claims, civil claims that arise out of breaches of contract, and that's fairly common, and what basically gives rise to a liability in a contractual claim is the breach of a duty or an obligation that the contract between the parties what that breach entails would give rise to a contractual claim. Essentially, the liability for that breach is either defined within a contract itself, or if it's not defined within the contract, then we generally fall back on the law of contracts, which would be the Indian Contract Act. So these are essentially contractual claims. For instance, when there's an agreement for sale of property within a particular period of time, the buyer is paid in advance, and the seller fails to register and execute the documents within this stipulated time within the contract, there appears to be a breach of contract by the breach of the duty to sell that is cast under the contract. Now, this breach of duty gives rise to a claim. This would be a contractual claim that the buyer can make. Now, the remedies can be varied. It could be compensation, it could be return of the money with interest, it could be enforcement of the contract itself, and the remedies that are available under law. This is as opposed to a tortious claim, which is the kind of claim that a consumer claim or a consumer complaint would fall within. A tortious claim are essentially all claims that are made for civil wrongs outside of a breach of contract. Therefore, excluding breaches of contract, most claims would be tortious claims that are made. These such claims are made when a duty of care is breached. As I think Dr. Suresh was saying in the earlier session, he briefly outlined what these elements of a claim within the Consumer Protection Act would have is, or a claim for medical negligence needs to consist, is there must be a duty of care, there must be a breach of this duty, and the breach of this duty must have caused injury. Therefore, the three elements that need to exist are duty of care, breach of duty, and injury. And the fourth element is that the causation of that injury should be relatable or attributable to this breach of that duty of care. So, tortious claims can arise in different scenarios. It could arise out of contractual relationships, like as when a patient would approach a doctor or a medical institution and seek treatment. There is a contractual relationship where the patient pays consideration for the treatment that is received. Apart from the contractual relationship, there is also a duty of care that the medical professional has to the consumer. Now, what standard this duty is and to what standard this duty is to be observed, and that is basically, those are questions that determine whether there has been a breach of this duty of care or not. There could also be duty of care that exists outside of contractual relationships, where, for instance, if a person is constructing just in the just amongst general public, when people live in society, there is generally what law recognizes as a duty of care, where, for instance, if a person is building a house and he has put up some scaffolding which extends onto the footpath, and there is some construction material that falls onto a passerby and injures him. Now, this would certainly be a breach. There is a duty of care for that person who is constructing on his property to the neighbors and the people passing by and the people around to maintain standards of safety, so that to ensure that they are not harmed or his actions do not cause any harm to these persons. Therefore, this person constructing and a passerby has no contractual relationship, yet there is this duty of care which would be breached if something of this nature were to happen. So what the Consumer Protection Act, and these are essentially tortious claims. These are the broad area of tortious claims that could be made. Tort law in India is not a very developed field of law, and the claims, tortious claims that are made in India are, we see very few compared to other jurisdictions. So essentially what the Consumer Protection Act does is it codifies certain areas of tort law where certain contractual relationships between consumers and service providers are essentially covered, whereby the Consumer Protection Act defines who a consumer is, who a service provider is, what a product is, who a product supplier is, and it has various definitions of what would amount to deficiency of service. This basically codifies principles. The Consumer Protection Act, what it seeks to do is to codify the principles of tortious claims that may be made within contractual relationships. Now, in particular, when we look at medical negligence cases, the duty of care is more or less, again, like Dr. Suresh said, as soon as a patient walks in to a medical institution or to approaches a doctor and begins a consultation, and which is either for a fee or agreed to be provided for a fee, there is a relationship of a service provider and a consumer that is established, and therefore this duty of care kicks in. What is duty of care essentially? It is a duty to act in a reasonable manner, in accordance with standard operating protocols, or in a manner not to act in a negligent or a rash manner. Therefore, to sort of observe the minimum standards that a reasonable doctor may prescribe in a given situation is basically what the duty of care is. Now, that is the first element. Now, whether the question as to whether there has been a breach of this duty, whether a doctor has acted in violation of this duty or not, is typically a question that is for the consumer courts to decide, consumer commissions to decide in most complaints that are filed. So far as the injury is concerned, again, in consumer cases, typically it is only when there is some injury that a consumer case arises. Now, whether this injury was caused due to a breach of duty or not is the question that arises. The other significant question that would arise is whether it was this breach of duty that the consumer complaint alleges which led to the injury. Therefore, the question of whether it is the direct cause, whether the breach of duty is the direct cause for that injury, is the other significant question that generally arises in consumer complaints. Therefore, the two significant questions that we generally see are this, whether there's a breach and whether this breach has led to the injury that is complained of or the damage that is complained of. Now, I can give a brief example of a recent case where in a hysterectomy that it was alleged that a hysterectomy was performed incorrectly, which led to a VVF, and subsequently there was a VVF repair surgery, and this all happened across a span of about 2 months or so, and thereafter, unfortunately, the patient suffered a cardiac arrest. It was also learned that this patient was I think a primary school teacher who was commuting immediately after the hysterectomy against medical advice, who was commuting about half an hour, 45 minutes each way to her school to teach. Now, one of the questions that could arise in such a case is, even if a breach is proven, even if there is the complainant is able to establish before the commission that there was a breach of duty of care and that the hysterectomy was not performed properly or in accordance with the standard operating protocols, and this is what led to the VVF, the consumer would also have to prove in this case that the cardiac arrest, which is the injury suffered, was a direct result of or was a proximate result of the hysterectomy having gone wrong itself. So therefore, this causation is also an important element that we need to keep in mind, particularly because we see generally patients may or may not have acted in accordance with medical advice. They may have had other they may have consulted multiple people, they may have, so there may be various circumstances, other circumstances also which may have led to the injury that they complain of. So these are essentially the 4 elements. So once we understand that these are the elements of a tortious claim, which is now codified in the Consumer Protection Act, we look for these elements in the complaint and seek to tackle these elements. So what essentially the Consumer Protection Act was initially, what it does is, of course, it protects the interests of consumers. It was initially enacted in 1986, and that was the old enactment, and it was enacted because there's a large information asymmetry in India between consumers and either service providers, or not just in the medical field, even in the medical field it's probably world over that, and also the legal field is probably world over that this information asymmetry exists, but also in other fields. Therefore, this enactment was made, and consumer rights were protected. But what the Parliament found in 2019 was that procedurally there had been a significant slowdown. Consumer complaints were not getting decided quickly enough. Therefore, some procedures needed alterations, and the appeal mechanism and the jurisdictions needed alterations. Therefore, they brought in a new enactment in 2019, completely replacing the old enactment. So, there are about 3 or 4 significant changes insofar as consumer complaints, the decision-making process itself is concerned, and how the complaint is heard, which I'll just delve into. The first one being that since the aim was to quicken the decision-making process, the first change was that after the issuance of notice, once a consumer complaint is filed, a district commission or a state commission, depending on the jurisdiction where it's filed, they look into the matter, hear the complainant, see whether there's on the face of it, if there's any prima facie case that they need to look into further, and if they find, and in majority of the cases, they typically mechanically issue a notice to, in medical negligence claims at least, to the concerned doctor or the opposite parties. Once this notice is issued, now this notice is typically issued along with a copy of the complaint and the documents. Once this notice is issued, what is required to be done is, once the notice is received, by the opposite party, the doctors or the medical institutions. The 2019 Act makes it clear that there is only 45 days for a response to be filed to that complaint in the commission. Now, if a response is not filed within 45 days, the significant change that the 2019 Act has brought in is that this right to file a response is forfeited. Therefore, it is very important that once a notice of a consumer complaint is received, it's very important that decisive and quick action is taken. Quick to approach maybe your legal counsel and understand the steps that are required to be taken, and decisive being the this version or the objections that are filed forms the basis of the defense for the consumer case, against the consumer case, and through its journey. That is, it may go on to appeal before the State Commission, it may go on further appeal to the National Commission and then to the Supreme Court, but this version that is filed will be basically the basis of the defense. So the explanation as to the facts, as to what happened, what exactly transpired, what was the course of treatment that was chosen, what are the reasons it was chosen, that needs to come through in the version. This is a decisive action that needs to be taken within the first 45 days. Once this is done, then the commission posts the matter to evidence. So evidence of these, now typically the burden of proving this allegation of negligence lies initially on the consumer, and the consumer is afforded the opportunity to lead evidence. The other change that has now in the field of evidence, the other change that has been brought in is that evidence now is taken generally on affidavits and documents. Earlier, under the 1986 legislation, the doctor would have to go personally, and the complainant also would have to go personally, stand in the witness box, swear to the affidavit, and submit the affidavit, identify the documents, and thereafter mark them. This process has been done away with, and now it's not done away with entirely, but generally, the general procedure prescribed is that personal attendance of either the parties or witnesses is not necessary, unless again, medical negligence cases would be an exception to this general rule, where if an application is filed before the commission and reasons are shown as to why personal appearance is required or necessary, the commission has all the power to order personal appearance of the party. Typically, we see complainants leading evidence just by their evidence affidavit, repeating what they say in the complaint and producing the copies of the documents that were provided to them. This in itself is generally insufficient to prove negligence. Because the complainants typically don't have a medical background, they are not experts in the field, their evidence of saying that this is negligent or this was not in accordance with standard operating protocol, it may be insufficient. Therefore, if only this evidence is placed before the commission, then it's open for the doctors and the medical institutions to place their evidence also on affidavit and leave it at that. It's not necessary that in every single case some expert evidence requires to be placed before the commission. Although if the consumer the case is prosecuted properly and expert evidence is led, then the documents that are initially produced are referred to an independent expert who then refers his opinion. That opinion may then be subject to, on application, cross-examination of the expert by the defense counsel. And if, again, like Dr. Suresh had clarified, if another opinion is required, an application may be made, another opinion may be also provided. And thereby this would if another opinion is provided, the Consumer Commission is then required to consider all of these opinions and thereafter come to a conclusion. Now, the final stage, of course, is the counsels would argue and then the consumer argue on the evidence that is available, and the Consumer Commission would come to a conclusion. I'll just only to reiterate what the standard of care is. It is not that if there's an alternate course of action which may or may not have yielded a different result and that could have been chosen, that would in itself not amount to negligence, but it must be shown that there was a significant deviation from the standard that is adopted across within a particular field. It is in this case where there is injury suffered that the courts would typically hold that there is negligence. In terms of once a decision is made, if in case there is an adverse decision, again this process has been quickened. There's 45 days to appeal. An appeal is to be filed quickly so that in order to obtain either a stay of that adverse decision, it would be possible if there's no delay to obtain a stay without notice to the other party. If there's a delay, then the commission is generally reluctant to grant a stay without notice because they would have to first condone that delay beyond 45 days and only then issue a stay. And execution of the orders has also been made a little more stringent in the new enactment, and therefore in the event there is an adverse order, it is always it's good to stay vigilant and again take decisive and prompt action. So these are essentially the steps. So thank you very much. If there are any further questions, I'd be happy to answer.
Thank you, Rahul. It was very elaborate and clear about the steps that will go on following the case filing. Thank you very much. Any questions?
So, is there any time frame to file a case in consumer court, like 1 year, 2 years after the incidents have occurred, or is there anything you can file whenever you want?
Yes, there is typically a time frame. So the Consumer Protection Act 2019 gives 2 years of time.
Previously worked in a PHC, General Hospital, District Hospital, Victor and a Corporate Hospital, and passionately committed as a law educator. I work with advocates, we work with advocates also. Sir, over to you. Thank you, sir.
Of Vijayanagara, with the blessings of Lord Virupaksha, a civilization that reminds us the duty, ethics, governance, and which must walk together. With this, I would like to start, and this is my actually team at Vijayanagara, and myself I told, and this is my alma mater where I got educated at JJMC, then Bangalore Medical College, then KSLU Law School, and right now this is my hospital. So data says annual medical malpractice incidents are approximately 52 lakhs and negligence related deaths are approximately 98,000 per year, which is surged by 110%, which may not be a clear-cut data in India. Litigation has increased by 400% in recent years. That is why we are all little bit worried. Over 12,000 medical negligence cases are filed annually in India. It is 2023. Only 20 to 30% of doctors in India have adequate medical indemnity insurance. So I will be stressing on that point. And in 2022 survey, Indian healthcare professionals, nearly 60% admit they were unaware of laws governing medical practice and documentation. So the legal wisdom is all enacted laws must operate within the boundaries set by the Constitution of India. Ignorance of law is not a valid excuse. Any action not explicitly allowed by law is deemed unlawful. These are bigger words, but that will subsequently understand this. So authority and government officers can make mistakes. Mistake of law has no excuse, even both sides. Unless you approach an advocate, you will not know the illegality. Being aware of law is becoming more important. So case 1. This is a case, Dr. V. Padmavati. This is a decision from National Consumer Dispute Redressal Parties are, that is, the complainant is Parveen Banu, and OP1 is Dr. Padmavati, and OP2 is Yashoda Hospital, and OP3 is the New India Assurance Company. So medical facts: the patient presented dysmenorrhea, menorrhagia, abdominal pain and comorbidities with diabetes mellitus, hypertension and hypothyroidism. She was diagnosed uterine fibroids, TLH, total laparoscopic hysterectomy advised and performed on 27/6/2012. Post-operative abdominal pain, vomiting, blood in stools and distension happened. CT scan revealed rectal and bladder injury with infection. TLH, rectal injury, and also bladder injury. Exploratory laparotomy was done in 2012. Pus, rectal perforation repair and loop colostomy, and also ureteric catheterization was done. Prolonged ICU care, multiple admissions, later colostomy closure. Allegation of wrong surgery, lack of disclosure, invalid consent and negligence. This is what the case. Injury to bowel bladder due to negligent TLH. This was the complaint. Allegation: endometriosis falsely shown post facto to justify complications. Informed consent not valid. Risk not explained preoperatively. Excessive physical suffering, loss of income, high medical expenses. Sought 35 lakhs of compensation. So defense by the hospital: patient had extensive grade 4 endometriosis discovered intraoperatively. Bowel and bladder injury is a known risk in severe endometriosis. Multiple consents obtained, like general consent, surgical consent, high-risk consents were taken. Complications were promptly managed, life saved. Literature shows non-negligible incidence of such injuries in TLH. No independent expert evidence proving negligence. Actually, the complainant should have bought an expert, but that has not been done. State Commission order was: complaint partly allowed, held OP1, OP2 negligent to the limited extent, awarded 3 lakh compensation and 10,000 for cost. Held hospital vicariously liable, insured to indemnify. Issues before National Commission are bowel bladder injuries, ordinary risk. They went for appeal. The patient went appeal for higher compensation. There are the National Commission had a few issues which it listed are bowel bladder injuries or ordinary risk of TLH. Was informed consent valid and adequate? Could endometriosis have been diagnosed preoperatively? Whether negligence was proved, warranting higher compensation. Findings of National Commission on Medical Negligence: TLH in severe endometriosis carries recognized risk. It has observed. Injury per se is not equal to negligence if procedure otherwise reasonable. Doctors acted to save patient's life. Once complications emerged, they have acted, they have saved the patient. They did not allow the patient to go for sepsis and die. So on endometriosis, gold standard diagnosis is laparoscopy, not imaging alone. This is what the observation by National Commission. Discovery during surgery was medically plausible. However, preoperative discussion on suspected endometriosis was inadequate. On informed consent, consent is not mere formality. It must be informed and patient-centric. While general and surgical consent existed, high-risk consent was obtained post-surgery. This was the observation, which is legally weak unless justified by emergency. Commission held deficiency in consent process, though not gross negligence in treatment. On Bolam test cannot fully govern consent aspect. Patient autonomy and statutory duties override blind reliance on Bolam. So here Bolam is override. The actually National Commission has override the Bolams. Final decision was both appeals disposed, both party as well as the doctor, both appeals were disposed. State Commission awarded 3 lakh upheld. Whatever the compensation already given is upheld. No enhancement of compensation. Actually, in this National Commission, doctor has won the case. Hospital and doctor not held grossly negligent, but deficiency in informed consent acknowledged. Insurer liability indemnify as per the policy. They have given us separate order. Legal principles laid down as complication is not equal to negligence if risk inherent and managed timely. They have managed it timely. They did loop colostomy. They closed it. Informed consent is substantive legal duty, not procedural. Here, the doctors have missed putting this proper consent. The Bolam test is diluted in consent in Samirapulli and Montgomery. Consent must disclose diagnosis, alternatives, material risks, and prognosis. So, consent should have all these things, all these wordings. So, how the court came to decision is, in high-risk surgeries, while occurrence of known complications may not amount to negligence, failure to obtain proper informed consent, especially regarding material risk and altered surgical scope, constitute deficiency in service under consumer law. So, these are just, I have put, simply I have just listed one. This ends actually the case as well as the decision just now finished. I will go for next case. If you have any specific question, you can ask in this. Or you want me to finish another case. So TLH is a clear-cut case, a TLH with bladder and bowel injury. Later what happened was they went to district forum, then went to state forum, then went to national forum, national commission, where doctor went to national, and where enhancement of compensation was not allowed in this case. So it was a known complication in medical records. The consent wise, actually the court discussed that consent should have mentioned the complications, like bladder and bowel injury was not mentioned in the primary surgical consent. Later on they have taken a consent, but still judges have favored doctors in this case. So such cases, if happen, complaint can reach, I will just give a scenario, it can reach the SHO, THO, DHO, DC, MLA, civil court, criminal court, consumer court, KMC, media. Okay, such things we have all faced. Just now we discussed that if it reaches the strain the doctor goes through when whether he is negligent or not negligent is also a bigger punishment. So for that, what is this CME has an intention is, we are actually doing so many complex procedures where so many IPC sections, BNS sections, BNSS sections are attracted. They are the list of crimes. Even with the list of crimes, we are operating like we are afraid about the procedure of law. But the intention of CME is we all should become little more tough, so that when you are operating on such things, you should be able to sustain all the procedure. Maybe this case took 8 years for complete disposal. So for a quick, just I have added one extra PCP&DD case here. In this case, maybe you might have known, this is a recent case of 2022. Here, a petition was filed under section 482 CRPC seeking quashing of criminal proceeding initiated under PCP&DD Act. The petitioner were medical practitioners running a hospital at Gokak, Belagavi district. The respondent was Taluka Health Officer Gokak, who initiated the criminal proceedings. The criminal case arose out of inspection conducted at the petitioner hospital premises. During inspection, Taluka Health Officer alleged violations of PCP&DD Act rules. It was alleged that mandatory records prescribed in the Act were not properly maintained. Certain medical equipments and documents were seized during the inspection. Based on the inspection report, the private complaint was lodged before the judicial magistrate. The magistrate took the cognizance and registered the case. Petitioners challenged the proceedings on the ground of lack of jurisdiction. The principal contention of petitioner was the Taluka Health Officer was not an appropriate authority under PCP&DD Act. It was argued that only authorities notified under section 17 of PCP&DD can initiate prosecution. The petitioners contended the initiation of criminal proceedings by the incompetent authority violated the entire prosecution. The state defended the action, stating that the inspection was conducted in public interest. The state argued that the Taluka Health Officer was empowered to act to prevent misuse of diagnostic techniques. The court examined section 17 of PCP&DD Act in detail. The court noted that the statute mandates appointment of appropriate authorities by specific notification. The court emphasized that the criminal law must be strictly construed. That means even government has to obey with this section. It was held that the powers inspect, seize, prosecute cannot assumed unless expressly conferred. So the court observed that no notification was produced to show that the Taluka Health Officer was appropriate authority. The court reiterated that absence of jurisdiction goes to the root of the matter. It was held that any action taken by the authority lacking jurisdiction is void ab initio. The court relied upon settled principles that criminal prosecution initiated by the competent authority is unsustainable. Incompetent authority. The court further observed that the procedural safeguards PCP&DD are mandatory. Violation of statutory procedure cannot be cured by subsequent justification. The court held that allowing such prosecutions would amount to abuse of process of law. Inherent powers under Section 482 CRPC were held to be rightly invoked in the case. The court concluded that continuation of proceedings would result in miscarriage of justice. Accordingly, the criminal proceedings were quashed. Liberty was reserved for competent authority to proceed afresh accordance with the law if permissible. So here, criminal prosecution of the PNDT Act can be initiated by the authorities notified under Section 17 of the Act. Jurisdictional competency is a sine qua non for valid criminal proceedings. Proceedings initiated by incompetent authority are void ab initio and liable to be quashed. In this case, government lost the case. Act involved was PCPNDT Act. And relevant section was 17, which I explained. Section 28, cognizance of offences, was again the same PCPNDT Act. The Rule 12 and 17 maintains inspection of records was also discussed in the court, and Section 482 Code of Criminal Procedure, here also that was it was considered. So questions, I think we will take it at the end. Going on to one more medical negligence case, number 3. It is Hindu Sharma case. It's a very famous case in the Prastha Apollo Hospital. Happened in 2015 actually. It happened in 2015. The background of the case is the complainant is Dr. Hindu Sharma, conceived after 4.5 years of infertility treatment. She was under antenatal care at Indraprastha Apollo Hospital. She was admitted in 1999 after premature rupture of membranes, PROM. Labor was induced using syntocinon and continued for a prolonged period. Emergency LSCS was performed after 27 hours and female baby was delivered. The baby suffered birth asphyxia, seizures and later cerebral palsy. The child survived with severe disability and died in 2012. This is what the background of the case. Allegations: excessive and prolonged use of oxytocin 66 units without adequate monitoring, failure to respond non-reassuring CTG, fetal heart rate patterns, unjustified delay in performing cesarean section, suppression and tampering of medical records, especially tracings, failure to obtain proper informed consent, resulted hypoxic ischemic encephalopathy causing cerebral palsy. Defense by the hospital: pregnancy was high risk due to obesity and infertility history. Oxytocin was administered within acceptable medical limits. Fetal heart rate was claimed to be normal throughout the labor. Baby condition was due to prenatal causes. No intrapartum negligence. Apgar score improved 3 to 1 at 3 and is ruling out severe aspects. Expert opinion from hospital doctor stated no negligence. Evidence considered: original hospital records produced after long delay. They took lots of time to produce. Neonatal records showing metabolic acidosis. Court observed this. 7.12. Early onset seizures. CT scan, MR reports confirming diffuse ischemic brain injury. Disability certificate from AIMS, 95% disability. Medical literature, they followed this. Key medical findings by the Commission: oxytocin should not be used indefinitely without progress of labor. Poor Bishop score and lack of cervical effacement indicate failed induction. Repeated warning signals, signs of fetal distress were ignored. Delay in LSCs was medically unjustified. Excessive uterine contraction reduced oxygen supply to the fetal brain. Neonatal ABG and seizure pattern confirm birth asphyxia. Medical record tampering, critical finding. Overwriting, erasers, inconsistencies in oxytocin dosage, nursing charts, CTG. CTGs were not preserved or produced timely. Commission held poor records mean no poor defense, no record mean no defense. Legal principles: duty of care existed, breach occurred due to delay in improper labor management, direct cause, the damage happened, breach and injury. Volume test, doctor failed to act as a reasonably competent obstetrician would. Res ipsa loquitur here applied due to gross deviation from the standard of care, suppression of vital evidence, unexplained severe neonatal injury. Supreme Court precedents, they referred Jacob Matthew. Findings on consent patient reluctance to LSS cannot override the medical duty. We say patient refused, but court will not allow us. Doctor must take independent clinical decision in fetal distress. Failure to document refusal LSS weakened defense. Conclusion, prolonged labor after PROM, excessive oxytocin without response, failure to act, fetal distress, delay in emergency cesarean. These cumulatively constitute gross medical negligence. Compensation, multiplier method is not suitable here. Compensation must just bear in deterrent, so rely on Nizam Institute case, so child lifelong suffering and death considered. So here how court came to the conclusion is prolonged misuse of oxytocin, failure to act on non-reassuring fetal heart tracings, delay in emergency cesarean section, tampering of medical records constitute gross medical negligence, attracting doctrine of res ipsa locator. So that is another case. I just now, that is one of the fetal distress case where most of the times we say a patient refused, and also we say we waited for so many reasons, but still baby died, and such things. What happens is they will attract gross medical negligence. So we have to take on our own decision. Even patient refuses also, we have to do cesarean section. That is Article 14, right to life. So there you can substantiate. Even they refused also, we have done. We could not take the LSCS consent, but still you can do cesarean section. Questions will be taken, sir. If you
excuse for not.
Hello. So yeah, like being a medical practitioner, what we are taught is like we, for example, if we got a patient, we are supposed to identify the symptoms, diagnose the disease, treat the root cause, like others do. Like for example, there are these airlines and all who has a possibility to ban their passengers or customers if they go against the rules. So as a medical practitioner, are we also allowed to ban a patient or like who doesn't comply to the rules and regulations? Is it okay or are we?
I will answer.
ಬಹುಶಃ ಕನ್ನಡದಲ್ಲಿ ಆರಂಭ ಮಾಡ್ತೇನೆ. ಯಾಕಂತ ಬಹುಶಃ ನನ್ನ ರೆಸ್ಯೂಮ್ ನೋಡಿದ್ರೆ ಗೊತ್ತಾಗುತ್ತೆ. ಕನ್ನಡ ಸಾಹಿತ್ಯ ಪರಿಷತ್ತಿನ ಅಧ್ಯಕ್ಷನಾಗಿ ಸಹ ನಾನು ಕೆಲಸ ಮಾಡಿ. ದಿಸ್ ಈಸ್ filled with obstetricians. As usual, our session is delayed. Exactly behave like a post-dated pregnancy, which has created anxiety. Hope we will come with good and fruitful delivery. This is totally a different panel discussion where nowhere in India or anywhere they have tried, and I found it very difficult to convince my panelists to go about how this panel during the discussions. Probably ಎಲ್ಲರೂ ಅರ್ಥ ಮಾಡ್ಕೊಳ್ಳೋದು ಏನು ಅಂತ ಹೇಳಿದ್ರೆ, ಆಬ್ಸ್ಟೆಟ್ರಿಷಿಯನ್ಸ್ ಕೂತ್ಕೊಂಡಿರ್ತಾರೆ, ಆಡಿಟ್ ಆಗುವಾಗ ಯಾರು ತಪ್ಪು ಮಾಡಿದ್ರು, ಎಲ್ಲಿ ತಪ್ಪು ಮಾಡಿದ್ರು, ಒಂದು ಕೇಸ್ ಡಿಸ್ಕಷನ್ ಇಟ್ಕೊಂಡು ಆ ಕೇಸಲ್ಲಿ ಯಾರು ತಪ್ಪಾಯಿತು, ಎಲ್ಲೂ ಲ್ಯಾಕ್ಯೂನೆ ಇದೆ, ಅದನ್ನು ಕರೆಕ್ಟ್ ಮಾಡ್ತಕ್ಕಂಥದ್ದು. ಬಟ್ ದಿಸ್ ಇಸ್ ಟೋಟಲಿ ಡಿಫ್ರೆಂಟ್ ಬಿಕಾಸ್ ಎವ್ರಿ ಮೆಟರ್ನಲ್ ಡೆತ್ ಹ್ಯಾಸ್ ಅ ಸ್ಟೋರಿ ಟು ಟೆಲ್. A family waiting, a clinical team striving, and a system that is somewhere it has passed, delayed, and definitely failed. Many private and government medical offices approach maternal death audit with fear. This you have to take it. It is not a conducive area where they go happily like they do section, they do a complicated case like that. For the reasons that are well known to all of us here. Let me state clearly, this panel is not an academic discussion. Please have it in your mind. Yava academic discussion agalla, and our focus today is not academic, it is totally different, and we are here to guide the obstetrician on what documentation is expected of them when they come prepared for the audit. This is more important. And how they can present their clinical decisions with clarity and confidence. For this, a clear, well-defined standard SOPs are really essential. And probably after this panel discussion, all of us will sit again. Then we will formulate the SOPs. The outcome of this medical legal conference, on this platform, we are going to submit to the government. Probably if that happens, it will create a very good conducive environment for the obstetricians to face the maternal death audit. It is the very time that we create conducive and supportive audit environment. That is what we are planning to do it now. And the intent of this panel discussion is therefore constructive, a forward-looking, and to evolve model SOPs to protect sincere practice, strengthen the confidence, and also ultimately help forming a meaningful policy decisions and save our mothers. Well-learned and different strata of doctors are there in the panel. I'll just go ahead. Have you read their biodata? It's not submitted. Have you read their biodata? Yeah. So we have peripherally working obstetricians who represent the grassroots level workers, and we have Dr. Abhinav as a RCSO officer. He has seen the strata from primary care level to the tertiary care level. He is being a general surgeon. He would have witnessed, as when I was interacting with him before this panel discussion, he has a lot of exposure in conducting. He said he has conducted nearly 7 to 8 deliveries in a periphery, being a medical officer. Definitely he has got a lot of experience with him. Also we have Dr. Lata, and both Latas, when working in a periphery. The other madam is head of the department of Basaveshwara Medical College, and also we have Mallikarjun Kirti. He is also peripherally working obstetrician. I don't know, one more madam. Dr. Megha, okay. Dr. Shubha MT, who has got experience of both working in a periphery and also government and private setups. I welcome all of you for this fruitful discussion. Probably we will come out something new so that all the obstetricians can practice the obstetrics without fear. Without fear, they have to help the system, that is the government, to come out of the policies which can definitely help in saving the mothers. When I went through the Lakshya guidelines, absolutely beautiful. They have given each and everything, what needs to be done, what need not have to be done. But that is, I call it as anatomy. Anatomy means how the system has there. Physiology is there. But when pathology happens, how to face pathology, let us come out with SOPs. Okay, next slide. Yeah, I request the panelists, this is a no blame, no shame approach. Let us not blame anybody. Kindly don't take, I request the panelists not to take the name of the patients, hospitals or doctors in our discussion. Even for the participants also, if you want to express your experiences, never take the patients' names. As far as myself is concerned, I am the chairman of the Indian Medical Association Karnataka State Branch, Karnataka Professional Protection Scheme. We are giving around 1 crore, up to 1 crore compensation for the medical consumer court's verdict. We have 38 cases. I am handling 38 cases at present in the consumer level court. 7 to 8 cases were dismissed. Almost all the cases we are on the verge of winning. So, as Harsha said, judges, the system, they want to save the doctors. Probably, ಈ ಮೆಡಿಕಲ್ ಲೀಗಲ್ ಕಾನ್ಫರೆನ್ಸ್ಗಳಾದ ನಂತರ ತುಂಬ ಜನ ಹೆದರ್ಕೊಂಡು ಹೋಗ್ತಾರೆ ಮನೆಗೆ. So much of laws are there to punish us. No, so many laws are there to protect us. As he said, we need to have an eye and knowledge to look into it. Okay, so this is the system-based analysis, not individual point faulting, action-oriented outcomes with a measurable follow-up. So why SOPs? When SOPs are established before the audit, the meeting shifts from stressful interrogation to a structured gap analysis where they went wrong. By having clear SOPs, any fallacy becomes a glorious, it becomes a very clear and obvious. This makes it easier to identify for scope to correction. So this is one of the, probably you can see the name of, see Raravi PhD, it is from my place, Siruguppa, is one of the very ideal medical officer. This represents everything. For an antenna, one page gives everything because see, her hemoglobin level, from where she has come, group, where she has entered, even all those blood samples, how they have detected, in which stage she is, and high risk pregnancies, and they have written, he has written, she is willing for tubectomy also counsel. Everything, she is so structured, as Harsha and all other people were telling, documentation saves you from everything for litigation. So this is one government system, how it is helping all of us to get. So panelists, so as far as this case scenario is just a gate to open the discussion. Don't take it the exact medical perspective per se, the condition, don't take the medical condition. This is the scenario, then it will open the gate for the discussion. This is the postpartum hemorrhage where the golden hour was lapsed. 26-year-old G2P1L1 from rural Taluka delivered at a private nursing home. She experienced severe attempt PPH. The PPO attempted medical management but lacked blood storage unit there. The patient was referred to a medical college. 3 hours there was a delay. She arrived in irreversible shock, that is DIC, and died within 30 minutes of admission. So I request Dr. Shubha Madam. So she has conducted this delivery at a place. She has encountered maternal mortality. With what documents and mentally how she herself prepares to face the audit. You please, ma'am.
Hello. Hello. Good afternoon, everybody. Regarding this case, the first thing that will come to my mind is why did I attempt this case? So the moment everything happens, will be psychologically very low. But as you said, we have to be prepared for the audit, as you discussed yesterday with us. So few points I would like to present here. First is, we have to go back and check what all we have done, like what medical treatment we have given, as we don't have a blood storage unit in our setup. And this is a normal case, not a high risk case. So what medical treatment I have given in that immediately after delivery, like injection methadone, syntocin, oxytocin, to prevent the PPH. All the active management guidelines of prevention of PPH, I should mention and make it a record.
Yeah. Now, how do you go prepared to face the audit? You are talking like an obstetrician, what you have done?
No, I'll mention these things first. What I have done immediately after the PPH, after the delivery, to prevent the PPH. So in spite of all my medical treatment, if PPH was not controlling. So the second thought is, I would like to refer the patient as I don't have a blood.
Yeah.
So immediately I should make a decision to refer the patient. So the timing I have to record when I decided to refer, and when the help was arrived to refer the patient, that is ambulance services.
Yeah.
So the timings between my decision and the ambulance which took the patient, the time interval, and counseling the patients, because the tertiary level is 3 hours long. So before shifting, I should make sure my patient's vitals were normal. It's not like I have referred the patient once, she has become totally deteriorated. Even when she was, vitals were normal, her condition was very oriented and she has not gone into a shock, I have decided to refer the patient. So on the way, with ambulance, with oxygen, with the IV fluids in, I will counsel the patients and refer. And coming back to the hospital records, we have to maintain the labor room records like partogram, and when the patient was admitted, whether it was induced or normal, admission time to delivery time, and then the PPH onset, and these things.
Yeah, thank you, madam. The last 4 points are very important. The first 4 points, you're talking like an obstetrician who tried to manage the case. As attendee of the audit, those last 4 points are very important, which I am going to tell you. And this is the questionnaires which usually comes. What worries you more today in the labor room, the clinical emergency or fear of inquiry? Are you worried about the inquiry?
No, first we have to manage the case first.
Yeah.
And then we have to be prepared for the audit.
Yeah. Has the current medical legal environment pushed obstetricians towards defensive cesareans or early referrals?
Defensive cesareans only, most of the time.
HOD madam, what is your observation on the peripheral doctors? Because you are working in a very, what do you call that? You have anesthetist, you have pediatrician, you have everything. So you can take, what do you call, measured decisions. What is your opinion on the peripheral obstetricians? Are they going for defensive cesarean sections?
Yes, sir. Little bit, because of the litigation problem and problem from the attenders, patient and attenders, and fear of normal delivery complications.
Yeah.
All these have pushed more toward, and because of this has resulted in raising cesarean section.
Yeah.
Right, in present day obstetric practice.
Okay. If this environment comes, the fourth part is, if audits are purely non-penetrative, as Abhinav I said, I had shown you one, because I don't want to make it the same, where they have mentioned to an obstetrician like, baby and mother have died, why can't you held responsible? ನಿಮ್ಮ ಮೇಲೆ ನಾವು ಯಾಕೆ ಕ್ರಮ ಕೈಗೊಳ್ಳಬಾರದು KPME ಕಾಯ್ದೆ ಅಡಿಯಲ್ಲಿ ಅಂತ ಒಂದು ಲೆಟರ್ ಕಟ್ಟಿದ್ದಾರೆ. Is it really causing, I mean, as an administrator, I am asking you, is it truly non-penetrative? Would you openly share what could have been done better? ಈ ಥರ ಕೇಸ್ಗಳಲ್ಲಿ.
So that's what, sir. First of all, maternal death audits are for fault correcting exercise. Yeah. It's not a fault finding exercise. And I want to make this announcement also. It's a very good news in Chitradurga that since 3 months, that is November, December, and January, we have reported 0 maternal deaths.
Thank you.
And that I would say this achievement we could do only because of all the maternal death audits, especially we did since 2.5 years. And then there is a methodical approach for the maternal death audit. As I said, it is a fault correcting exercises. So that's why we should always encourage reporting. So we are encouraging reporting by awarding honorarium to the ASHA workers also. ASHA workers or anybody, it could be. If they report, 150 rupees is the honorarium that NHM, National Health Mission, gives to the reporting person. And after that, for traveling allowance, everything will be there. So that's why ಏಕೆ ನಿಮ್ಮ ಮೇಲೆ ಕ್ರಮ ತೆಗೆದುಕೊಳ್ಳಬಾರದು ಅಂತ even it could have been that could have been like this kindly come for a maternal death audit to discuss more and then get to know more about the details of the maternal death. So it is always we always divide maternal deaths in two sectors or two segments broadly, that is preventable and non-preventable. Preventable, if it is preventable, what are the steps we can take? And then if it is non-preventable, what could be done, or sterilization procedures should have been followed or something. So the idea is mission 0 preventable maternal death. So we are not talking about non-preventable maternal deaths. So some of the even legal proceedings have happened against a lot of hospitals. Some chronic pancreatitis case died. So legal proceedings happened. So we went up to AC and then convinced them, and there was a panel formed, and then we reported it as non-preventable death. So the system is in favor of the doctors. That's why as medical practitioners, as obstetricians, as everybody, we should encourage such things. And if somebody is doing such thing, either it could be bureaucrat, somebody from bureaucracy or DHO, RCHO, or any gynecologist, or any, if somebody is involved in malpractice, the others should make sure to put him out of that place. So that is important. That's why we should always have this attitude towards doing something for the society than normally mechanically doing some work. That's why definitely it affects the rural doctors or other doctors to go defensive, to be very stringent or do very safe practice. but that should not be the idea. And then we should be, as Harsha sir said, it is always we have to have a clear and good thought and intent and work for the society.
Yeah, thank you. As you said, it is not punitative. It is not with the punitative intention that you are conducting a death audit, maternal death audit. Thank you. That is really reassuring for the obstetricians on the administrative perspective. Definitely, this is one more question that probably all of us would have seen. Most of the practitioners, obstetricians, are getting into defensive practice, like fetal medicine they are choosing infertility workup more rather than going for routine obstetrics care. Will it not, if this continues, routine deliveries in the next decade, who has to conduct? Sir, Kirti sir.
There's definitely many of the obstetricians have gone for defensive practice.
Sir, I'm Mike Torres.
Hello. So many obstetricians nowadays have gone for defensive practice. There is no doubt about it. That's one of the reasons for rising cesarean sections. So the pressure is from both the sides. From the investigation team, if something goes wrong, we have to be answerable. And as you just mentioned, how the investigation is going to be with hard words and all those things. There is no support from the government or any other faculties if something goes wrong. It's the individual obstetrician who has to face himself or herself. Then there is a pressure from the patient side also. So if you do cesarean section, they might say we're just doing enough, more cesarean section. But if I try normal delivery, if I do forceps, if the patient ends up with PPH, if the baby has got paralysis, then I have to face the situation. That's how the obstetricians are going for a defensive practice. So there is a lot of needs to be done from the government side also, from educating the patients and encouraging the obstetricians and also the medical colleges to teach the new skills for the coming obstetricians. Because I think next month we are going to have one discussion about instrumental delivery. So people have forgotten instrumental deliveries. The new generation of obstetricians are hardly exposed to these things. So a lot of this has made defensive practice.
So you need to say there is a lot of responsibility on the catering medical colleges in this aspect. Thank you, sir. See, the gist from the discussion is, when the maternal death happens, after discussion, this is the SOPs we wanted to form. Like immediate notification, inform the DHO within 24 hours of the maternal death. Am I right, sir? Okay. Complete documentation is needed of the hour. What are the documents? Antenatal records, referral notes, partogram, treatment timeline, when they have come, what have done, everything in a chronological order, you have to make it. Then consent forms, very, very important. And Foxy and even our IMA is also coming out with, we have Kannada Vaidya Balaga antide. ಅವ್ರ ಜೊತೆಗೆ ನಾವು ಮಾತಾಡ್ಬಿಟ್ಟು ಕನ್ನಡದಲ್ಲಿ ಕನ್ಸೆಂಟ್ ಫಾರ್ಮ್ ಇಂಗ್ಲೀಷಲ್ಲಿ ಇದ್ರೆ ಇಟ್ ಡಸಂಟ್ ಹೋಲ್ಡ್ಸ್ ಗುಡ್. ಓಕೆ, ಕನ್ನಡದಲ್ಲಿ ಯಾವ ರೀತಿ ಕನ್ಸೆಂಟ್ಗಳನ್ನು ತೆಗೆದುಕೊಳ್ಬೇಕು ಅನ್ನೋದ್ರ ಬಗ್ಗೆ ಇನ್ಫಾರ್ಮ್ಡ್ ಕನ್ಸೆಂಟ್ ಇಸ್ ಟೋಟಲಿ ಅ ಡಿಫರೆಂಟ್ ಟಾಕ್ ಅಗೈನ್. ಫಾರ್ ಈಚ್ ಪ್ರೊಸೀಜರ್ ಯು ಆರ್ ಸಪೋಸ್ ಟು ಟೇಕ್ ಎ ಡಿಫರೆಂಟ್ ಕನ್ಸೆಂಟ್. It should contain all the complications, shortcomings, what are the facilities you are giving, what are the facilities that are available, alternate treatment guidelines, separate format for anesthesia complications, all those consent forms you have to get ready. This is what the SOP is. You need to get prepared before going to audit so that you can face it very confidently. So self-review, within 72 hours, you have to, what went well. Definitely, let us look at the positive aspect of the things that went well also. Okay, what could have been done better? Then constraints faced. Like if you have any infrastructure constraints, manpower, as Abhinav said and Madam also said, if you have any manpower shortages, corrected, blood, transport, delays also, you need to just correct yourself. Participate in audit meeting without fear or punitive action. This is what the SOPs from this meeting. Is it okay? Right? Right.
Sir,
yes, sir. Please.
in the government delivery booklet ಮಾಡಿಸಿದ್ದೀರಲ್ಲ, ಅದರಲ್ಲಿ ಎಷ್ಟೊಂದು ಇಂಗ್ಲಿಷ್ ಕಂಟೆಂಟ್ ಇದೆಯಲ್ಲ, why can't you translate to Kannada, please? Including the consent form in the government booklet, so many ಇಲ್ಲ ತುಂಬ ಇಲ್ಲ ನಮ್ಮ ಮೀಟಿಂಗ್
ಸರ್ ನಿಮ್ಮ ಪ್ರಶ್ನೆ ಅರ್ಥ ಆಗಲಿಲ್ಲ. ಯಾವುದು ಕನ್ಸೆಂಟ್ ಫಾರ್ಮ್ಸ್ ಇಂಗ್ಲೀಷಲ್ಲಿದೆ ಅಂತ?
ಗೌರ್ಮೆಂಟ್
ಸರ್
The basic idea is to have a record which explains in detail and which explains to everybody. That's why, for example, translating some Kannada word directly, some English word directly into the Kannada, it may be possible, it may not be possible, and different people sitting there in the committee may have different opinions. So that's why at that time, and then to make it more easy. For example, follow. The word follow, we have to write Anusarana. So most of the gynecologists will not understand. Follow-up date, Anusarana Dinanka. Many may not understand. That's why some of the English words are put like that itself. That's why it is the tie card that we have is a lot of effort is put in there. So it's getting corrected and a lot of things are getting added. Gestosis score is added now, and now we have one more form of birth planning. Birth planning form is there. So that's why there is a constant effort of adding things. For example, I always say, sir, we all work under some programs, and we all come under the program. We all have to understand one thing, that is, we are not because of the programs. RCH, it may be RCH program, it may be child health program, it may be National Tuberculosis Control program, whatever it is. We are not because of the program. Program is there because of us. So program is designed by some experts. Who are those experts? We are the experts.
Yeah.
So that's why we should understand that and then work towards it. Recently, what happened last year? There was in the family planning the guidelines, the timings and all, the schedule of one OC oral contraceptive pill is wrongly printed by government of India. So we noticed it here, and then we put a mail, and after that government of India sent a mail back to us, and then they said that this is a typing mistake or this is some mistake that has happened, and then in the subsequent editions they changed it.
Yeah, definitely.
It's a continuous process. We have to put efforts to correct it.
Yeah, all these efforts are on corrective and improving more. Thank you, sir. And this is one simple SOPs, probable questions regarding PPH. You need to get prepared before going to audit. This is the thing. Anything you can add or delete, whatever it is. This is only for PPH. I am just giving a scenario. You can take a photograph. Then you can prepare SOPs for different cause of death. Probably 3 or 4 causes for very common cause for APH, PPH, amniotic fluid embolism, DIC, ARDS. Basic questions will be there. You can just, this is one example I have given. Queries, you get prepared before going to that. Madam, anything you want to add?
Hello. Suppose we have a case, high risk for PPH, atonic PPH, multigravida or twin pregnancy, or in those cases, is it a must to keep the blood ready and then start the case? And then we can reserve a blood and then do it.
You have to ask Abhi. They have the guidelines.
Sir, like said, I want to go back to the previous talk, like Harsha sir mentioned. I want to make this observation, sir, because whenever there is a teenage pregnancy, what the judgment says is, you don't have to, suspicion is not enough, and then you should have a strong evidence to write that she is below 18 and then complain. So in that case, so all of us can definitely say that I did not think she was 18. I did not think she was under 18, that's why I did not report. So we all can say that this is happening with all the other departments.
Yeah.
So what the POCSO Act says is, whoever finds it first have to go and complain. But all the other departments, it may be Women and Child Department, it may be Panchayat Raj, or anybody, neighbor, nobody will accept that they have seen it and then they know it. But our department is the only department who cannot say no. I mean, doctors are the only professions who cannot say no, because we have given them UPD certificate or high card or whatever. That's why we cannot say no. That's why we are accountable for it. If and then in that case, we cannot say why we should inform is the idea of
no, sir. We are going out of the topic.
Let me.
Her question is
no, sir. I'll come to this. Why I'm taking that is we have to make an effort to inform all the teenage pregnancies. So by that we are trying to bring down the teenage pregnancies. Pregnancies. In that case, we are not. Likewise, we cannot say there is a strict rule to have blood or not at a facility and then start the LSCS or whatever. So that's why our clear intent should be like this: what will I do if I encounter PPH?
Yeah, definitely.
Do I have all the arrangements at the facility? Do I have all the required capacities? And do I have the ability to convert it to GA in case, and then do I have the capacity to go for a uterine artery ligation or the ovarian anastomosis ligation or the internal artery ligation? All those things can be.
Most of the time.
So the question is, do I need to keep the blood ready? Do I need to keep the blood ready always in a case of expected PPH? Suppose in that cases, because the blood, we don't have blood bank in our, it's a taluka place, we don't have blood. Usually in a case of anemia, PIH and those twin pregnancies, I do keep a blood ready and get it ready.
But this is, it is written on the wall. If there are complications you are expecting, you need to be prepared. Not only for the blood, whatever it is.
Otherwise, anytime the PPH, even for any case the PPH can occur, is I am doing a case, then I order keep the blood ready, reserved, and then I do the case. Suppose if there is a PPH, obviously there is some delay in getting the blood. Will the primary consultant be held responsible? I mean,
see, the required thing is you need to have a blood storage unit. If at all, if you want to have.
That's why, sir, we cannot have a
generalized
rule for such things. Yeah. So if I say that no, you need not have a blood storage unit or you need not have this blood at your facility, and then you can go ahead with the surgery, and then you go ahead with the surgery, and then she ends up with PPH, and then we report a maternal death, and there is a provision for us in the law for safeguarding us.
Yeah.
So that becomes very mechanical, or that becomes very technical, leaving all the ethics and all other things behind. So I think the social intent or clear this thing should be there, so that we can plan a.
If it is a high risk case, if you know, better to keep ready to become yourself safe. Because they may ask you, when you know the high risk, why you are not prepared?
That is what.
It is emergency. If it is a elective, you know that you have a time prepare and do the cases. Emergency, you can defend because it is emergency. That's why you are done a cesarean or not a cesarean. If it is a elective, you know that you are anticipating the PPH, you should keep the blood ready and do.
All of us have to. Madam, thank you. Let us move ahead. Because as I said, yes, madam. Yeah. No, as I said, this is not an academic discussion. Yes? So let us have some. Any problem? Okay. So let us move ahead. So this is case scenario 2. How much time do we have? This will go on. 20 minutes. Definitely there will be premature delivery. Yeah, I have to end prematurely. This is a 22 years old pregnant girl with 34 weeks. This is a missed red flag sign. Gestation visited PHC with complaints of headache, blood vision, staff recorded the BP 150. This is a typical case. And after 2 days of later delivery, she had seizures at home, that is eclampsia, died during transport to district hospital. In this case, definitely the DHO or the administrator view this as a preventable death. Mega madam, how do you ensure maternal death this remains system focused, not individual blame? Open blame ಮಾಡಬಾರದು ಅಂತ ಹೇಳಿ. How do you reassure doctors? Like Abhinav can answer this because he is there. Previously, anyone?
Sir, it is mainly the technical committee, expert committee. So the idea of maternal health audit is like this.
Yeah.
So we have facility-based maternal health audit and community-based. Facility-based audit, our reporting should be done within 24 hours. And after that, the form 1, 2, 3, 4, there are 4 forms which are given, which give the details about the facility. And then community audit is like we go to the deceased family, we inquire them that we community-based audit within 3 weeks we will do. And after that, this preventable and non-preventable death is decided by the expert committee.
Okay.
So what we do in Chitradurga is DHO will be the president of that committee at DHO level. So I will be the member secretary, and then we will call everybody, all the private gynecologists, and then the gynecologist, the HOD of experts we call them, and they collectively take the decision and then say whether it is preventable or not preventable.
Yeah, as an administrator, that last question can you answer? What district level gaps repeatedly emerge? That is blood bank, ambulances, ICU beds, and how can audit trigger real changes for the things provided?
Yes, sir. The way I discussed with you earlier, there are 3 delays in maternal death. So delay 1 is the pregnant is not aware, and that health seeking behavior is not
delay in reporting.
No, so health seeking behavior itself is not there. So that becomes completely an administrative issue.
Yeah.
So she has not gone to any NC checkup. She has not visited any health facility. At that time, that health seeking behavior itself is not there in the community. So that becomes an administrative issue. The administrators have to go do IEC, make them reach the health facility.
Social changes.
And delay two is the transit. So some of the death audits that we did, the road to that village or the hatti was so bad that they could not travel. That's why we involved Tahsildars, and then we spoke to DC, and then we spoke to all the EOs there, and then MLAs also, so that we can get a road done to that spot. That is the road delay 2 treatment. And then like that, we have to, maternal death is a state issue, and then everybody have to be accountable. And then whatever delay is there, we have to address it. Then only we can control.
Yeah, absolutely. Thank you. This is what I have prepared. What you expect out of such things is definitely they have to report within 24 hours, adhere to protocol guidelines, and stabilization effort has to be shown, clinical transparency has to be maintained. Right, ma'am? See, I have kept it very simple. The third question is one in the perspective of the peripheral obstetrician, second is a combination of both, third one exclusively the death happening in a medical college. With everybody around, death happens. Definitely there are 3 things: avoidable death, probably avoidable, unavoidable. Right? So unavoidable. 32 years old G3, P2, L2 with healthy supervised pregnancy was admitted in a medical college for elective induction of labor at 39 weeks. Labor was progressing normally under continuous monitoring. Suddenly during the second stage of labor, patient experienced gasping for breath, tonic-clonic seizures, then immediate cardiac arrest. So how the HOD should prepare the SOPs specifically for this maternal death audit, which will help. Definitely this can happen in a medical college. This can happen to anybody, even in the periphery setup also. Definitely it can happen. When and how you can prepare, like what you have done. I'm not talking about you called anesthetist, you called, what all the things, the medications, resuscitation measures, all those things. How do you go prepared for facing the audit? Because you have to prove that it is unavoidable death. Unless the audit comes out that it is unavoidable, we have to prove it. Am I right? See, audit people think that there is a death. We have to prove to them that this is unavoidable death. How do you prepare them? This.
Second stage arrest, cardiac arrest,
There is a problem with mine. So, madam, I am mic there.
In second stage arrest, cardiac arrest, there are definite guidelines are there how to go.
and time frame is very, very important here. Because resuscitation in a pregnant lady is different from non-pregnant lady. Here we have to take care of both mother and the baby. So when there is sudden cardiac arrest, what is the time of arrest that should be documented, and what is the time of cardiac compression started? Everything should be, correct times should be monitored, because according to the guidelines, within 5 minutes the baby has to be taken out. If the arrest has occurred in the first stage of labor, PCMD, that is perimortem cesarean section, has to be done, because here not first resuscitation followed by delivery. Like, it is not like that. Everything should be simultaneous. Resuscitation, delivery and documentation, everything should go on simultaneously. So when the cardiac compression started, when the oxygen was started, when the bag mask ventilation, when she was intubated, whether the obstetric code blue, it was brought into the picture, all that should be documented. And left uterine displacement, that is also is very important to prevent aortic caval compression. So all these things should be documented, and 4 minutes if there is no reversal of spontaneous circulation, so then she has to be operated or delivered. If she is in second stage, instrumental delivery has to be done, or in first stage, cesarean perimortem cesarean section should be done. And here, immediately we should not rush the patient to ICU. That is not the dictum here. If there is cardiac arrest, delivery should be conducted there itself. First stabilize the patient and then shift to the ICU. That means equipment should come to the patient, not patient getting shifted to ICU. That is the guideline, according to the guideline. So we have to, by that time, we would have called for help. Anesthesiologists and emergency medicine people would have come. So treatment will go on, and resuscitation will be favored with the delivery of the fetus. So that should be constantly. There should be given constantly.
Yeah, thank you. The overall observation from Madam's talk is, whatever she has done, you need to have a documentation for them. Everything, timeline, what they have done, whether they have vaginal delivery they have tried with assisted or they have done section, everything should be substantiated with documents, with writings. So this is what I have. Just to go through, I learned to read everything. You can go through acute hypoxia, we have to prove that, we have to write sudden hypotension and coagulopathy also we have to. You can take a photograph. Unresponsive, unpreventable narrative, we have to make it. We have to prove that there is a suddenness. Suddenness is proved by documentation.
Sir, in case if you are asking us to communicate how we should come prepared for
absolutely.
One of the cases which happened at the state level, the Davangere team had come and presented it. It was so beautiful that the whole team had come there. She had some septicing maybe DIC case, which went to ICU and then intensivist took over, and after that she had AKI and then nephrologist took over. This thing happened and at last she died. The Davangere team had come from the ground level till the nephrologist level. Everybody had come to the maternal death audit and then they started presenting. The medical officer started presenting the case, and then what was the registration, at what time was the registration, and what was the initial findings, what was the initial HB, BP, and then how was the care, how many ANC checkups happened, and all those things he presented. And after that, till birth planning he presented, and after that she was taken to a Taluk hospital where they could not do the delivery because of preeclampsia. That Taluk hospital gynecologist was there. He presented his story and then with all the documents. And after that, district hospital doctor, gynecologist presented, and after that this happened, anesthetist took over, and then everybody presented their part. So Taluk hospital gynecologist, after that, sir, till here I saw, and after that, a gynecologist ma'am of district hospital was there, and then she took over and then she started presenting. And then she said, after this, anesthetist went to ICU, and then me and anesthetist saw. And then after that, intensivist also was present in the audit. He presented, and after last, the nephrologist took over the case, and then he made 2 or 3 cycles of dialysis, and they could not save her. So after all these presentations, the number of questions which came from the technical committee of state was almost 2-3, because they had narrated all the story in detail. So that's why, in case if you come prepared, 2 advantages are there, sir. One is you come prepared for the maternal death audit, and the second is you are when you are from the same locality, that medical officer will have a good rapport with this gynecologist, and then that gynecologist will have a good rapport, so that anything goes wrong in the next case, the communication, the channel will be established so well that we can definitely save the next.
Absolutely, you said it's a teamwork.
Whenever I request, what I observed in district level audits are, there is no pre-audit discussion between the medical officers and the gynecologist, so that should happen. So rather than blaming that field did this and then we did this, there has to be coordinated effort, so that coordinated effort and the specialists or super specialists who are involved in managing, like intensivists and the nephrologists, all those, if they also come, that is a good thing. I should thank Dr. Murali, nephrologist from Basaveshwara Medical College. One death happened. He had made a presentation regarding that, and then he communicated with me, and then he presented at the state level. So those are some of the good habits that we did. So because of all those efforts, we are able to bring down maternal death in Chitradurga.
Yeah, definitely.
I hope we continue that, sir.
In one of the primary health center, which the ANC card which have projected for the last 20 years, 0 maternal deaths, and that primary health center is till today has conducted maximum number of HIV deliveries. So it is around 10 kilometers from our place. So beautifully they are doing it because of these protocols. So what you suggest, what our suggestion was, we suggest the associations, Fox or medical colleges catering here, why can't we do dummy audit reporting? I mean, you can have a panel of representatives who can make the doctors to present a case presentation, what we have done it, so that while during presentations, you will come to know fallacies, as Lata Madam was speaking, like how to operate, or we have to make blood ready for every case. So such questions will come, then we will have the answers, then we can correct the system without even being putting the mother at risk. So it is the responsibility of the medical colleges to conduct dummy audit. Am I right? Okay, na? Yeah, they need to sensitize the obstetricians to come to the stage, exactly like we have started recently in Gadag.
A lot of near-miss audits are also there, sir. Near-miss audits are the case which are potential maternal deaths.
Yeah, definitely.
We do all those very actively.
ಇದನ್ನು ನಾನು ಮಾಡಿ ಅಂತ ತಮಗೂ ಸರ್ಕಾರಕ್ಕೂ ಸಜೆಸ್ಟ್ ಮಾಡ್ತಾ ಇದ್ದೀವಿ ಸರ್. ಹಾಗೆ ಮೆಡಿಕಲ್ ಕಾಲೇಜ್, ಬಿಕಾಸ್ ತುಂಬ ಜನ ಪ್ರೈವೇಟ್ ಪ್ರಾಕ್ಟೀಸಲ್ಲಿ ಮಾಡ್ತಾ ಆಬ್ಸ್ಟಿಟಿಷಿಯನ್ಸ್ ದೇ ಆರ್ ಗೌರ್ಮೆಂಟಲ್ಲಿ ಮಾಡ್ತಕ್ಕಂಥ ಆಬ್ಸ್ಟಿಟಿಷಿಯನ್ಸ್ಗೂ ಪ್ಯೂರ್ಲಿ ಪ್ರೈವೇಟ್ ಮಾಡಿರ್ತಕ್ಕಂಥ ಆಬ್ಸ್ಟಿಟಿಷಿಯನ್ಸು ಸಾಕಷ್ಟು ತೊಂದರೆ ಇದೆ. ನಿಮ್ಗೇನಾದ್ರೆ ಪನಿಷ್ಮೆಂಟ್ ಬೇರೆ ಕಡೆ ಟ್ರಾನ್ಸ್ಫರ್ ಮಾಡ್ತಾರೆ, ಬಟ್ ಪ್ರೈವೇಟ್ ಪ್ರಾಕ್ಟೀಷನರ್ಸ್ ಆಗಲ್ಲ. ದೇ ಹ್ಯಾವ್ ಟು ಲೀವ್ ದೇರ್, ದೇ ಹ್ಯಾವ್ ಟು ಫೇಸ್ ದ ರಾತ್ ಆಫ್ ದಿ ಪಬ್ಲಿಕ್ ಆಲ್ಸೋ, and also very badly they have to face the consumer court. Consumer court, we are protected, but private practitioners are not. They have to be there, their life depends on the practice, they have to be with the society, they have to be with the system, like government system. ಇವೆಲ್ಲವೂ ಆಕ್ಟ್ ಆಗುತ್ತೆ. ಸೊ ಅದಕ್ಕೆ probably this is the best thing that you conduct whether government or even the association along with the academics. Why can't you have a dummy audit report? In the sense, you enact, as I said in Gadag, we have moot courts. Harsha, is there? Yeah, Dr. Yoga Rao, he creates a court scenario where one of us will be there on the board. He will present, he will narrate a case, how the proceedings, examination, cross-examination, all pre-enacted. Why can't we have such moot, what do you call that, death audit in the coming days? We can make it so that we can correct the mistakes before it happens. Okay. Yeah, this is one question which was maybe out of this thing, we will come to within 5 minutes, we will be finishing it. So, Lata Madam was asking, the practitioner in every obstetrician comes out, faces such problems while doing in their practice. SOP specifically for infant, that is neonatal death occurring on second or third post-operative day after delivery, or LSCS, aligned with Indian medical legal realities and audit expectations. Probably sir is in a right position to answer. Kindly hand over. Sir, mail banduri. Our mic and Sarila. You can come. Yeah, please. And you can come here. How they should face, what documents they need to have it. See, for 35 cases, almost all the cases we are winning. Nimma IMA.
Thank you, everyone.
ಬೇಗ 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 ಬೇಗ